participation and well-being. This this theme captures the essence of occupational first play to purposeful aging. Participation here is not actively alone, but meaning
training for specific delays in their development. From 4 year onwards, they are included in the daycare program, full day program, which is like from 8 a.m. to 1:30 p.m., where all the areas of or routines, we focus on their development. Like it includes everything from academics to OT, PT, behavior, speech, music, craft, sports, everything. In the center, we have individuals who have autism spectrum disorder, cerebral palsy, intellectual disability, attention deficit, hyperactivity disorder, learning disabilities, plus various syndromes. Some of our students have really complex needs. We have 4 units where each unit having 10 students, where the students having multiple challenges and medical challenges are placed. So their program is a little different from the rest of the center's program. As occupational therapists, our role is to improve activities for daily living, enhance fine and gross motor skills, improve sensory processing, support communication and social participation, and promote independence and quality of life. And in all these areas, we work on these areas to ensure that technology, as it is seen across all routines, is effectively used for these students. So briefly, assistive technology is basically any device or system that helps to improve functional abilities. And this can be broadly divided into low-tech, mid-tech, high-tech. So that's just an example on the side. Low-tech are the ones where we use cards, picture cards, or maybe some symbols. Mid-tech would be the switch. This is a broad sample that I'm giving. And high-tech is an AAC communication device. We'll go into the details of these as and how we go in each section of or each area of work that we do. Okay, so we have a transdisciplinary approach where we don't work in isolation. We always have a team approach towards intervention of a student, or we call them students because they're not in a hospital. So the team approach is where, depending upon their needs, an OT and a PT may work together, or an OT and an SLT may work together, or an OT and a special educator may work together, and vice versa. They also, the physiotherapists also work with others. We work with the vision rehab specialist also, and we work with the co-curricular team as well. So our role when we are looking at the transdisciplinary approach mainly is assessment, where we assess their individual needs, and then we select the technology. We provide intervention to ensure that the technology is appropriately used, and then we monitor the effectiveness. This is a cycle because when we monitor effectiveness, we also do assessments, ongoing assessments. So OT in a physical setup, of course, we are, as everybody, all of you are aware, focused on improving posture and mobility and balance and whole body coordination. But the focus is also on enhancing participation in all routines, and we'll come to that later. So when, say for example, if you see the wheelchair, it's not just a wheelchair in terms of mobility and posture that we look at. We also look at what else the student or the individual may need when they are using that wheelchair, because if they are non-verbal, they cannot go anywhere without their communication system. So the wheelchair should be appropriately able to support a communication system or an eye gaze system, or if they are using low tech, then it should have a proper tabletop. So we are looking at a core function in the wheelchair plus all these additional things that other professionals may require. On the top, what you see is a robotic equipment. It's called InnoWalk. It is used for providing weight bearing and also gait mobility. Uh, the the specific reason or the specificity of this equipment is that it is ensuring that the posture is completely maintained right from head neck down to the ankle while this activity is being done. So this young boy that you see here is actually not even able to sit without support, but he is independently using the, and it is mechanical, so he is getting the feedback of how a step would be taken and how mobility can happen. We focus also on improved learning and independence. So going back to enhancing participation in all routines, this is just a sample of what we do, and since we are talking of physical challenges, on the on the right hand side is a boy who wanted to play in the sports session with all his friends, but he wasn't able to really roll the ball to participate in the games. So this is a customized innovation or a technology that we have devised where there is a roller stand, and this stand is actually activated by a switch. So it is connected to a switch where once he presses the switch, the ball will roll through the on the roller, and then it will hit the pellets there. On the top, we have a team of 9 students. All of them are our wheelchair users who are playing a music. They are part of a musical band which we call Heartbeats. Every one of them is having an equipment, a musical instrument which is adapted to their specific needs. So on the extreme left hand side, if you see, there's a girl who's using eye gaze. In the middle, the one who's wearing an Arabic dress is a individual who's using beams. That's so every equipment is adapted, and every equipment is adapted to the needs of these individuals. At the bottom is a student who's using a switch to activate an art spinner. The art spinner, so first he chooses, he discriminates between colors. So he chooses between the colors that he wants up to an array of 3. And then these colors are dropped by the art teacher on the spinner, and he activates the spinner. The speed is controlled by him to decide on the artwork that he wants to generate. His artwork has been actually picked up by a couple of corporates to have it on their company t-shirts and company mugs. So he's really good at it. So transdisciplinary approach, OT part, along with this SLT, speech therapist, we look at this the figure on the side where we go from really low-tech pictures and cards to switches to simple speech generating devices like GoTalk, going ahead right to eye gaze and mobile phone usage and AACs. Our role here is to ensure that the sensory processing is in place, or to give accommodations if the sensory processing requires them to have some accommodations. We also focus on fine motor skills, reach, whether they can reach the device, whether they can reach the switch, the finger isolation that they might be requiring for pointing or even for picking up things, then hand swiping, which may be required for an AAC device that has multiple pages. So that's our focus in fine motor. As in visual perception, before the device is given, we look at discrimination abilities, figure ground perception, and sequential memory. So the first 2 are the ones which will decide the device. Say for example, in the speech generating devices, the grids can be decided. We can start from just 1 or 2 grids depending upon their ability, and then gradually progress as they get a hang of it and learn more skills. We also look at cognitive abilities like attention, processing information, recognition, identification of icons, identification of figures, and memory, of course. Memory, which is required in AAC. The main page will have icons which will tell them which page to go to for their communication, so they need to have that memory. So eye gaze. This was the girl who was there in the music band, the one who was using eye gaze. So this is how we started her training. We started her training with very basic discrimination on paper, where she was. So it was first actually placed on left and right side, and then I don't have a picture of that. But then it came in front of her, and she could look between the two and decide which one. And then the same icons were used on the eye gaze, and this is the basics of the training that we started as occupational therapists. So once she got an idea of how to use the eye gaze and was able to dwell enough for making those changes on the eye gaze, she was then, like when I said transdisciplinary, the other team got involved. Like the special educator included some academics on it, the speech therapist included communication on it, the music teacher included music in it. So she is a very proficient eye gaze user now, but her therapy with us as OT started 4 years back at this basic level. In visual challenges, when we work with the vision rehab therapists, so they are the ones who identify what needs to be done, especially when there is cortical visual impairment, where there is partial visual impairment also. So that is when they look at the readers, the magnifiers, and our job is to ensure that we do an assessment where we tell them how this needs to be placed, what should be the magnification level, whether a contrast is needed based on their visual sensory needs. So these are the areas where we collaborate with them. Uh, there are individuals in our center who are totally blind as well, and the communication is done through tactile symbol or tactile objects. So now this is a speech therapist. So here we are working with two different disciplines. The speech therapist will say we want to start with tactile symbols, and then we are the ones who will start working on tactile discrimination first. Only and only when we start getting some discrimination abilities, we'll tell them. They are the ones who will select the symbols. We are the ones who will tell them that, okay, you can go to 2 symbols now, and then progress to more as and how the ability increases. We work with the ICT team for robotics and coding. This is part of their mandatory curriculum, so they get sessions once a week for robotics and coding. And apart from the fine motor skills which are required to build a robo and the cognitive skills which are required to build a robo, the focus is also specifically on, while coding, especially on spatial relations and directionality, because that's what they need to know if they have to decide how that robo is going to move mechanically. So the code is set. So we start off with very basic games, as you see here, where we teach them the up, down, right, left, and how many times you have to go right and things like that. And once they have the basic skills, then the basic robotics and basic coding is started by the ICT team. In academics, when we work with the special educators are working on academics and literacy. So our role is to support them by developing foundational skills, where sensory processing may be a major area, to develop their attention span, to have motor skills, especially for handwriting and executive functions. Of course, we had a long discussion yesterday on executive functions. I'm not going to go into details, but we also decide if handwriting is in the way of progress academically or in literacy. We are the ones who will decide whether they need to go on a digital platform, use a computer, whether they can use a mouse, whether they need a tracker, whether they can use a keypad. So that assessment is done by us, and decision is done by us. Then we collaborate with them, and the ICT team takes the training forward. So again, we've had a long discussion on this, benefits of technology in OT. I'm not going to go into details, but it definitely increases motivation and engagement. We've seen that qualitatively. It provides individualized intervention because each technology is very specific to each person's needs. It enhances skill generation and allows progress tracking and data collection. That's for us. So the biometric, the tracking is very easy when we are using technology along with it. But we do have challenges and limitations. One of the major challenges is cost and accessibility. In the part of the world where I work, the parents are paying from their pockets. They are not covered by insurance. Very rarely do they get insurance cover for this. So we have to keep that in mind when we talk about technology. Like say, for example, eye gaze is a very, very expensive equipment. Need for therapist training because using eye gaze requires specific skills. So the therapists need to get trained on that. Risk of over-reliance on technology. Now, this is very common. And say, again, we are going back to visual aids. So when we are using an eye gaze, we have to keep in mind that there will be visual fatigue. And this is something that we have to insist in our transdisciplinary meetings, because everyone looks at their component and says, the teacher will say, I'll work for half an hour, and the ICT teacher will say, I'll work for half an hour, and the music teacher will say, I'll work for half an hour. In this, we have to consider the fatigue factor that the individual may go through, and that we are very mindful of that. So in our report, we do write about the duration through the day that they can use eye gaze for, and then may have to shift between low tech and high tech for some time. And it's not suitable for all clients. Not everybody is not everybody is able to manage this, and maybe not every parent is able to afford this. So basically, to conclude, technology is a very valuable tool for us in OT intervention. It enhances functional ability with children with developmental disabilities, and it should be used thoughtfully along with traditional therapy approaches. Very, very important. And this has been, since we've increased the use of technology, this has been a part of our reports now, that we insist on balancing, and we give a recommendation as to for how many hours it can be used, and what should be balanced, and what should be the breaks and everything. It's part of our recommendation in our reports. So thank you for listening to me.
Thank you, madam. Is there any questions, any query, any doubts you can ask right now? Thank you, madam, for a wonderful talk. Thank you.
Hello, madam. I have one just clarification. Like, do you have your country have some list of all these assistive technology products? Because recently in India, last 2 years back, ICMR has launched a national list of assistive products. That is NLEAP. So that provides almost a good long list of these products. However, that list is not being prepared by occupational therapists or the group of OTists. It was prepared by multiple professionals, and their prescriptions are given by various professions. And there's no challenge we are facing is that there is no means a good list of a long list of suppliers where we can get it from. So how do you approach to those? Another question is, how is there a list, and how do you approach to?
No, we don't have a list of suppliers, but what we do is we have suppliers in Dubai especially, who will source things for us if we tell them where it is available. So they do get from Europe and US, and we also got from India. We've got the Avaz app from here. But it is something that is a struggle for us as well. So very often, and when it comes from abroad, it becomes very expensive also for the parents. So we have to sometimes do in-house modifications and work, like the sports equipment that I showed was done in-house. We also have a 3D printer with us, so which helps us to make some in-house adaptations. So apart from the OT assessments that we do, we also have an assistive technology checklist format, which is a standardized one, I think, which is used everywhere. So the assistive technology checklist format has components which will be, so there are sections which are filled by the speech therapist, occupational therapist, physiotherapist, and one more is by the visual rehab therapist. There are 4 sections. So once they fill, all of them put in their criteria, which gives a baseline data to us. Once the baseline data is, say for example, if a physiotherapist is talking about position and they say, so there's a curvature of the spine, so that helps us to decide the placement of the equipment, say for example. So this information that comes from the access assessment is, it has its own, so it's standardized, it has its own component and recommendations coming out of the standardized format. So that helps us at a very baseline level, and then we modify for customization for each individual as required. Thank you. Thank you.
Thank you, ma'am, for such an inspiring session. I would like to request our chairpersons, Dr. Kamal Arya sir and Dr. Vijay Bhadra sir, to felicitate Dr. Shruti Nadkarni, ma'am. Yes. Please give a warm round of applause. At this juncture, may I respectfully hand over the microphone to our honorable chairpersons to lead the sessions further.
Good morning, everyone. Today we are going to start with our first scientific session on nurturing the ability across lifespan. The evidence-driven insight in occupational therapy participation and well-being. So, on behalf of my co-chairperson, Dr. Kamal Naran Arya, and myself, Dr. Vijay Batra, welcome you all. In this session, we have both competitive and non-competitive papers, and few rules we would like to follow. There should not be any cross-questioning. Maximum of 2 questions are allowed for the session, and no follow-up questions is allowed for the session. So, I would like to invite the first speaker of today's competitive category, Dr. Banna Senapati. She will be speaking on Odia version of breastfeeding self-efficacy scale, reliability, validity, and cultural adaptation with occupational therapy insight.
Good morning, everybody. The topic of my research is ODI version of breastfeeding self-efficacy scale short form, reliability, validity, and cultural adaptation with occupational therapy insights. Coming to introduction part, breastfeeding is internationally recognized as the optimal method of infant feeding. The WHO recommends exclusive breastfeeding for the first 6 months of life, followed by continued breastfeeding for up to 2 years or beyond. Despite this recommendation, global and regional variation persists due to socio-cultural norms, maternal beliefs, and availability of professional and familiar support. Maternal confidence plays a very critical role in both initiation and continuation of breastfeeding, which leads to longer duration of breastfeeding, improve maternal-infant bonding, and exclusive breastfeeding. Research across countries such as Canada, China, Spain, Iran, Germany, and India has shown this scale maintains high internal consistency, reliability, and construct validity. However, successful use of such tools in diverse population requires cultural and linguistic adaptation to ensure conceptual equivalence and cultural relevance. Odisha, where the Odia is the primary language and diverse population surrounding childbirth, postpartum care, and feeding rituals and making patterns. These cultural elements can directly affect maternal problem with breastfeeding. So what was the need for the study? Audio version of breastfeeding self-efficacy scale short form with occupation therapy perspective was very much required because breastfeeding comes under ideal, and if the scale is in ODIA version, that will be benefit for the ODIA mothers, and they can understand and they will have the better expression in ODIA language. And cultural relevance of breastfeeding practice, and it is like life-center care. And if this ODIA version of breastfeeding self-efficacy scale will be given to the mother, ODIA mother, mothers who don't know the language of English and Hindi, then proper inclusion and equity is possible. And effective international planning can also be done by occupation therapists. So the aim and objective of this study was to translate and culturally adopt and psychometrically validate the ODIA version of the breastfeeding self-efficacy scale short form for ODIA-speaking postpartum mothers using an occupation therapy framework. The objectives are to translate and validate the ODIA version of this scale, incorporating occupation therapy insight for cultural and contextual relevance. And the second objective was to find out the association between the level of breastfeeding self-efficacy and socio-demographic variables.
Methodology, the study design was cross-sectional and the setting was district hospital, community health center, private and private maternity clinics in Odisha. Total 200 postpartum mothers were selected and the sampling was used like convenient sampling. Inclusion criteria, mother of an infant irrespective of gender, age below 1 year, able to communicate in ODA language, mothers who initiated breastfeeding to their infants for at least 10 days since birth. Exclusion criteria were mothers who have to discontinue feeding their infants on any medical recommendation or mothers who are previously diagnosed with depression. The instrumentation was used like socio-demographic information for the mother and baby, a pre-prepared questionnaires based on previous researches on breastfeeding to assess basic socio-demographic variables of the mother and baby, and the English version of breastfeeding self-efficacy short form was used. All items are preceded by the phrase like I can always and rated on a 5-point Likert scale ranging from 1 not at all confident to 5 confident, completely confident. And in the middle section you can see the original version of breastfeeding self-efficacy short form and the steps involved for the English BSS short form to the ODIA through a structured linguistic validation process, and it was done through these 4 procedures like forward translation of the original scale to ODIA by a native ODIA speaker, then back translation was done into English by a second bilingual translator who are no access to the original version. Reconciliation was done by comparison of the back translated version with the original English scale, followed by revisions until conceptual and semantic balance was reached. Pre-testing was done with the preliminary ODI vision with 20 mothers to ensure clarity and ease of understanding. The procedure was mothers who met inclusion criteria were selected, written infant consent was obtained, structured interview by trained nursing students or nurses, mother will explain on the scale administered ODIA. The ODIA version of the scale was used. Same order and wording followed for interview. No extra probing or expression for bias control. Data was checked for completeness. Unique code was assigned to each participant for confidentiality and secure storage of data analysis. Data analysis was used by descriptive statistics. Continuous variables were summarized as mean and standard deviation. Category variance as frequency and percentage. Constant validity was assessed through explorative factor analysis with principal component of analysis and variance rotation. Factors were written based on eigenvalues greater than 1 and script plot inspection. Internal consistency was evaluated by using Cronbach alpha. Research and discussion, maternal demographic characteristics. Total a cross-sectional study was conducted with total of number of 200 participants. As you can see, most mothers were in the 30 to 37 years age group. More than half had completed college education, and most lived in joint family, and 52% mothers were multigravida. Table 1 shows the internal consistency and reliability. The ODIA translated scale showed excellent internal consistency as measured by Cronbach alpha, which is 0.947. The arrow mark, which the black and yellow arrow shows that. Similar results also have been found in the various studies validating the same features. And coming to validity, as you can see, the table 2 shows that ODIA version of this scale has 2 components. One, this differs from some earlier studies which reported only a single factor structure. This study has 2 components, like one is confidence in breastfeeding, that you can see high loadings for items such as 1, 2, 3, 6, 7, 9. Another is component 2, that is breastfeeding management skills, high loadings for items such as 4, 5, 11, and 14. These items reflect practical skills, technical knowledge, and task-oriented behaviors related to breastfeeding management. PCA revealed 2 components that had eigenvalues lesser than 1, which express this percentage of the total variance respectively. You can see the script plot.
Last 2 minutes.
Continuation, and table 3 shows mothers who were multigravida in joint family on better education. They showed high breastfeeding self-efficacy score, and this study concluded that previous breastfeeding experience and social support levels have significant impact on maternal self-efficacy for breastfeeding. And coming to integration occupational therapy in cultural adaptation to ODI version of BS scale, occupational therapists help ensure that the translated items were kept relevant to the daily experience of ODI speaking mothers within their cultural and social context. Examine whether each item represents common breastfeeding routines, physical demands such as positioning, comfort, and the emotional aspect of early motherhood that influence confidence and performance. Consideration of cultural factors such as joint family support, postpartum rituals, and community expression, which are known to the influence maternal breastfeeding confidence. Conclusion, the ODI version of this scale showed strong reliability and validity. It can be useful for assessing breastfeeding self-efficacy, and this scale reflected both the cultural context and the practical aspects of breastfeeding. This scale has some limitation, that possible bias from self-reported confidence levels, exclusion of mothers with low literacy, cross-sectional design limits assessment over time, psychological factors are not evaluated, test reliability, and predictive validity was also not assessed. Recommendation, this ODI version of scale can be applied in routine clinical practice at Odisha to identify mothers who need focused breastfeeding support. Future research should involve a wider range of participants and access the contribution of psychological aspects to the breastfeeding self-efficacy. These are my reference, and thank you all of you.
Thank you, madam. You are well in time. Judges, kindly note, this was a competitive paper.
Yes.
So, question answers we will be having at the end of the session.
Okay, sir. Thank you so much.
Now, I would like to request my co-chairperson to proceed further.
All the papers in these sessions are competitive only. So we may call the next speaker Dr. Rajalakshmi Lanka, who is going to present her paper on the effect of task-oriented circuit class training in attention, memory, and stroke survivors. The speakers may note the timer is coming in front of their dais, so they can look at the timings.
You can just change it like that. Okay, wait.
So there should be something. Speaker notes here and there.
Notes you want.
Speaker notes here and there. I don't know why it's not able to do that. Notes.
Go to the next slide otherwise. Let's see that. Yeah.
There should be. Notes. I'm not going to do that. Okay, fine.
Yeah, okay. Would you want to use the project with this pointer? Pointer? You can use it. Use this also.
How can I use that?
You can use it like this also. Okay.
Good morning, everyone. I am Rajalakshmi Lanka, and I am going to present my study on the effect of task-oriented circuit training on attention and memory in stroke survivors. Stroke is a leading cause of long-term disability worldwide and remains a major health burden in India. While motor impairments are commonly addressed in rehabilitation, cognitive deficits, especially attention and memory, often remains under-recognized despite their strong impact on functional independence. Task-oriented circuit training integrates functional, goal-directed activities that simultaneously engage motor and cognitive processes. Such an approach may enhance neuroplasticity and improve attention and memory. While this keeping the background, we can come forward to the rationale. The neuroplasticity is essential for cognitive recovery after stroke, as it supports learning, reorganization, and restoration of neural pathways. The stroke-related injury reduces neuroplasticity potential, partly due to decreased levels of brain-derived neurotrophic factor, which is critical for synaptic strengthening, memory processing, and neuronal survival. The physical activity has been shown to enhance neuroplasticity by increasing cerebral blood flow and stimulating the BDNF release, promoting improved neural activation. Moderate to high intensity activities particularly associated with improvements in attention and memory, suggesting a dose-response relationship between exercise intensity and cognitive function. Task-oriented training emphasizes purposeful, goal-directed activities that mirror real-life movements and functional demands. Circuit training enhances task-oriented practice by combining multiple functional tasks in a structured, repetitive sequence, especially at moderate intensity. These tasks activate both motor and cognitive systems requiring sustained attention, planning, decision-making, and problem-solving. Research has demonstrated that task-oriented intervention can improve visual perception and functional performance, particularly in individuals recovering from neurological disorders. The aim of the study was to explore the effect of task-oriented circuit training on attention, enhancing attention and memory among stroke survivors. The objective was to evaluate the effectiveness of task-oriented circuit training in improving attention and memory. The hypothesis was that there is a positive impact of task-oriented circuit training in attention and memory. The null hypothesis was that there would be no impact on the cognitive domains. This was a quasi-experimental pre-test post-test design conducted on 30 individuals, and the participants were screened using Montreal Cognitive Assessment, MOCA, and the variables, that is attention and memory, it was measured using Edinburgh Cognitive Examination version 3. The subjects included in the study aged from 18 to 70 years, both male and female, who sustained a stroke with a mild cognitive impairment. Both male and female subjects were included. The subjects who were able to follow instructions and were able to ambulate without physical assistance were also included. The subjects who were excluded from the study had a severe cognitive impairment, aphasia, musculoskeletal conditions which restricted participation, and unstable medical condition, particularly exceeding heart rate and blood pressure. First, the participants were screened based on the exclusion and inclusion criteria. Then 30 participants meeting the criteria were recruited and randomly put into experimental and control groups. The experimental group received task-oriented circuit training while the control group received conventional therapy. The duration of the session was 45 minutes per day for 5 days per week for 4 weeks. Each session began with a 15-minute treadmill walking activity which was carried out separately from the circuit. This was done to bring the participants to a moderate intensity zone that was calculated using the Carbonian formula for target heart rate. Then after the treadmill, the participants completed a 30-minute circuit consisting of 5 stations. These included lower extremity tasks, balance activities, upper extremity tasks, cognitive tasks, and dual motor cognitive tasks. This shows the whole circuit. There are 5 stations, and each stations have their own multiple tasks, and each task had to be completed within 1 minute, and then the participant moves on to the other task. And the circuit continues if the time allows. The quantitative data were analyzed using appropriate non-parametrical statistical test. The Wilcoxon sign rank test assessed pre and post changes within each group, and the man-Whitney test compared post-intervention outcomes between the groups. The statistical significance was considered at p below 0.05. The results in within the group comparison shows that the experimental group showed a significant improvement in both attention and memory scores following the intervention. Meanwhile, the control group also demonstrated improvement. However, the magnitude was smaller. In between group comparison, the post-test scores revealed a significantly higher improvement in the experimental group compared to the control group. Both groups showed improvement, but the task-oriented circuit training led to significantly superior outcomes. My findings indicate that the task-oriented circuit training led to a greater improvement in attention and memory compared to conventional therapy. The integration of motor and cognitive demands may have enhanced neuroplasticity through increased cerebral activation and engagement. The moderate intensity activity likely to have contributed to improve cognitive outcomes by supporting the cerebral blood flow and neurotrophic mechanisms such as BDNF release. The heart rate variability reflects the body's adaptive capacity, and the higher heart rate variability has been linked to improve attention, memory, and executive functioning. Task-oriented circuit training engages motor and cognitive systems simultaneously, increasing attention, memory, and problem solving during the movement. The performing functional task while thinking, such as stepping, balancing, counting, naming, creates a dual task environment that strengthens neural connections and supports neuroplasticity. In comparison, the control program involved simpler, less demanding exercise, likely delivered at a lower intensity with a fewer cognitive components, which may explain the smaller gains observed. The findings from different lines of research demonstrate that aerobic exercise, functional task practice, and dual task challenges all support cognitive recovery, and task-oriented circuit training integrates all these elements into one structured intervention. In conclusion, the group that received task-oriented circuit training demonstrated greater gains in attention and memory compared to the control group. This study suggests that task-oriented circuit training may have a useful approach in stroke rehabilitation to support attention and memory recovery. Keeping the conclusions in mind, there are still limitations to the study because of the smaller sample size and the shorter intervention durations. Also, there was no biomarker or the neuroimaging measures to confirm that it was the BDNF levels which contributed to the improvement. So, my future recommendations would be to use a larger sample size and include a longer follow-up period, and include biomarker studies such as BDNF measurement to help confirm the underlying neurophysiological mechanisms. Also, to compare task-oriented circuit training with other approaches to confirm the effectiveness. Thank you. These are my references.
Thank you, ma'am. You are well in time. Now, I would like to invite our next speaker for today's session, Dr. Sujata Misal. She will be speaking on factor analysis of school readiness implementary for preschooler with autism spectrum disorder. Over to you, Dr. Sujata Misal.
Can my child go to a normal school?
I'll stop. Can you reset the timer, please? Judges, this is under competitive category. You can start, ma'am. Thank you.
Can my child go to a normal school? Can he be admitted into a mainstream school has always been a question that was asked to be by many of the parents with children with autism spectrum disorder that I have come across in my past 15 years of experience taking care of children with autism. So this has been a very common question, and that is what led to develop a tool which is called as School Readiness Inventory for Preschoolers with Autism Spectrum Disorder. Good morning to all of you. I am Sujata Misal and I am from Coimbatore. I am presenting on the topic Factor Analysis of School Readiness Inventory for Preschoolers with Autism Spectrum Disorder. Respected judges and respected chairpersons, good morning. So this is a very overview of the part that I'm going to take. School readiness is an important goal of early childhood education, and assessment of school readiness skills is an important aspect among preschoolers with autism spectrum disorder for inclusive education. However, there is a lack of well-designed tools that are specifically developed for this purpose. According to School Readiness Conception Framework of UNICEF, school readiness is defined on 3 dimensions: children's readiness for school, school's readiness for children, and family and community's readiness for school. According to me, I have only taken the first part to develop the tool, that is children's readiness for school. Though globally there are many tools specifically designed to evaluate the school readiness of preschoolers with ASD, but school readiness skills catering to the Indian context and culture are sparsely available, and especially for children with ASD. So the tool that we developed was in the year 2018 and 2019. It consists of 4 domains: cognition, language development, social emotional, physical health and motor development, and 9 subdomains, and total of 98 items. Scoring was based on a 6-point Likert scale ranging from 0 when the skill is not at all present, and 5, when the skill or behavior is present in all settings and the child can generalize the skill. The item content validity of the instruments range from 0.75 to 1. There was a good agreement in all of the 98 items except 14 items which were having a score below 0.78 item content validity, which was again modified based on the changes recommended by the experts in the field of pediatrics. Process in the tool was, it consists of 5 phases, and I'm going to talk today only about the 4th phase, that is basically the exploratory and confirmatory factor analysis that I have done for the scale. I'll be talking about that. So, aims and objectives was the study aimed to perform factor analysis of SHIPA scale to establish psychometric properties, to find the factor structure and group items into subscales, to confirm the factor model, to test the convergent magnitude. These were the objectives. It is a psychometric property testing design. Children with autism spectrum disorder with a sample size of 80 were taken. Purposive sampling was done. The children were taken from different centers of occupational therapy in the Coimbatore city. Duration of the data collection was done between 2021 and 2023. In this phase, the school readiness inventory for preschoolers with ASD was administered to the pilot population of 80 children based on the selection criteria, that is children medically diagnosed with autism spectrum disorder and 3 to 5 years, 11 months of age, both boys and girls, children who had autism spectrum disorder but with visual impairment or auditory impairment were excluded, or with any kind of associated comorbidities and genetic disorders were excluded. So research protocol was reviewed and approved by the Departmental Review Board of Maharaj Vinayak Global University, Jaipur. This study was conducted in accordance with Declaration of Helsinki as well as ICMR guidelines. A written consent was obtained from the heads of the centers as well as from parents of children with ASD, and the SHIPA scale was administered. The data that collected was then subjected to statistical analysis using SPSS version 25, and for factor analysis, STATA version 14 was used. Table 1 shows the descriptive statistics of children. The children's age range from 4.56 plus 1.03, and there were maximum number of boys rather than girls. The exploratory factor analysis, the Kaiser-Meyer-Polkin measure verified sample adequacy, and it was 0.74 initially. Barnes test of sphericity was also significant, indicating that the data was suitable for factor analysis. And IG's value of more than 1 was applied. A factor loading threshold of more than 0.40 was used to retain the items in the test. The initial analysis produced only a 17 structure explaining 77.5% of the total variance, and 3 items, that is item number 33, 53, 97 of the scale. 33 is an item like in maths domain. The child could not, the counting scale 1 to up to 1 to 5. And item 53, it's in a social emotional domain wherein the child knows name or not. That was a question. Item 97, can the child wash hand independently? So these 3 things, items had a low factor loading, so they were removed from the scale. And another EFA was again done. Exploratory factor analysis was done, wherein 95 items were included after excluding these 3 items, and the QMO improved from 0.74 to 0.78, and also the BPOS also improved. So the goodness of test, fit test was performed, which was significant, non-significant, indicating that the scale is predominantly 1 factor and secondly 16 factors. And there was only a 79.7% of variance of the items. So table PCA shows that most of the items had a strongly correlated with each other, varying from 0.96 to 0.41. In figure 1, it shows structural equation modeling of the cognitive domain. In this, it was found that the strongest domain which influenced the cognition was general knowledge latent, and followed by mathematics, then was attention and memory domain. In the affective domain, communication and affective domain, it was found that social emotional skills contributed more significantly, followed by the expressive receptive skills, underscoring the dominance of social emotional adaptability in school readiness. The third domain was self-help and motor domain. In this, the overall gross motor domain emerged as a dominant contributor, highlighting physical readiness component with SHIPA framework. This table shows the content convergent validity which was done with ESI, that is early screening inventory, and it showed that there was strong positive correlation among the scores of between the scores of SHIPA as well as ESIR. So the results reveal that SHIPA successfully identified core readiness domains essential for transition to school among children with ASD. Similarly, similar findings were also found out by Klibnik and Marshall. The present study indicates that while cognitive and academic readiness may be relatively preserved, social, emotional and self-readiness remain significantly delayed among children with ASD. Factor analysis demonstrated a 7-factor structure explaining 60% of total variance, comparable with other established readiness skills. The elimination of the 3 low-loading items improved the model fit, supporting the theoretical coherence of retained 95 items. The strong correlations and satisfactory eigenvalues further confirm the internal consistency. So the correspondence supports significant correlations were found in convergent validity analysis, and it supports the tool's validity and responsiveness in line with recommendations of Cordia et al. And Misal et al., who emphasize the need for psychometrically sound school readiness assessments. Importantly, the SHIPA scale addresses contextual gaps in existing school readiness measures, which often fail to capture social, emotional, behavioral nuances in Indian preschool settings. By integrating culturally adaptive items, SHIPA enhances ecological validity and clinical relevance for occupation therapists and special educators involved in early intervention planning. So literature search revealed few tests with norms of psychometric qualities, and that is why majority of the school readiness tools evaluated the skills of typically developing children were used for assessment. This tool could help identify deficits and improve children's readiness for school within the context of Indian culture and schooling results. The results of the current study are consistent with Klibnik et al. Also, wherein they found less self-care and social awareness than children with ID in children with ASD. So to conclude, future research should include larger diverse samples with longitudinal validation across regional and linguistic groups, and despite the methodological strengths, there has been certain limitations like a small sample size and gender bias or gender imbalance, and this tool bridges a cultural or critical gap in cultural relevant assessment tools within the Indian context and offers OTs and educators a comprehensive framework to facilitate successful school transitions and promote inclusion. Thank you.
Thank you, ma'am. You are well in time. Yeah.
Now we call the next speaker, Dr. K. Naresh Babu, enhancing recovery in alcohol dependence syndrome through person-centered occupational therapy intervention is his study. Good morning to all. My topic is on enhancing recovery in alcohol dependence syndrome through person-centered occupational therapy. The challenges of occupational dependence syndrome is a chronic relapsing disorder causing significant occupational as well as the psychosocial impairments as per the World Health Organization. Despite pharmacological as well as the psychosocial treatments, relapse rates remains high and functional recovery is often incomplete. So individuals with ADS or alcohol dependence syndrome experience persistent deficits in daily functioning, poor routines, and reduced engagement in meaningful activities. So as per, we have an opportunity as an occupational therapy to offer a client-centered approach, holistic approach, focusing on habit formation, role enhancement, and as well as the meaningful activity engagement. So as a critical lack of evidence on structured, person-centered occupational therapy interventions, specifically tailored for alcohol dependence syndrome population, we have framed it. So as my review of literature, so occupational disruption in alcohol dependence syndrome impairs the daily activities, productive roles, as well as the social engagement, even after detoxification. So treatment limitations like existing rehabilitation models often lack structured occupational therapy components, leading to incomplete functional recovery, high relapse rates, and persist despite advances in pharmacotherapy. So role of occupational therapy, it has a person-centered approach, promotes adaptive habits and meaningful engagement. Preliminary evidence suggests occupational therapy improves psychosocial functioning in substance use disorders. So as in research gap, limited studies evaluate person-centered occupational therapy intervention, specifically for alcohol dependence syndrome, highlighting the needs for the robust evidence-based practices. So as in my research hypothesis, there will be no significant difference in functional recovery, psychosocial well-being or relapse rates between individuals with alcohol dependence syndrome receiving person-centered occupational therapy plus the conventional occupational therapy care and those receiving only the conventional occupational therapy care. So alternate hypothesis, individuals with ADS receiving person-centered occupational therapy intervention demonstrate significant greater improvements both in occupational performance as well as in satisfaction and quality of life and lower relapse rates compared to the standard care only. So theoretical basis, the grounded in the occupational therapy adaptation model, which posts engagement in meaningful activities, enhances the adaptive capacity and reduces the maladaptive behaviors and their symptoms. My objectives or the aim is to evaluate the effectiveness of person occupational therapy centered intervention on functional recovery in individuals with alcohol dependence syndrome measured by the Canadian Occupational Performance Measure. My secondary objectives will be assess impact on psychosocial well-being using the WHO quality of life scale, the brief scale, and determine effect on relapse prevention using addiction severity index and 6-month follow-up relapse rates. So compared with outcomes between the both experimental as well as the control group, it will actually aligned with the World Health Organization goals as emphasis on functional rehabilitation and quality of life enhancement in chronic health conditions. So as my study design, we have obtained an ethical clearance and with the informed consent and also the confidentiality maintained in the center. The quasi-experimental design with 2 groups, which both experimental and control group, pre and post designs with assessments at baseline, 6 weeks and 12 weeks. And there is a follow-up. It was done at the Arishodi Mental Health Center, where with an MOU with Sri Abhirami College of Occupational Therapy. The participants and sampling were taken with adults with age 25 to 40 years, diagnosis of alcohol dependence syndrome, and both the genders were included, both male and female. But though actually I got it only in the experimental group, we had the 12 females, 23 males, whereas in control group only males. So sampling method, like it's convenience sampling, initially there was a 109 clients were taken, and later on with their consent, only 70 participants can able to participate. So exclusion criteria, comorbid psychiatric conditions, severe cognitive impairment, and unwillingness to participate has been withdrawn. So there was a mean relapse or alcohol dependence syndrome for more than 6.2 years. This was my procedure. As this quasi-experimental study permission was granted by the board, and 70 subjects were included in the study based on the selection criteria. Screening and pre-test was done by ASI as well as the World Health Organization called brief and COPM for 2 weeks. And control group has 35 subjects and given 45 minutes of session, both 30 minutes plus, only in the control group, and in experimental group we have 25 minutes of intervention plus person-centered occupational therapy intervention, planned intervention for them. So post-test was done after, by using the whole call and as well as the COPM for last 2 weeks being taken. Data analysis interpretation was done by the space software. The 12-week intervention protocol included in the experimental group with activity scheduling, coping skills training, as well as sensory regulation, community reintegration, and leisure activities. Whereas in the control group, only standard care, sometimes they have the pharmacotherapy, counseling, as well as combined with conventional occupational therapy. The structure were between 7 structured sessions, so 45 to 90 minutes, sometimes it's within the 45 minutes, and the follow-up questions will be taken within 90 minutes. So the blended approach, both conventional as well as the person-centered occupational therapy. So assessment tools and timeline, we have taken Canadian occupational performance measure. There was a high reliability of that scale, and there is a whole brief scale which is also free of cost, whereas Canadian occupational pressure is a paid scale. Whereas addiction severity index, we have got the permission from the e-provide MAPI research test. So they have given based on the ethical guidelines, and we can use it up to the limit. So the data analysis methods, we have taken with the inferential statistics, independent t-test between the group and paired t-test within the group, and 95% confidence intervals were being taken, p-value being set to less than 0.05 significant. To reduce the bias, we have used the double data entry to maintain that accuracy, multiple imputations using the handling missing data, and intention to treat analysis like comprehensive evaluation being done. The data which was showed on the whole brief scale, whereas it has improvised on both control group as well as in the experimental group, where the range of magnitude more in the experimental group comparing to the control group. Whereas in this data which is showed on the Canadian occupational performance measure, where here there was an equal performance in the control group, whereas in high magnitude on the experimental group comparing towards to the alcohol dependence syndrome. This particular analysis between the group, whereas in COPM, where it has showed a magnitude of both occupational performance as well as in the occupational satisfaction. But comparing to the addiction severity index, the occupational satisfaction was less, though the relapse been controlled. So actually this is a significant on the performance of the participation in daily routine. The study showed that the positive impact on outcome measures of psychological as well as physiological and social aspects of quality of life and occupational performance and satisfaction among people with ADS was especially in the experimental group. So the discussion, the purpose of this study was to determine the effects of person-centered occupational therapy programs to enhance the quality of life and occupational performance in participants. And the table 2 and graph 1 was showed pre and post test values, and table 3 and graph 2 showed the pre and post test values of occupational performance, whereas occupational satisfaction was less compared to the occupational performance. So this study results indicated the activity scheduling, group activities, relaxation exercises, craft activities, and coping skills development, sensory regulation techniques, and community reintegration. Even we tried our clients to be in the field or with the family. So strategies were facilitated the quality of life and occupational performance of patients with alcohol dependence syndrome. Conclusion, the study was concluded that the person-centered occupational therapy-based outcome strategies have significant positive changes in participants with alcohol dependence syndrome and their psychological, social aspects of quality of life and occupational performance and satisfaction in daily routine. And further, the study results concluded that the person-centered occupational therapy-based outcomes strategies effectively work on patients with alcohol dependence syndrome. Limitations, we couldn't able to do it on different multiple centers, only on a particular center. These are my references. Thank you.
Can we go to the next speaker, Dr. Vishal D. Khande Parker, who will be speaking on the determining association between self-efficacy and lifestyle among older adults, a cross-sectional study.
So one small announcement, sorry to break it up. So the examination for the gold medal award for the best OT delegate will be held in the boardroom. So students who are participating for that exam or appearing for that exam should be reporting to the boardroom by 10:15 sharp. Dr. Vishal, Dr. Vishal.
Good morning, everyone. My Topic for oral presentation is determining association between self-efficacy and lifestyle among older adults, a cross-sectional based study. Older adults face chronic and non-communicable diseases. As per the report by the United Nations, older adults are expected to become 2 billion by 2050. Lifestyle behaviors are now viewed as essential vital signs in patient care. As per the recent study, 75.39% unhealthy lifestyle among older adults in Goa has been reported. A healthy lifestyle reflects a state of balance in daily living. An individual intentionally adopt behaviors that promote health. Occupational therapists have worked towards development of lifestyle redesign framework for the intervention and also constructed health enhancement lifestyle profile, that is known as HELP, for the comprehensive lifestyle assessment. A recent study identified 11 determinants of successful aging: regular physical activity, dietary habit, self-awareness and positive attitude, lifelong learning, spirituality, social support, financial stability, community participation, and independence in daily functioning. Need of the study: evidence suggests improving self-efficacy enhances aging perception and quality of life. Self-efficacy could significantly and positively predict health promotion behaviors of middle-aged and elderly people. However, one of the limitations was that the study focused only on people who have physical training in past, leisure centers, who are generally healthy with a high level of sport participation and exercise motivation. Also, there is limited evidence on self-efficacy and its association with lifestyle among older adults. Self-efficacy is one of the critical factors that is not assessed by most of the comprehensive lifestyle tools. Therefore, it has been recommended to incorporate self-efficacy along with lifestyle assessment. Aim: determining association between self-efficacy and lifestyle among older adults. Objectives: to administer health enhancement lifestyle profile assessment tool among older adults, to measure self-efficacy scale among older adults, and to find association between self-efficacy and lifestyle among older adults. Stroke guidelines, that is strengthening the reporting of observational studies in epidemiology, was used for the methodology. Study design was cross-sectional based, quantitative based study. Study setting was Goa Medical College. Population was among older adults. Study period was from March 2025 to November 2025. Convenience method was used for the sampling and sample size was 41. Inclusion criteria included minimum age of 55 years and above, informed consent, older adults independent in mobility and self-care activities, resident of Goa. Exclusion criteria included older adults with cognitive disorders or any other neurological problems, significant hearing, visual impairment, psychiatric disorder, acute care, hospitalized patient, and palliative care. Outcome measures: health enhancement lifestyle profile is a comprehensive tool designed to assess health-related lifestyle behaviors among older adults. It has 7 key domains. First is exercise, second is diet, third is social and productive activities, fourth is leisure, fifth is stress and spiritual participation, sixth is ADLs and IDLs, seven is other health promoting and risk behaviors. It has 56 items rated on a 0 to 5 scale. Score range from 0 to 40. Higher scores reflecting healthier lifestyle patterns. And it is interpreted as much less healthy than most people, less healthy than most people, similar to most people, healthier than most people, and much healthier than most people. Second scale outcome measure was New General Self-Efficacy Scale. Evaluate an individual's general belief in their ability to perform effectively across a variety of challenging or achievement-related situations. It has 8 items rated on a 5-point Likert scale from strongly disagree to strongly agree. Total score range is 8 to 40. Higher scores indicating stronger generalized self-efficacy. Statistical analysis were performed using SPSS 25.0 version. Data normality verified by Shapiro-Wilk test. Spearman correlation coefficient was used to assess association between self-efficacy and health total score. Results: in the social demographic characteristics, age distribution showed age group 55 to 64 years showed maximum number of participants, and the age group 75 to 84 showed minimum number of participants. In educational status, middle school showed 4.8%, high school showed 29.2%, graduation showed 46.3%, and post-graduation showed 19.5%. In the marital status, married participant showed highest than 95.1%, widow showed 2.41%, and single showed 2.41%. In the employment status, 46.3% were employed fully, 24.3% were retired, 12.1% were doing part-time job, and 17% were unemployed. New generalized self-efficacy score showed high self-efficacy, and HELP total score showed similar to most people. In the Boscan-Wixer test, health enhancement lifestyle domain subdomain showed ADL and IDL showed highest score, whereas the social and productive component showed the lowest score. Spearman correlation coefficient between self-efficacy score and HELP total score showed positive association, although weak. In the discussion, the study showed participants married were 95.12%, whereas only 4.88% were single and widowed. Evidence: the finding is consistent with the previous study. Older adults who were married tend to demonstrate healthier lifestyle patterns compared to their single counterparts. Previous studies have also highlighted marital status as an important determinant of lifestyle. Living with spouse has been shown to provide a protective effect against moderate depression in later life. The finding showed HELP total score was similar to most people. In evidence, in a previous study, the majority of the participants, approximately 76.3%, demonstrated a moderate level of healthy lifestyle behaviors, while about 23.8% showed a desirable level. Older adults in both urban and rural settings found that those with higher levels of self-efficacy tend to feel more assured in managing their health and adopting healthy lifestyle behaviors. The HELP subdomain revealed ADL and IDL category much healthier than most people, followed by exercise and leisure, healthier than most people, then social and productive, less healthy than most people, and the remaining three components, diet, stress, and other health promotion, found similar to most people. Evidence: regular physical activities were necessary for mental and physical health, as it helped to improve the sleep quality, reduce risk of fall injuries, better cognitive abilities, and improved quality of life. Proactive social participation and support have been related to life contentment and happiness and increased life expectancy. Older adults dedicated toward work and volunteer activities found enhanced psychological well-being. The study found, although weak, but positive association between new generalized self-efficacy and HELP total score. Evidence: Pender's health promotion model revealed self-efficacy had a strong relationship with health promoting behaviors of older adults. Second study on a middle age and elderly suggested there was a positive correlation between health promotion behaviors and self-efficacy and sports participation. However, in this study included participants who were generally healthy and those who often participated in sports activity or received physical training at leisure center. Conclusion: the study findings showed there is a positive association between self-efficacy and lifestyle among older adults. Limitation included study completed only 41 participants due to time feasibility, as study was part of fulfillment for master's program. The small size of sample may not provide a true proportionate of Goa's population, and also assessment tool had self-reporting nature, which may provide over and under reporting of lifestyle related behavior. The future implication of the study: the social and productive activities domain was identified as a least healthy area among participants. Future programs should focus on enhancing social participation, community engagement, and meaningful productive activities for older adults. Finding emphasize the need to incorporate self-efficacy assessment and intervention along with lifestyle program in older adults. In future, experimental study design shall be conducted to know the impact of self-efficacy on lifestyle-related behaviors. These were my references. Thank you.
Thank you, Dr. Vishal. May I call upon our next, may I call upon our next speaker for today's session, Dr. Ashish Das. He would be speaking on exploring professional perspective on sexuality education for children with intellectual and developmental disabilities.
Good morning. My topic is exploring professional perspective on sexuality education for children with intellectual and developmental disability. Myself, Ashish Das. The individual with intellectual and developmental disability affect intellectual functioning and adaptive behavior. Nearly 31 million of individuals in India, of whom 35.29% are children. Children with IDD experience developmental delay, including sexual development, biological, cognitive, psychological, and social factors that affect sexual understanding. Children with IDD often struggle with the independence, decision making, sensory regulation, and face limited or negative sexual experiences. The many stereotypes are that sexuality, medical decision like menstrual suppression, reflect stigma, lack of formal sexuality education, leave children with IDD vulnerable to abuse. Children with IDD primarily depends on the parent, teachers, and healthcare professionals for sexuality education. But however, the sexuality education, formal sexuality education is rarely provided in Indian schools. The Indian studies show the parent educator lack in training about the safety, puberty, hygiene, inappropriate behaviors, and cultural biases in discussing sexuality often feel unprepared to address this issue. The gap, there is no evidence on how different professionals teach or manage sexuality related behaviors in children with IDD. The existing literature doesn't examine how their sexuality education is actually delivered and what methods are used or what challenges professionals face, training needs, resources gaps, and support requirement for the professional remain unexplored. The no study has investigated what type of program or interventions professionals believed would be effective and culturally appropriate for children with IDD in India. So my aims is to understand the experience of professionals, including the educator and the healthcare professionals, in teaching children with IDD about the appropriate sexual behavior, to explore the perspective on the intervention of the program to support the development of appropriate sexual behavior in children with IDD. My method is the qualitative descriptive design, including semi-structured interview. The participants are the 12 professionals, the special educators, occupation therapists, psychologists, psychiatrists, and the speech therapist, having the inclusion criteria, minimum 1 year of experience with children with IDD, age between the 10 to 17 years old, mild to moderate IDD, including the ASD and Down syndrome. The exclusion are those professionals who are primarily working with the children with physical disability, that is cerebral palsy, sensory impairment, and psychiatric illness. The purpose is sampling, and the snowball sampling will be included to ensure the diverse across the discipline. The ethical clearance is this present study is the continued part of the another main study, received approval from the IC, KMC hospitals, and Mahe, Manipal. It also be registered in CTRI. Informed consent was obtained before the study. Participants were informed about the purpose, procedure, voluntary nature, and the right to withdraw at any stages of the consequence. Data collection, the individual telephone interviews will approximately 6 to 19 minutes, conducted in English at the participants' preferred time. Interview guide was developed from the literature, expert validated, and pilot tested. These are the list of the questions. Thus, socio-demographic details are collected, interview is audio recorded and transcribed verbatim. Data management, transcription is anonymized, stored and secure with the password protection. Code categories are organized using the Microsoft Excel. Data analysis, thematic analysis is followed by the Brown and Clark's 6 phases. The coding were inductive and iterative, and the grounding in data nature. Data will the thematical analyze. Initially, the code will be carried out by Ashish Das, and the result will be finally verified by the Sebastian and Anita D'Souza. The structured code book was maintained, and the triangulation across the professionals group ensure the rigor. The rigor and trustworthiness will be maintained by the verbal transcript. 3-member checking has done. Audit trail was maintained throughout the process. Reflexive journal to reduce the personal biases. The interview is include the rich contextual description of the participant, and make sure that the identity is pseudonyms and participant in the code. All the information will be audio file like transcript, notes, everything will be password protection, limited access. Telephone interview will be was conducted in respect to participant privacy, convenience, and their comfort. Initially, it was developed with the rapport building, and followed by that might be helped the participant to open up in the sensitive topic. These are the results. The total 12 participants, out of which 2 are occupation therapists, 4 are the special educator, 3 psychologists, 1 speech therapist and 2 psychiatrists. Among them, the 10 are the female and 2 are the male. Age experiences are range from the 5 to 25 years experience. The 5 theme emerges from this. The theme 1, cultural, parental, and systematic barrier. Theme 2, common sexuality related behaviors in children with IDD. Theme 3, the teaching methods used. Theme 4, professional knowledge, expertise, and practice. Theme 5, expectation for the better programs. Theme 1, it identified the cultural is the stigma. So sexuality is viewed as the shameful and inappropriate to discuss. Parents often avoid the discussions or maybe delay in discussion. Limited follow-up through at home, even though it's provided. So one note is say that we can say that sexuality education is a very taboo topic in our North India. They strongly believe that we should not open discussion this topic in front of the child. Even neurotypical children are not getting proper guidance. So how they will be bring the special child. Similarly, the another educators say that the people will feel talking about the private parts of safety is shameful, thus they avoid the topic completely. So often they overprotection that's limited the independence, that lack of the structures, material, tools also be identified, and also be identified the many systematic level like police, hospital, the systems like the POSCO Act are not disability sensitive. The second theme, they identify the children are do the public masturbation, sometime inappropriate touch, they not able to maintain the boundaries, approaching the unknown adults. Sometimes the curious driven also the experimenting. So one educator reported that we have come across the boys talking about their private parts or masturbation in public because of their intellectual incapacity. So these cases are difficult and very common. Same thing similar to puberty related is sometimes confused. They have the fear and menstruation at the erections. Like girls panic during their first period because of they have no idea what is happening. They think they are injured. Theme 3, they often use the visual aid like the chart, model, body diagram. Out of the 2 participants said about the Suvidha kids, the role play, modeling, simplification of the concepts like the breakdown the topics in the simpler small steps. Repetition reinforcements, customization to the developmental level, use of digital assisted tools like video and mobile aids. Theme 4, they also however identify they have lack of the formal trainings. So we have never been formally trained. Whatever we teach or in something we learn through the experience. They also hesitate to do fear due to saying something to the wrong. Therapists are hesitant because they don't know how to teach the sexuality skills. They ended up only talking or giving the advices. The reliance on the improvise the techniques, sometimes they're inconsistent practice across the different professions, need structure professional guidance as well. So it requires the step-by-step modules. They also be expect that the manual should include the visual and simple, sometimes cultural sensitive information. Parents should be part of the modules, and age and cognitive level of adaptation also be required. They also say that should be some device like AI tool that can be respond to the child, like an Alexa for the sexuality questions. There will be need of the standardization across the schools and clinics. So related one, the sexuality remain deeply stigmatized topic in India, especially for the children with disability. The parent often perceive children with IDD are innocent, leading to denial, avoidance, and delay in conversation. These findings are aligned with the Indian global reach, showing that the culture silence as a major barrier to children education and inappropriate IDD in population. Professionals observe the behaviors such as the public masturbation, inappropriate touching, poor boundaries, awareness, and fear during the puberty. This behavior often becomes only time families seek help, indicating a reactive and problem-driven approach. The findings support the global recommendation for the proactive, developmental, appropriate, and early sexuality education. Professionals rely on the visual modeling, repetition, step-by-step teaching, and role play, consistent with the best practice for children with IDD. But however, this practice are not uniform and are often improvised due to the lack of structured curriculum. Limited formal training leave the professional feeling inadequate and prepared and hesitate to address sexuality-related topic. Similarly, pattern also reported in others international journals. The parents are primary reinforcers without their following through the skills to do not generalize. Many parents feel unprepared, uncomfortable, and unsure how to teach this concept. So teaching effective
Your
improve
time
when
is
the
up.
professionals and parents are together highlight this
Judges
parent
may please
focusing
note
model.
down.
The professional describe the insensitive policies like lack of disability understanding, the weak implementation of the POSCO. Family often avoid the reported abuse due to fear and nothing will be happen so that the children will not believe it. So this highlight the critical system level gap in the children protection for children with IDD. So that it will be strong need of the step-by-step standardized module, visual simplification content, the shoot at the cognitive level, parent inclusive approach, age appropriate, cultural sensitive languages is required, and the
Dr. Ashish, kindly sum up.
interested in the technology based solutions like video, mobile app, AI assistance, and reflect openness technology. So so these are the needs like can be implicated that culture sensitive communication strategies, training can be include, capacity building can be improved, evidence standardized and evidence informed visual teaching need to be developed, and early sexuality education should be integrated into the schools and practices. So limitation is generally it's a strength is multidisciplinary, reach and quality data, but also we identify the improvise the teaching method, post-course systems that will be lack. Limitation is only professional. Topic is very sound sensitive. Maybe the possible that there will be disparity. The purpose is sampling, that is one, and teaching also across inconsistency. So conclusion, urgent need of the structure and culture appropriate sexuality education professionals show and professionals show readiness to implement the evidence-based program. Require investment in training, guidance, materials, technology, and disability sensitive system. Thank you.
Thank you. Yes, cross the time limit. Judges may please note down. We may call the next speaker, Dr. Anushari Bhaje, who will be speaking on the effect of dynamic splinting in improving hand function in conservatively managed distal radius fracture.
Good morning to all. Myself Anushri Bhaje, and I am presenting the topic the effect of dynamic sprinting in improving hand function in conservatively managed distal radius fracture. We'll go with introduction. Distal radius fractures represent one of the most frequently encountered injuries in orthopedic practice, occurring when the radius breaks close to the wrist joint. They account for approximately 8 to 15% of all fractures in adults, with a higher incidence seen in older populations. Although most commonly associated with fragile bones in elderly, even healthy bone can fracture under sufficient impact force. Dynamic splinting, it applies controlled passive and sustained stretching, has been proven effective in minimizing contractures across a range of joint and pathological conditions. This evidence supports its therapeutic value in the rehabilitation of patients with distal radius fracture and related musculoskeletal impairment. Dynamic sprinting is a biochemical intervention used to correct joint contractures and stiffness by applying low load prolonged stretch and to targeted joints. Dynamic sprinting allows motion in one direction and control resistance in another. It works by maintaining constant tensile stress on periarticular soft tissues, promoting tissue elongation through creep and stress relaxation mechanisms. This tension leads to reorganization of collagen fibers in the direction of applied force. The remodeling phase of healing is optimized by this consistent stretch, leading to improved flexibility, joint mobility, and functional alignment. A fundamental biomechanical concept that supports the use of dynamic splinting is the total end range time, which describes the overall duration a joint is maintained at its maximum comfortable stretch each day. Dynamic splinting provides a gentle, sustained force that keeps the joint position near its end range for long periods. This method promotes creep, stress relaxation, and plastic adaptation of soft tissues, resulting in lasting gains in tissue length and joint motion. Rationale: distal radius fracture leads to loss of hand function. Dynamic splinting involves passive prolonged stretching that has been proven effective in connective tissue elongation This method reduces contractures in various joints and is particularly relevant in managing distal radius fractures. Molecular studies also support its role in promoting tissue remodeling through sustained stretching. Patients' active range of motion, additionally, uh, strengthening exercises combined with resistive purposeful activities have been shown to enhance grip strength in conservatively managed distal radius fractures. Methodology. So, place of study was tertiary institution. Sample size was 30 subjects taken in study. They were divided into two groups, 15 in experimental and 15 in control group. Types of sampling, it is a convenient sampling. Duration of study was from April 24 to May 2025. Intervention duration for 6 weeks. Selection criteria. Inclusion criteria included patients that are diagnosed with all types of distal radius fracture, patient belonging to age group from 18 to 60, patients with any level of education, both male and female sexes were included, patient managed conservatively, and patient immediately after removing cast. My exclusion criteria includes prior trauma of wrist, malignant conditions, all types of arthritis of wrist and hand. Outcome measure used was goniometry and Jepsen-Taylor hand function test. So intervention for experimental group. The experimental group received intervention for 6 weeks, total 30 sessions for 45 minutes each, 5 days per week. At the beginning of treatment, patients were instructed to wear the splint continuously for 4 to 6 hours at the lowest tension setting to allow for adaptation. Following this initial adjustment period, they were advised to use the splint overnight for 6 to 8 hours while sleeping. After 1 week of tolerance that at level 2, tension was increased to level 3, with further incremental adjustments made every 2 weeks. If a patient experienced prolonged discomfort lasting more than 15 minutes after a session, the tension was reduced by half a setting for 2 days before gradually resuming longer wear at the adjusted level. So conventional occupational therapy intervention included for edema management, active range of motion, elevation, cold application and compression. For pain management control strategies included prescribed medication, cold therapy, heat once swelling begins to decrease, contrast bath, graded motor imagery, wound and scar care, appropriate care for wounds and pain sites is necessary to prevent infection. Scar massage should begin once a soft pink scar is present. Firm circular massage with lotion helps mobilize adhesion and reduce hypersensitivity. If the area is overly sensitive, graded desensitization procedures may be used. Activity-based exercises. Exercises turning the back and palm of hand with elbow fixed at the side as doing painting on wall board. Cleaning tabletop, cleaning window, spreading and joining fingers with keeping squeezing foam inside, reaching the fingertips with thumb, reaching finger base with thumb with help of cloth clips, bilateral paper ripping, simple blackboard writing and drawing tasks, various pinching and opposing activities. Result: a total of 30 subjects were included in this study. 16 were male, female, and 14 were male. The participants were divided into two groups, experimental and control group, having mean ages of 41.26 in experimental and 43.8 in control group. So table 1, it represents pre-test for both group analysis at baseline for goniometry and Jepsen-Taylor head function test. At baseline, there was no statistically significant difference between experimental and control groups for goniometric measurement at t-value for 0.270 and p-value of 0.789, and Jepsen-Taylor hand function test scores t is minus 0.529 and p-value 0.529. This indicates that both groups were comparable before intervention. This is table 2. It is post-test analysis for goniometry and Jepsen-Taylor head function test. Post-test analysis showed a statistically significant difference between the experimental and control groups in goniometric scores, with the experimental group demonstrating greater improvement at t-value 2.15 and p-value 0.041. Similarly, Jepsen-Taylor hand function test scores revealed a significant difference favoring the experimental group at t minus 2.62 and p-value 0.014. Table 3, it shows within group analysis for range of motion and Jepsen-Taylor hand function test. Within group analysis showed a statistically significant improvement in both goniometric range of motion and Jepsen-Taylor hand function test scores from pre-test to post-test in experimental group, where P is less than 0.001. The control group also demonstrated a significant improvement in range of motion and hand function. However, the magnitude of improvement was greater in experimental group. Discussion. The study demonstrated that dynamic sprinting combined with occupational therapy significantly improved wrist range of motion and hand function after a conservatively managed distal radius fracture. Compared to conventional therapy alone, dynamic sprinting produced greater gains in wrist mobility and Jepsen-Taylor hand function test performance over 6 weeks. So, limitations of my study was, the study was conducted only on a small sample size of population who attended the study setup, and no comparison was done between dominant and non-dominant hand. And future recommendations include randomization should be done to improve reliability of the study, long-term follow-up should be done, and comparison with other interventions can be recommended. So, to conclude, this result of this study indicate that dynamic sprinting is a highly effective method for enhancing hand function in patients who have undergone conservative management for distal radius fractures. Individuals treated with dynamic sprints demonstrated marked improvements in wrist mobility, decreased stiffness, and better performance in daily functional activities. The gentle, sustained stretch provided by the splint directly addressed the soft tissue limitations and joint restrictions that occur after immobilization, leading to meaningful functional progress. These are my references. Thank you.
Thank you, Dr. Anishri. You're well in time. Now, I would like to call upon our next speaker of today's session, Dr. Revant R. Would be speaking on effect of physical exercise program protocol on hand flapping in children with autism spectrum disorder.
Respected chairperson and esteemed judges and all member delegates and our students, good morning all. Today I am going to present a paper entitled on effect of physical exercise program protocol on hand flapping in children with autism spectrum disorder. Introduction. Autism spectrum disorder is a neurodevelopmental disorder characterized by persistent social communication difficulties, presence of restricted and repetitive behavior. Symptoms usually appear within first 3 years of life. Prevalence and behavior feature. Prevalence in India ranges from 1 in 500 to 1 in 16 children. ASD occur more frequently in males. Common associated features include sensory dysregulations, echolalia, sleep disturbances, rigid routines, solitary play, fixed and specific objects, hand flapping, and need for the intervention. Common stereotypical behaviors: hand flapping, rocking, vocalization. Hand flapping functions as sensory seeking or emotional experiences. Physical exercise may regulate excessive energy and provide sensory rhythmic input. Limited evidence on structured exercise protocol necessitates evaluation of physical exercise program and their protocol. Aim and objectives: to determine the effect of physical exercise program protocol and hand flapping in children with autism spectrum disorder. Objective: to assess the severity of autism using Indian scale for assessment of autism. To assess and evaluate the hand flapping behavior by using GARS-2. To assess and evaluate the frequency and duration of hand flapping behavior during the intervention by using antecedent-based intervention data sheet. To find the effect of physical exercise program protocol and hand flapping in children with autism spectrum disorder by using subscale of GARS-2. Hypothesis. Alternative hypothesis: there will be a significant reduction in hand flapping behavior in children with autism spectrum disorder after participating in PEPAU protocol. Null hypothesis: there will be no significant reduction in hand flapping behavior in children with autism spectrum disorder after participating in physical exercise program protocol. Study design: quasi-experimental study. Study population: autism spectrum disorder. Study setting: Sri Sarvavidya Multispeciality Therapy Center. Sample size 30. Study duration 4 months. Independent variable physical exercise program for autism. Dependent variable hand flapping behavior in children with autism. Sampling technique: convenient sampling technique. Inclusion criteria: children diagnosed with autism by a pediatrician or psychologist. Children with mild and moderate level of autism in ISA score are included in the study. Male and female children are included in the study. Children aged between 5 to 11 were selected. Exclusion criteria: children with severe autism in ISA were excluded from the study. Children above 11 years of age are excluded. Children with associated problem like seizure disorder were excluded. Children who were under on medications for any autism associated condition were excluded from the study. Screening tools. ISA Indian Scale for Assessment of Autism and Stereotypic Subscale of Gilliam Autism Rating Scale. Measuring tools, Stereotypic Subscale of Gilliam Autism Rating Scale and Antecedent Based Intervention Data Sheet. Procedure. Data were collected using ISA and GAUS2 and Antecedent Based Intervention Data Sheet. Experimental group consists of 15 and control group consists of 15. Experimental group receives PEP-AU protocol along with conventional occupational therapy. Control group receives only a conventional occupational therapy. The intervention period is for 4 months in 16 weeks for in a session, 45 minutes a session. The intervention included preparatory phase and relaxation phase with the activities such as ball tapping, climbing, jogging and elastic band exercises. Data analysis. The first is a comparison of stereotypical subscale of GAUS2 in pre-test between experimental and control group. Second, comparison of stereotypic subscale of GAUS2 score between pre-test and post-test on control group. This table shows us there will be no significant difference in both groups. Table 3 and graph 3, comparison of stereotypic subscale of GAUS2 score between pre-test and post-test on experimental group. This score indicates that there will be a significant difference in both groups. Table 4 and graph 4, comparison of stereotypical subscale of GAUS2 score in post-test of experimental and control group. This table indicates that there will be a significant statistical difference between the two groups. Graph 5 and graph 6 shows that comparison the frequency of hand flapping behavior in experimental group by using antecedent based intervention data sheet. Graph 5 and graph 6 shows there will be a significant reduction in hand flapping behavior in experimental group. Graph 7 and graph 8 shows that comparison of frequency of hand flapping behavior in control group by using antecedent based intervention data sheet. This graph shows that there will be a not significant effect in control group. Discussion. The present study evaluated the effectiveness of PEP-AU protocol in reducing hand flapping behavior in children with autism spectrum disorder. Table 1 graph 1 shows the pre-test comparison between experimental and control group. The mean score were 11.00 experimental and 12.27 control with p-value of 0.208 indicating no statistical significance at baseline. Table 2 and graph 2 shows the control group comparison. The mean score reduced from 12.27 pre-test to 11.13 post-test with p-value is equal to 0.001 showing mild improvement following conventional occupational therapy. Table 3 and graph 3 illustrate the experimental group comparison. The mean score decreased from 11.00 pre-test to 7.00 after the post-test with the p-value is more than 0.001 demonstrating a highly significant reduction in hand flapping behavior following after PEP-AU protocol intervention. Wilson signed rank test results showed a significant reduction in hand flapping frequently in post-experimental condition. Median is equal to 10.00 compared to pre-control median 13.00 and pre-experimental median 12.00 and p-value is greater than 0.001. Graph 5 and graph 6 revealed significant decrease in hand flapping frequency in the first week to the 16th week in the experimental group based on antecedent-based intervention dataset analysis. Graph 7 and graph 8 show only a modest reduction in hand flapping behavior in the control group over the same duration. Overall experimental group receiving physical exercise program protocol along with conventional occupational therapy demonstrated a greater and significant statistical improvement compared to the control group. Conclusion. The study concluded that physical exercise program protocol along with conventional occupational therapy lead to significant reduction in hand flapping behavior among children with autism spectrum disorder. Limitation of the study. The sample size used for the study was small. The duration of study was relatively short. The study only included participants within the age group of 5 to 11 years. Study can done on larger sample size. The study recommends to be done on more than 11 years of age. Extending the intervention period could offer insights into a longer term effect on sustainability. References. Thank you.
Thank you, Doctor. Now we would like to call upon all the presenters to please come on the dais for the question and answer session.
So our first speaker was Dr. Bandhana Senapati. Any question to her? Yeah. One question from each. No more than 2 questions from overall.
The first one was Dr. Bandhana Senapati. What I would like to ask you was, when the translation was done for your test, how was the accuracy ensured? Was there a double-blind translation done, or did you follow any other method?
Ma'am, double-blinded was done actually for the accuracy. That's why we chose nursing professional and trained nursing students. Yes, ma'am.
Okay.
Madam, one more question. Sir, as a question.
So good morning, ma'am. What made you to do this study, ma'am?
Sir, actually, I'm a certified breastfeeding trainer, and for the past 15 years, I'm doing breastfeeding self-efficacy practice in my setup. So, the breastfeeding self-efficacy scale has been translated into 14 languages, but Odisha doesn't have. And I belong to Odisha. So somewhat I thought, okay, I should do the test and I should translate this breastfeeding self-efficacy scale into Odia versions so that it will be helpful for the Odia mothers. They don't have to follow the English and Hindi version, because if it will be implicated to them, definitely those who don't know the English and Hindi, we have to translate and then they have to answer. Definitely there will be changes in fulfilling the questionnaires.
Okay. Thank you.
Madam,
Thank you.
I would have one clarification. Like usually, like you may be a certified therapist in breastfeeding.
Yes, sir.
But usually the patients or the mothers will not be going to occupational therapist who are a mother of typically normal children, kids. So how this study will be have implication for the occupational therapists?
Sir, actually nowadays in Pondicherry, breastfeeding self-efficacy train is going on in last number.
No, I'm talking referring to occupational therapy practice.
Yes, sir. That's what not only lactation professional and nursing professional, they are encouraging occupational therapists, physiotherapists, or any professional in the healthcare system starting from primary level to tertiary level, that they should go for the training. So if the patient goes to any center and there the lactation professional or nursing professionals are not available during that time, if any occupational therapist knows about this the breastfeeding training, definitely they are going to help them.
But can this study maybe have an implication for the mothers of the developmental disabled children?
Yes, sir. Sometimes in my...
so they might have different issues.
They have different issue, but while taking this assessment, sometimes when I take the breastfeeding history, they say, "Ma'am, I'm giving cow milk or I'm giving formula powder," which is not good. So as I'm a certified breastfeeding trainer, being occupational therapist, so I could able to help them.
Thank you.
Thank you so much.
Okay, the next speaker, Dr. Rajalakshmi Lanka. Any question to her? Her study was on effect of task-oriented circuit class training in attention, memory in stroke survivors. No questions. So if no question,
is there any question from the audience? Yeah. No questions? Okay. Can I ask you one small question, Madam Dr. Lachikmi? Your topic was on effect of task-oriented circuit training in attention and memory in stroke survivors. The first thing, your age range was wide, 18 to 70 years, number one. Second, you mentioned the stroke survivors. What was the sensory motor status? The tone and other factors in your patient population you included in the study?
Sir, since the tertiary institution did not have a large base of incoming stroke patients, so I did not find many stroke patients at one time. So I had to increase
my question is the sensory motor status. whether what was the tone? Tone was normal or impaired, or any synergy pattern was there, or any brainstorm stage you would like to specify?
So there was no particular Brunstone stage that I was taking. The patients which participated were of different Brunstone stage.
Then how did they manage the treadmill?
So for that, I had to see that the Brunstone stage for the leg was of 4 or above to maintain so that they don't fall.
Dr. Kumar, you would like to ask any question?
I would like to add on for your this methodology and the implication on in terms of limitation recommendation. See, it's for not you, for all the budding therapists. The recommendation cannot be opposite of the limitations. Limitations are those which you wanted to do but you couldn't do, and recommendations are your future studies implications which you would like to suggest to others that they would like to carry on.
Okay, sir. Thank
So
you.
please, all the budding therapists, limitation and recommendation cannot be opposite of each other's. And similarly, inclusion, not for you, but for the other one, inclusion and exclusion criteria cannot be opposite of each other's.
Okay, sir.
Thank you. Can we call the next speaker, Dr. Mr. Ma'am? Any question for her? Yeah, please.
Sir, to Raj Lakshmi ji.
Achha, the previous one?
Yeah.
We already have 2 questions, please.
Okay.
Thank you.
Okay.
Please.
Thank you.
If no question to ma'am, so ma'am, just I would like to have a clarification, not a question. Your this scale has, I think, 95 items.
Yes, sir.
So
The final scale is 95.
Okay.
Initially, it was with 98 items.
So how much time it takes to us run on the
2 hours.
2 hours. You
Yeah.
know, one go or one day or
No, we can divide it into 2 sessions to do this thing.
Okay.
Because we cannot get the cooperation of the child fully.
Yeah.
So at a stretch, 2 hours is very difficult. So we do it in 2 sessions.
Okay, thank you.
Any questions from the audience, please? Ma'am, can I ask one more clarification? Your topic was on the factor list of school readiness inventory for preschoolers.
Yes, sir.
Preschoolers with ASD.
Yes, sir.
Ma'am, how did you manage the confounders? Like the socioeconomic status, the family environment and all this?
Because we took all the children from the urban setup. So socioeconomic status mostly was like average and above average. And most of the children were already going to play school. So because they were from an urban setup, I did not take any children from the rural setup at all. So that is why those confounders were not much, it did not affect much.
Thank you.
Thank you.
Our next speaker is Dr. Naresh Babu. His study was enhancing recovery in alcohol dependence syndrome through person-centered occupational therapy interventions. Any question of the audience? Yeah, please.
Good morning, Dr. Naresh. I'm Dr. Srihash Jagirdar from Mumbai. I would like to ask you, how did you differentiate your conventional occupational therapy from client-centered occupational therapy? Is there any operational definition that you used for defining the conventional occupational therapy in your study?
Actually, in person-centered occupational therapy, we have follow 4 categories, which is activity scheduling and coping skills as well as sensory regulations. Whereas in conventional occupational therapy, where even we have a counseling as well as pharmacotherapy we have been utilized for them. So it's like the definition, like it's same, I know that, but the thing is we are specified for the session scheduling for them, and we give a coping skills also for their home based or in the center based. So that's what's a difference between them.
Okay, one more question at the
Hi, good morning.
Yes, ma'am.
My question is, why did you have to stop the age group at 45?
Ma'am, the center which having a more severity. So because I think after 45 or 40, the family expectation of them to recovery into their society was very limited. So that's why I have to take it between that group, though the previous study also stated in that, But even though I wanted to plan in the next study for the age group up to 60, though most of the fathers, most of the families are affected. So,
But I didn't see that in your recommendations.
yeah, because actually I want to take it in the other centers. That's what I wanted to mention. But though it is missed. Yeah.
All right, thank you.
Thank you.
Dr. Naresh, is that any age factor is specifying age factor? Is it as a confounding factor, or is it what impact on your studies?
So the age factor is the younger the age. So the younger the age was so much affected, and the recovery was faster in the younger age, whereas in higher age, still some of the relapses were still there, according to the addiction severity index. Where the younger age, we couldn't able to get a higher recovery.
Okay, just we need a clarification. In the control intervention, was there any sort of a psychological counseling for the addiction or CBT type of thing?
Yes, sir. It
will
was
also
being
get
continued. Yes.
Okay. Thank you.
Thank you, sir.
Can we the next speaker, Dr. Vishal, who talked about the determining association between self-efficacy and lifestyle among older adults, a cross-sectional study. Any question to him?
Hi, it's me again. I have two questions, if you don't mind. One is, what is your definition of unemployment? Because I saw one as retired and one as unemployed. And the second one is, what is the correlation between marriage and social productivity for you?
Thank you for the question, ma'am. For the first question, why the employment? In my study, I have included 55 years for the population for older adults, as the health enhancement lifestyle profile is specifically designed for the age group 55 years and above. First, secondly, the older adults who are employed may be working or may be unemployed because of other medical problems, because the retirement happens at the age of 60 years. And the second, marital status and relation with the social, the key article studies suggested that the older adults who had a marital relationship had a good, healthier lifestyle.
No, I understand that. The expectation is also that if you're married, then you're happily married, you might have a better social participation. But your study seems to show something else altogether.
No, ma'am.
Or maybe I didn't understand it. That's the question.
So, based on the finding, health enhancement lifestyle profile has 7 domains: exercise, diet, social productive activity, and other 7 domains. In that area, how was the lifestyle pattern among older adults in Goa found that social productive area had a lowest score. Like social productive area was lifestyle was poor in Goa.
So the ones who are married have low social productivity.
Yes, ma'am. That was the lifestyle pattern in Goa.
Oh, all right. Thank you. Yeah.
Okay. So, okay, ma'am. Short question.
So you have found a correlation with the marital status. Have you also measured the support, the family support that the individuals may have had from siblings or children or grandchildren?
Actually, primary objective was understanding self-efficacy and lifestyle among older adults. And in the socio-demographic characteristics, I had included the marital status and family status.
Family status was not reflected. Marital status was reflected.
Yes, yes.
So that was not measured.
It was measured, but I am not included in the presentation.
Okay. Thank you. Thank you, Dr. Ashish. Okay. Can the next speaker, please? Oh, sorry, Dr. Vishal. Dr. Ashish, can you the next, please? I'm sorry. Okay, so Dr. Ashish talked about the exploring professionals' perspective on sexuality education for children with intellectual and developmental disabilities. Any question to him? Yeah. And it's short question.
Yeah, short and only one question. You said it was a continued study. So what were the difference in the findings?
Sorry, I couldn't get you.
You mentioned that this was a continuation of an older study. So what were the findings? What was the difference between the two?
It's a continuation, means it's an ongoing study is going on. It's one of the part of the major study. So it's a major study is including the parents as well. So along with the healthcare, along with the professionals. So that was the major qualitative studies is underwent, and this is the one of the sub part of the total qualitative studies.
All right, it would be nice if you can mention that.
Okay.
Becomes clearer. Thank you.
Hello, Dr. Ashish. This side. I have a question for you. Yeah. I'm Geeta Oja. I'm working in Ibhas, Delhi. And I have a question. You mentioned in your slide, you have mentioned about AI, isn't it? So how are you going to take care about the AI hallucination, or like in the present context, AI, particularly your topic being such a sensitive one, how do you think you are going to take precautions, or how are you going to clarify the use of AI in that?
Okay. So one of the participant recommended AI might be going to be useful. So they like explain like if there will be AI which would be a kind of Alexa. They gave an example where they can able to answer those sensitive informations. Currently, if we are going to be asked any kind of AI chat models, anything, so they have the restrictions to all sexuality related contents. So that's why there's some application which they suggested, if some application which is enable those kind of features, and obviously it will be developed and verified and have some limitations within that.
It's not only development, because there are a lot of ethical issues involved, and
Yeah.
other thing is confidentiality, particularly in such a sensitive topic. Confidentiality is something which is very, very important.
Yeah.
And AI, current AI tools, none of them actually adheres to those ethical standards. So if you are planning to involve AI, even if it is a suggestion of the participants, I think there should be so many things to be taken care of, isn't it? So I think that can be highlighted into your thing.
Yeah.
Okay. Thank you. All the best.
Thank you. I
Dr.
just have
Ashish, I have
I
one
think
question.
We already have two questions. A very small question. Okay, take it
Okay.
short.
Dr. Ashish, as an occupational therapist, what are the challenges you faced while taking up the sexuality education? This is special children, right? So, what do you think about normal and special?
Okay. So
what are the challenges you faced?
The main challenges the children more, if in this category, some of the intelligence is the one of the central aspect of the, so and another is the non-verbal communications. So these are the central aspect along with the others like characteristics of the children have, if there is autism, any other feature, they have the unique characteristics. So main challenges I found is if directly working with the child, so to make them to what level have to be come down and then decide. Some require the prerequisite skills like have certain understanding, comprehension. If the children do not have the comprehensions like severity levels, like severe level, so it's really challenging to teach them even the basic characters like safe touch, good or unsafe touch. So I feel that's and another main challenges I found that the parents do not consider including the professional as well. They might be they, even if the many professionals also say that they are ready to or they are willing to, but in reality they are not practicing. They also be said the same. So most of the prefer to be comfort in a kind of a discussions. So they really don't like to be involved. Is inside there will be like kind of hesitance or maybe shame feeling. At the same time, conversation is feeling more like shameful, feelings. So that's why the major challenges in occupational therapy are found. Even though I am focusing on the independent skills like safely handle the dressing and
Please
everything.
be brief to your
So
answers.
sexual activity is
No
added in
cross question,
OTPF
please.
also.
Excuse me, no cross question, please. Please.
Thank you.
Please brief to the answer. We are running also this out of the time. Okay. It means you are already explaining the themes. Okay, we understand you have done a qualitative study, and if it is a good study. And what I'd like to clarify to this last question, that the challenges were not because you have interviewed with the professionals, not to the children. Okay.
As a profession,
No, no, who are the participants? Who are your participants?
Participant are the parent. If you are looking at
No,
the
your participants.
Sorry, sorry, sir.
Who were your participants?
In this present study,
Yes.
these are the professionals.
Professionals, okay. And they might have not talked to any parents or the children on the issues of sexuality. So they might have not faced all this issue, we are just assuming these issues. Okay. Thank you. One more last question. You use sexuality education. Is it the same as sex education or sexuality education?
Sex education and sexuality education. So both are different. Sex education include more about the preventions of sex, and sexuality is including more specifically genders, identity, their own, not only limited to biological, more about the cognitive, more about the social aspect and the emotional aspect. So it's a kind of comprehensive, but sex education is specifically focused on the body anatomy and more about like prevention of sexual abuse. So here more
Thank you.
comprehensive.
Okay, the next speaker, Dr. Anushri. Her paper was on the effect of dynamic splinting in improving hand function conservatively managed distal radius fracture. Any question?
Good morning, everyone. In your study, you have included...
Please introduce yourself. Please introduce yourself.
In your study, you have included participants
Audience,
with...
please introduce yourself.
Sorry, sir. Good morning, everyone. Myself, Subrato, second year MOT students from Isviniftar. In your study, you have included participants with both Colles fracture, including both the Smith and also Colles fracture. Distal radius fracture, including both Smith and Colles fracture. And we know that in both the fracture, the displacement will be in opposite side, palmar and dorsal side. So my question is, how did that, and you are also included, you have used the dynamic splinting. So how did the
ask the
opposing...
question directly and do not comment what he did. You can ask the question directly.
Okay, sir. So how did the opposing vector of force distinctly impact the integrity of the dorsal and the volar carpal ligaments?
Actually, my studies was focusing on hand function. So I didn't consider about this. Means I just use that splint that it gives that it should be in wrist extension, and which included the where head which are like for 30 degrees of wrist extension and little bit of MP flexion and IP extension, which is ideal for hand functions. So I didn't consider that force and all. So it was just it was only dependent on that patient comfort. According to patient comfort, I saw that if you are asking for that resistance, how it,
like the opposing force of vector will be acting upside and downside, no? So how these two will be impacting that ligamental stability? Because in order to improve the hands function, obviously there has to be ligamental stability, which provides passive stability. So my question was like the mechanism, like how does it really impact that stability part?
so mechanism, it's like it works according to mechanism on creep and muscle relaxation. So it provides controlled sustained motion, sustained motion, and control low load and controlled motion. So it it provides tissue remodeling. So it is not like too much joint immobility is not there, but it is controlled, so it won't affect much of that forces. So stabilization is not much affected.
Okay, thank you. Any more question? Yes.
I congratulate on your topic, and it was wonderful. But however, I need clarification on what mechanical principle, maybe that extension also, or was this splint of the counter or fit for all one design, or it could have some customization also available? And how did you calibrate the force of the rubber bands that you had used? Were they calibrated? Was there any specific unit to that?
It would have been better if you had shown one picture of your splint.
Sir, I have
or dynamic
mentioned
video.
there.
Okay.
Sir, I have
No.
showed it.
Did you show the picture?
Yes, sir.
Okay, maybe I skipped. Sorry. So explain the answer. Answer his question.
Sir, sorry. Can you again?
Okay, so can you give me one clarity about how did you grade the force of the dynamic component, and whether there was any measures taken to customize the splint, or it was one design for all?
Okay. Sir, it was custom fabricated splint. It was not one design for all, since everyone has different hand features and all. So according to sir tension, if you are asking how I did it, there was nothing like to measure anything in units or anything, but clinically it is measured like elastic rubber band I have used here. You can use springs and all, but sir, what I have done is to see patient's comfort and optimum stretchability of joint displacement should not be there, and patient's comfort, these are to be noticed. Other than this, no such units of measurements are available.
Okay, thank you. Just small clarification. Did you do the sample size calculation?
Sir,
Did you do the sample size calculation in your study?
sir, sample size calculation.
Yeah.
Sir, 30, sir.
But you not done any statistical calculation for estimation for the samples?
Sir, no, sir. Sir,
Okay, thank you. Can the last speaker for any question answer? As this effect of physical exercise program protocol on hand flapping in children with autism spectrum disorder. Any question to Dr. Revant? The audience, do you have any question? Please.
So good morning. Myself Raghuram from Chennai. What are the challenges you faced when you prepared for the protocol?
Yes, actually, I applied physical exercise program protocol, sir. Here, hand flapping is the children is doing for 2 times. One is for sensory basis, another is for emotional. Suppose if children are doing with sensory basis, for that kids, I am giving an intervention, I get a good result for that kids, sir. If suppose the children are doing for emotional basis, for that intervention, I feel limited thing only, sir.
Okay, thank you.
Any more questions?
I am Dr. Ganapati Shankar from SRM Chennai. So my question is there any rationale the child exhibiting stereotypical repetitive pattern of behavior due to the emotional? You mentioned only sensory. Sensory means you have to explain, maybe audience maybe interpret various types. This sensory processing problem or something else you mentioned too, sensory as well as emotional.
Yes.
Is there any rationale before preparing protocol for your intervention?
Yes, actually, before preparing a protocol, I didn't fix any rationale, sir. During the intervention, I faced these challenges. Children, especially children, in emotional aspect, in case of fear, in case of anger, in case of whether exposing their emotional, for that kids, I am applying this intervention. In that time, I am getting a limited exposure compared to sensory basis kids.
Okay, thank you. I think one.
Any other question?
Can I?
Very small question.
Yeah.
Please,
Yeah.
only have 2
My name is Vaishali Pai.
Yes,
Good morning. One observation, there is also a cognitive issue, not just sensory and emotional. Why did you leave out severe? You expect a lot of hand flapping in children with severe disabilities. So why leave them out?
Ma'am, actually, I am here applying physical exercise program protocol, ma'am. They're having certain jogging, then climbing up activities. I'm having separate set of protocol. There is a 3 phases are there: preparatory phase, intervention phase, and finally relaxation phase. In a preparatory phase, we need to make the child lie down on breath up exercises and wearing of.
No, I understand. You have your protocol. That's
Yes,
not the
yes,
question.
yes, ma'am.
Why did you feel that you won't be able to apply your protocol to children with severe autism?
In a severe, previously I did a pilot study for this title. In that I included severe kids also. For severe kids, they can't able to participate in this physical exercise program. So
maybe that mention would be good.
Yes, thank you. Dr. Evan, if there is no more question, can I have the opportunity, one clarification I seek from you?
Yes, sir.
It's a wonderful topic. So you mentioned is a hand flapping in children with ASD, autism spectrum disorder.
Yes,
so what do you think? Is this a sensory seeking behavior or sensory stimulating behavior? And how did you differentiate between sensory and the emotional state? Whether sensory cause, emotional causes involved?
Sir, here mainly children are doing because of sensory stimulating behavior, sir. And also, why in emotional aspect, why I am differentiating mean, in case of anger or in case of tantrums, or children are doing hand flapping, sir. In that aspect, I am differing from emotional to sensory stimulating, sir.
Okay. I have one suggestion to your study. You
Yes.
mentioned your inclusion criteria and
Yes.
exclusion criteria, but you mentioned the exclusion criteria entirely opposite to the inclusion. Methodologically, it is wrong.
Okay.
Exclusion should not be the opposite of inclusion criteria. This is all for all the budding therapists and the freshers in the research. It is basically those who have included out of that population which subject you would like to exclude. For instance, we have all these audiences inclusion criteria,
Yes.
but those who have not taken the breakfast, they are excluded. Okay.
Okay.
So it cannot be opposite to each other.
Sure.
Please. Okay. Thank you. Thank you. So
Dr. Sujata Misal, please give a big round of applause.
And a fresh applicant will get at least 3 months time to come for webinar. So they will get sufficient time basically. So you are.
Thank you, sir, for your encouraging words. This webinar is all the self-nomination form is available on the IOTA website. So you can download and fill it from there. And this is for all the professionals, budding professionals, and our occupational therapy interns also. And since inception till date, 12 lectures have been delivered till date, and more than 750 professionals have been benefited who have attended the webinar. So on behalf of Academic Council, I would like to convey the sense of gratitude to all the resource persons, our speakers, as well as the moderators of the webinar series for contributing and making it a successful event. Now, I would like to request our Dr. Shailja Jayavant Bandhan, Dr. Vijay Supre sir to kindly felicitate our Dr. Pankaj Bajpai sir, Honorable President AIOTA.
And this felicitation because I took the first webinar just to start that.
Sir is our first resource person for this occupational therapy skill building webinar series. So they will be facilitating sir with the sash. Sir especially mentioned, do not give me certificate. So even the sash is a token of respect. Sir even was not aware of this. Thank you, sir. Thank you, madam. And now I would like to call upon our Dr. Pratibha Vaidya, madam. She was a moderator for the skill building webinar series. And may I request Dr. Sunny Joseph, Honorable Secretary AIOTA, and Dr. Anurupa Senapati, madam, to kindly felicitate them. Madam. Dr. Sunny Joseph. Okay. So, may I request Dr. Arun to come? Dr. Arun? Felicitate Vaidya, madam. Madam was our moderator for the session. Madam, the certificate is Miracle, last one. Certificate, please. Certificate, dear. मैडम का सर्टिफिकेट इज आल्सो हियर दे दी हाँ नहीं दी सर्टिफिकेट नहीं दिया वदे मैडम का है इज देयर ओनली एनवेलप ओके now may I request Dr. Madhu Mohanty madam Head of the Department of Occupational Therapies, Pandit Deen Dayal Upadhyay, National Institute for Physically Handicapped. And for this, I would like to request Dr. Shalja Madam and Dr. S.K. Meena sir to kindly come on the dais and felicitate them. Madam. Session certificate. Thank you. Now, may I request Dr. Vaishali Pai Madam to please come on the dais. And for this, I would like to request our Dr. Pragyan Singh Madam and Dr. Shri Harsh to kindly felicitate Madam. Madam was our resource person. Now, may I request Dr. Pragyan Singh Madam to please stay there. So, we would like to felicitate her. She was our moderator. So, I would like to request Dr. Raghuram and Dr. Harris. Dr. Harris Manova. Dr. Shalja Madam, please join them. Shalja Madam, please join them for the sesh. For the sesh. Certificate. Thank you, sir. Thank you, madam. Now, may I request Dr. Sujata Misal, madam, to please come. And I would like to request Dr. Sushmita and Dr. Ganpati Shankar. Sir, madam, please felicitate, madam. Sushmita, please join them. Please join them. Thank you, sir. Thank you, madam. Now, I would like to request to call upon Dr. Geeta Jyoti Oja. And I would like to request Dr. Shobha Chaku, madam, and Dr. Ram Kumar, sir, please. Dr. Ram Kumar, sir. Okay. So, can I honor to request our Dr. Shakti Das, sir, to please come on there and felicitate. Thank you, sir, for giving me this opportunity to invite you. Shakti sir was my teacher also during my graduation. Thank you, sir. Thank you, madam. Now, may I request Dr. Amitabh Trivedi, sir, to please come on the dais. And I would like to request our Honorable President, Dr. Pankaj Bajpayee, sir, and Dr. Lakshman, sir, to please come felicitate them. Thank you, sir. Now, I would like to request Dr. M. Ramakrishnan to please come on the dais. And I would like to request our Dr. Kamal Narayan Arya and Dr. Ajit sir, please, to kindly felicitate Dr. M. Ramakrishnan. Certificate, madam. Madam, please kindly hand over the certificates also. Now, may I request Dr. Anand to please come on the dais. And I would like to request our Dr. Haldas sir and Dr. Muhammad Yusuf sir to please felicitate him. Dr. Anand Sharma, please. Dr. Yusuf. Dr. Muhammad Yusuf. Okay. So, if no, can I have this honor to felicitate our Dr. Anand Kumar? And Haldas sir is there? No. Doctor. So thank you, sir. Thank you all our resource person for contributing to our webinar. We hope the similar response, and we should be more participants, more budding professionals to contribute to attend and participate as a resource person also, so that we have to increase our Zoom platform. Presently, the Zoom platform capacity is 100, but we will increase it further. Thank you. Thank you, madam. May I request Vedya madam to please come on here? Her certificate is here with Shalja madam. Please. Madam, please.
Double the markup.
Thank you, madam. Done, ma'am. Thank you, ma'am.
Thank you. Sorry, ma'am. Sir, ma'am.
Now we will. Now we will move on to next scientific session 3. Respected chairpersons, esteemed dignitaries, honorable delegates, and enthusiastic students, good morning to one and all. It is my privilege to welcome you to this scientific session at Oticon 2026, centered on the thought-provoking theme Rewriting Ability, Neuroscience-Driven Insights in Motor, Cognitive, and Functional Recovery. It is not merely a scientific theme, it is a celebration of the brain's extraordinary capacity to heal, adapt, and transform. This theme emphasizes how advancement in neuroscience are reshaping our understanding of recovery by highlighting neuroplasticity, motor relearning, and cognitive integration. It honors the journey from impairment to independence, where neuroscience meets human resilience and purposeful occupation. Before we commence the session, it is my honor to introduce our eminent chairpersons who will guide and enrich today's scientific deliberations. It is our privilege to introduce Dr. Professor Surendra Kumar Meena Sir, Dean, Faculty of Physiotherapy and Occupational Therapy, Vivekanand Global University, Jaipur. He holds a PhD in Occupational Therapy with advanced qualification in hand therapy and pediatrics. He is an active member of professional councils, a recipient of several prestigious awards, an organizer of national conferences, and a national trainer for Special Olympics Bharat with expertise in geriatric care, education, and research. Respected sir, I kindly request you to come to the dais and take your seat. Joining him is Dr. Professor Amitav Kishore Dwivedi Sir, Professor and Dean at JSS Faculty of Occupational Therapy, JSS Academy of Higher Education and Research, Mysuru. He is recognized as the first PhD in the Faculty of Occupational Therapy in India and a recipient of national and international honors, including the IOTA Professional Excellence Award. He is a fellow of the Academic Council of Occupational Therapy and has served as an external expert on BOS of leading universities. His contributions include authorship, research publication, and key leadership roles with IOTA, IJOT, and international academic platforms. Respected sir, may I request you to kindly come to the dais and be seated. As we move forward with today's scientific deliberation, this session begins with a thought-provoking guest talk. We are privileged to have with us Dr. Harris Manova Thanaraj Sir, Occupational Therapy Specialist and Clinical Lead, Non-Invasive Deep Brain Stimulation, Department of Occupational Therapy, Qatar Rehabilitation Institute, Hamad Medical Corporation. We request him to kindly share his insights on the topic deep brain stimulation within occupational therapy, which will provide valuable insight into this topic. Please, sir.
you submit? Is it
Yeah.
you, I think?
No, it's here.
No, I think. No, no, sir.
They put it in.
So, do you have pen drive which has your presentation? It is our presentation, not all. Sorry, no, he said it. No, so the pen drive. So this one, right?
Yeah.
Yes. Oh, screen. Oh, call this. Call. Screen call.
Good morning. It's my honor to be here. I need to greet my seniors and the president and IOTA board members and the secretary and the chairperson who are presiding over here. I have to start thanking first because it's a history. Like when I studied, I knew people from distant place came and taught us. To fulfill the gratitude, I came all the way to their place, and I want to thank them. And that is their. This is the place where my teachers came from, and they're here, Sujata Mishal and Ranjita Pandey, and my colleagues who are here, and my students also. I'm very thankful for that. And with that, we jump in. This presentation, I'll just give a prologue. This is like, it's good for developers, for the academicians and the students, because it's a tool, it's an administrative lead. For the an academician, it's a new scope field to work around. So my talk is on deep brain, non-invasive deep brain stimulation within the scope of OT practice. Though it's a very new concept on the dais, but it has been there since a century in an invariable form, and it has been to practice since 1985 somewhere. So my lesson NBAS is like latest evidence integration with functional therapy protocol. So that's my work on with some case studies there. So non-invasive deep brain stimulation in OT. It's a technology that applies electrical or a magnetic current on a scalp. Like you have a car and the battery goes off, you jump start and you make it functional. So likewise, without making the brain functional, jump starting the neurons, I think whatever we do, it goes insane. So we've been doing stimulation, which is a primordial, and we've been doing a lot of other stuff and functional training, FES, all sorts of stuff. But we have to do initial kickstart or jump start. So that's my key domain on there. So I have a lot of on the page, but I'm not going to go on complete there. Sorry, jumped on. So we have 3 modalities which I picked in, which are in the kickstarters for the brain or jump starters in the brain. So TMS, which works on the magnetic pole, and TCDS and ACS, which works on the current. One is a direct current, one is the alternating current. So we have the scope on there, like on the portability and the evidence and high focability. So the mechanism of action is the current is being given to the neural cells and you jumpstart. So it's a spatial and temporal mechanism there. And TDS, there is direct current, which alters the membrane potential. This is like, you do excitability in cathodal way. And then another one is like it is on the gamma stimulation. So you use a gamma inducement there. So that is where we use an alternating current. So they are mentioned with the quantifiable data delivery there. So we skip to the next one. So these induce in are we going in the right track with the core principle of neuroplasticity? Yes. The Hebbian learning model has been addressed. Long-term potentiation is addressed by like strengthening the synapses. State dependency is also established, and a metaplasticity is also established by priming, which is what a OT can do as a therapist along with the device. So it's like we can say TMS, we can say TCDS, all is good, but without like confounding factor, without an application, we cannot do insights like decisive role. So that's where TMS stands in cortical excitability. TDS stands on membrane potentialization, polarization. So that's a rough picture on there. So are they evidence-based? Yes. If you see the bar chart, TMS, it's around like, what transfers is TMS and OT combination has a high evidence, then followed by TMS and TCDS, and TAS is still in the prime state for creating evidence. So TMS works like, radial gain suggests, but high heterogeneity across studies, we see this one. And there are like 4 RCTs with like deep brain stimulation combined with OT, which gives a high evidence. And TAS and motor learning, because that's a gamma way we stimulate the gamma waves, which primes in retention of task. That's a key thing which TA is doing, and it's still under a like study plan, and it has strong for potential for dexterity training, maybe writing, learning. So these are, I'll just do 3 protocols which we use it in day-to-day life in the OT sector. And prior to that, I have to thank Abu and Wakura, who has been pioneer in the same TMS application in occupation therapy from the School of Occupation Therapy, Tokyo. And they have given these protocols for occupation therapy. So nothing is left vain without a therapist intervention. If you see all these protocols are there on the top, on the bottom, you need to have a session integrated, like, priming TMS, you need to have an OT training. So you have to have a protocol, functional training protocol for immediately after the TMS. So here the TMS use a magnetic stimulator that is 3 Tesla coil. So we have we'll deal with the protection stuff later. So the equipments are listed on that bottom. We need for safety side, we need an RRT emergency response cart in case if you need, in case any emergency requirements. But the area for stimulation, you see the ipsilateral excitatory and the contralateral inhibitory, that is in strokes. For Parkinsonism, we use a supplementary motor area, M1 bilateral. So this is a cortical target, and the frequencies are like 10, 20 is for excitatory, and below 1 hertz is for inhibitory. So this is the protocol detail for TMS, and any more detail we can discuss personal. And TCDS is a direct current, which is being used for it's a cathedral current. It is on the contralateral supraorbital area. It can be if it is bihemispherically, it is an ipsilateral on M1 cathode, or contralateral in M1 cathode. That's bihemispherically. So it is like a current is diluted 1 to 2 milliamps, and its duration is 20. And it is, again, the beauty of this is it can be sync during therapy. So it is a small, versatile, portable device. So it's work on direct current. So you have some safety considerations. If there is an impedance issues, if you have a helmet, you have thick skull, we have some issues. That's called impedance, which is above 5 to 10 ohms. For TAS, it's still a young entity inside, so which is using the gamma, which is 70 hertz online. So this is it's a sinusoidal wave, which is used in for the enhancing the motor learning and cognitive motor integration during activity tasks. This is again a portable device, which is very useful when you do with a function. That was the protocol. And for all these things, do we do assessment? Yes. As an OT, we don't skip out. So we use the diagnostic verification, functional goal established by the IMU sensors or optical sensor. and EEG monitoring, contralateral reviews like seizure risk, mental implants in pregnancy, and functional like measures. We can use Fugel-Meyer, ART, and nine-hole peg test. This can be with the technology in pursue, we can use IMU or optical sensor to gain these data, so we don't spend time on that. And cognitive safety, we use MoCA AI, which should be above 20, and trial marking test AB. So these are tests which is done for performing prior and post. There are contraindications for these applications. There's an absolute contraindication where it should be no, and there's relative contraindication precautions which we can validate at the time where we want to do. And TCS and TDS, there's TES is transcranial electrical stimulation, under which TDS and TAS comes in. So it's about check of skin integrity. Those are elements which you need to do. And there are documentations which we need to priorly check, safety records, informed consents, device model, risk discussions to the documentations. All these things should be done. So this treatment protocol lies on like intensive phase, progressive phase. That's 1 to 4 weeks is an intensive phase. Then it goes to progression phase on 4 to 8 weeks. Then mid and post evaluation, and maintenance phase 10 to 12 weeks. So this is like a 20 to 30 minutes priming, and task training 45 minutes, and cool down period 10 minutes. So if you're a clinician who wants to do a billing, you need to see 20 plus 60, roughly around 1.5 hour. A process billing should be done. And if you're planning a treatment, it should be in this way, or else you won't get good efficacy in getting the management done. So integrating with the deep brain stimulation, so you would with OT, like the why we do, it's like a priming effect. When we do a cortical excitability and just leave them, and we think that it is good and it is doing wonders. Last 5 years in clinician used to do that, but the results were dampened up because there is no functional post. So then they found, well, with Abu and Bakura, with their detailing from the Tokyo University, spread across that we need OT follow-ups. And then functional training such as like handwriting, self-feeding, and staking, buttoning, mirror therapy, and manipulation tools, and even cognitive motor integration. The deep brain stimulation with OT improved, and it is really giving a promising result. So this is again the motor learning principle with it is like a state dependency on timing. It should be specific, and intensity should be like say 200 to 400 repetition, and silence is like meaningful for the patient, and spacing. It should not be given today, next day. Like some patients say, sir, we give for can you give within 1 week all the session? No, don't do that, because brain needs some cooling period. So that's important. That's called spacing. So the clinical pearl is like neuroplasticity is double-edged sword. Avoiding reinforcing the compensatory pattern during the heightened plasticity window creates the deep brain stimulation created by deep brain stimulation. Focus on quality of movement. That's a key message on. So whatever we said, it's nothing. This is the main message on here. So I have 3 patients. I'll just take one patient in line. So we have one patient X, I don't want to mention, is 64-year-old and ischemic MCA stroke, post-time onset, 10 weeks subacute, right upper extremity weakness. So we did a baseline assessment of Fugel-Meyer 28 by 66, ART 1557, and 9-hole peg test when unable to do, and MBA is 65 by 100. No, I think I'll just turn. Thank you. Sorry for that. So we have the, for this client, we have functional goal to improve active reach, grasp pattern for self-feeding and adapted utensils, enable bimanual support for light and light meal preparation, reduce caregiver assistance for upper body dressing for MOD A and minimal, moderate to minimal. So the baseline assessment, we did this one, and treatment plan with the, not the, like with the TMS, we did an RTMS here, and primed with the task-specific training, 5 weeks and 4 weeks, like in for five sessions and 4 weeks duration and 20 sessions in total. So this is an outcome for the first client. So what we see is like, there is a, like, from the 9-hole peg test, unable to 120 seconds. Usually for the 62 years old, you should have a peg hole second should be around 34, 35, but there's an improvement ratio in 4th week. ART, there's a subjective measure, like there's a quantum jump in, and Fugel Myers also there is a change in. So this is like, what is the statement? Okay, these are all our statement. What is the patient's statement? I can finally hold a fork without dropping it halfway to my mouth. This is OT. This is where we stand for. What the machine is doing, that's different, but this is what we want to get a result. So we have, we can see that, and I would skip if the time, like due to time. Their cognitive client is also there, and then we have done that, and Parkinsonism we have done. So they are the outcomes. So we have worked on certain areas like pediatric CP and gait balance, which we say gait balance is an entity of another core profession, but gait is a very prime component of an OT because we do ADL. When we want to do a dressing, we want to reach cupboards. There is a gait which is not said as the gait. It's a different component of gait. Spasticity and pain management, TCDS and RMS has been a key thing, and language and communication, which is actually a new dimension for, like we use TPS, which I'm not mentioned. TPS stands for transcranial pulse stimulation, and that has even a higher pitch, and it is still budding in the European segment, and still we didn't have wider article citation. That's why I didn't pull down here. So these are safety considerations which we need to definitely look. If you any instrumentations when you induct in new, we have to be at the epitome of safety, which should be prioritized. So common side effects and rare serious events are there. So people ask, do we have side effects? Yes, there are some side effects. How to mitigate? That is the important thing. So you have the risk mitigation strategies on the corner on the right bottom. An emergency response plan should be always there in your cart. So when we always do a monitoring protocol during a treatment. That is pre-session checklist, post-session assessment, intra-sessional monitoring, and program level tracking. Program level tracking is not the one session, 20 sessions is done. We do program tracking post maybe 2-3 years, how the patient responded, and we document like is there subjective changes post effect. So is there a plateau, is there a ceiling, and does it really improve in the functional efficacy even after 5 years? This is a program tracking, so which is widely accepted in the clinical domain. So these are this is a take for a budding clinicians who is going to start up practicing private. So space requirements are like 10 to 12 feet if you have one equipment. It's all based on one equipment. And accessories, you need some like supplies which we need to do day to day, and they are here: head caps, rubber electrodes, and AED devices. And device specification, TMS in case if it's a figure of 8 coil is more. And if you want for like a AI or automated, it is a bit expensive, but you can do an automated delivery of TMS also, which is currently available last 6 months. And TCDS is like very portable, that I would advise the young clinicians who are starting up can do. Don't go beyond, it's written 2-4, you go within 1 to 2, it's more convenient for us. And you should do a ramping on there. And cost consideration without having a communication with the vendors or manufacturers. These are listed on the article. So we have 30K, it's all in dollars, and we have the least one is in 5K. So this is a small review on how you can use in a clinical per se. So training requirement, yes, any of the devices which we induct in practice, which is new, that's where the technology, today's technology is tomorrow's tradition. So we are going tradition to technology. So this would be one day become a traditional technology, I wish. So foundation knowledge should be there on TMS and technical skills on the device and clinical integration such as functional task and stimulation with the motor practice and documentation and billing. All the measures should be taken in there. And this should go, which is international governance body of the neurophysiology. So we need to, so I have, we put the documentation parameters. It should be in this direction, like informed consent, safety screening tool, motor thresholds, parameters, and concurrent OT activities and functional outcome. And you have a subjective report, skin integrity, and billing coding. So all these things are to be, we need to practice whether we are west or east. We should start these things even in here. And I know that it's been practiced in many of the institutions. So future directions with this one, the direction of choosing these TCDS or TMS, we've been doing something like an OT practice. We want to deliver such a way that if you have an MCA right, which has 10%, and it should be, we should have say, not do passive 10 times, 20 times. For them, maybe 2 times is required. So likewise, we should have a precision medicine and personalification of your treatment with the deep brain stimulator. So for that, like once you say MCA 5%, we will definitely optimize dosage to 1 and 2000 milliseconds. Like that we can work around. So there are novel technologies for the future direction, like high definition multi-electrode array focal targeting, temporal interference deep brain stimulation, focused pulse ultrasound. We had an opportunity of using the FPS also. With that, I would like to have a small, with the client. I had a client with because when you do a parietal deep stimulation, the TMS TES will go up till 3 centimeter, but TPS goes to 8 centimeters, so it can reach even the cingulate part of brain. So we had a client, ex-client, who had a TBI with the social disinhibition in memory. 20% of the times that is the memory occurring in the day, in a day. We went on a session with the TPS to deeply stimulate, and which was like a 20 and front parietal area. So this patient, within 18th session, the family, the spouse came and said, my husband is now without disinhibition, he's not showing any disinhibiting features. And I didn't do an assessment. I did an initial, then I want to do after 2 sessions. But in between, she gave this comment, and I didn't stop with that. I did a 32 channel EEG assessment, and I found that his memory regions were mapped in accordance with what spouse said, and that is a confirmatory assessment. We can do other tests, but we have to have a gold standard line. So take key takeaway message in clinical pulses like priming neuroplasticity and like modality selection, what you need to do, and rigor, safety, and systematic implementation. So ultimate clinical pearl is brain learns what it practice. Deep brain stimulation simply ensures the brain is listening. That's all. Whatever I said about deep brain stimulation is like we make the brain listen. That's the key message. But what comes after is like combining the precise stimulation with meaningful occupational-based activity translates the neural firing to the real world. It's like you use VR, all stars are there, but you need to do the neural firing. That is the real world. That is what OT as a profession gives to the world. And I thank that I'm an autist, and you are all my fraternities, and you will do a great job on that. So these are the references on this side, and the clinical toolkits which are met on there, which is the equipment toolkit and the practical guidelines and the OT toolkits we can use there. I thank, and I've complete my session on that, and this is a simple message for you. If any questions, I'm glad to take it. Thank you.
Thank you, sir, for this insightful session. Now, may I call um, our respected chairperson, Dr. Surendra Kumar Meena, sir, and Dr. Amitabh Kishore Dwivedi, sir, to felicitate our respected Dr. Haris Manova, sir. Sir, please come on the dais. Thank you, sir. It is our privilege to begin this session with the enriching guest talk on recent advances in surgical management of radial club hand and its occupational therapy perspective by Dr. Sakti Prasad Das, MS Orthopedic, DNB Rehab, FCGP, LLB, Fellow in Pediatric Orthopedics, and Board of Director, Medical Education and Training, Dreams University, Odisha. Please, sir.
Thank you very much for inviting me. I thank the organizers of the Oticon for inviting me for this annual conference and this opportunity. Again, thank you very much. I will speak on recent advance in surgical management of radial club hand and its occupational therapy perspectives. Actually, I will focus on our occupational therapy perspectives. But if you see any rehabilitation case we come across in various national institutes, if you see, I always teach also to students. If you remember all the 4 departments, when you write the management answer, your everything is complete. You should look at the medical, look at the physiotherapy department, occupational therapy department, and orthotics department. Your answer is complete if you answer for the management. Cause and everything you can mug up from the book. Anyhow, I will proceed to my talk because this is a very rare case, congenital case you find across. This is our institute where we are working now, the Dreams University. We have also got a school of physiotherapy and occupational therapy. We are working there. And I am very happy that those who are leaders here, I have worked with them, Dr. Bajpayee, Anurupa, and Pragya. I have worked with them. And my work is also, whatever I will present, mostly from the Nirtar. I have worked also with NILD at Dr. Bajpayee as an administrator. We have done good work during that 1.5 years. Thank you very much. Again, still I am working with Dr. Durga at Dreams University. Actually, this work started in 1995. This is around 413 hands history. If some of these faculties, those who are present, they may be knowing Dr. Santosh Rath, working as a hand surgeon there when I joined in 1995. My interest goes from that time during this managing radial club hand. At that time, lot of cases of radial club hand are coming to our institute. So later on, he became the president of the Indian Society of Surgery of the Hand, still working in Orissa. I will also speak about Dr. Johari, who is a pediatric orthopedist in Mumbai, with whom I am a mentor and also my friend and advisor also. Many times I have worked with him. I will also remember one person, Dr. Ganesh, who is in Lucknow. I think he's a little bit unwell, but I have worked with him and many things I have learned, and also we have published many papers with his help regarding all the many things, statistics and everything. So let us go to the topic. The radial claw band is a congenital anomaly of the upper extremity characterized by various degrees of hand and forearm deformities, ranging from mild radial hypoplasia, maybe small radius, to complete absence of the radius. Diagnostic possibility, many hand looks like that also. So we have to, when you see a hand, don't think that it's a radial claw hand, maybe ulnar claw hand. Sometimes you find children with osteomyelitis radius, the radius is lost by, absorbed by the infection. So they also look like that. Exhaust ulna, same type. Mid-lung deformity was a deformity. These three many times complicates the radial claw hand. So before diagnosing the radial claw hand, these possibilities are there. Associated syndrome, there are some life-threatening conditions also with associated with. One is Holt arm syndrome, in which there is heart and limb problems, anemia, thrombocytopenia, absent syndrome, and maybe with some vertebral defects, anal atresia, cardiac defects, tracheoesophageal, esophageal problems, kidney problems, and limb anomaly. These are many associated with many complications. Once diagnosed means there may be some of the other congenital problems will be there. So if you see 7038, the Petit first described the radial hand in autopsy. They found out that if untreated, there is a limitation of prehension. Dr. Lamb found bilateral involvement. If there is a bilateral, it reduces the activity by 1/3. Ulnar length at birth is known to 50 to 70% of the normal ulna. Ulna may finally be shortened by 40% normal length. So general agreement favoring surgical correction at 3 to 6 months age is practiced. Epidemiology 1 in 1 lakh. Hypoplasia of the radius. You'll say radial deviation because radius is not there, so no doubt it will be radial deviated. Thumb, because it is axis, longitudinal axis, so thumb may be absent, may be rudimentary, may be absent, and may be bilateral. So these are the examples, these are the cases we are thinking. See the radius, these are, the cases may be rare, but in National Institute they are not rare. They are adequate for us. So these are the cases. See, here there is no thumb. Here there is some thumb is there, even syndactyly. Here this thumb which is rudimentary. These are the cases we have discussed today. Bilateral, see bilateral also not uncommon. Bilateral. See the anomalies, sometimes operated during some problems, femur problem, cleft lip, associated with the club foot, cleft lip again. So many may be associated with many of the congenital anomalies, this absent radius. Thumb, again I have discussed thumb. Thumb, you see in a hand there is absent radius, but thumb is normal. But in some cases thumb is rudimentary, it is not useless, it sometimes needs amputation. Some cases thumb is normal. So these are the examples. Extent of deformity is important. How much is deformity? Maybe very minimum, you can say minimum deformity, or minimum or very severe deformity. Nobody knows. All are different. So classified by Bain and Cook, various types, how much deficiency. Sometimes very only deficiency radial epiphysis growth plate, distal and proximal radial epiphysis growth plate, partial aplasia or total aplasia. So maybe small to total absent, the entire range. So many classifications. James Fernandez from India, who worked in England also, he has also his own classification, little bit modifications. Heikel, very simple classification, the Heikel classification we follow. Congenital, little bit shortening, more shortening, and total absence. These are the various types, easy to remember. There is a global classification also. Those who consider thumb, corpus, distal radius, and proximal radius, all takes into one because this is a longitudinal axis. So these are also one of the global classification for the Manske in 1995. So X-ray, short radius, hypoplastic, partial, we have to assess how much of the radius is present. Depending upon that, we need the management. So here also see radius is small, radius is more smaller, radius little bit small, here radius is totally small, no radius. Here radius is present, here there is no radius. So these are the cases. So these radiologically you have to assess the severity, hand forearm angle, hand forearm position, and also ulnar bow. So these are the various you have to assess. Anywhere any result you want to and produce a result. So naturally you need some your assessment, how to assess pre-operatively, post-operatively. This angle, radiological angles helps us to that there is improvement or not. So this is the severity again. You see the minimum deformity and see the wrist, how, where is the wrist. Expression of concern. I have taken the permission. Normally, we don't show the face of any patient or my mother, but I see I have taken permission from these patients. You have to show the face. They see the face of concern. They don't know because in our time, I don't know now, 10, 15 years back, only if the mothers feel that the family feels that only the mother is responsible. So see the face of how they are worried. What is the future? They don't know. So that is the concern. This is one of anybody remembers this is a staff from the SB Nirta, those working. See the to comparison when somebody becomes adult, you see the harm and how it becomes if you don't treat. Goal: correct and maintain the wrist deformity. We want wrist-like mobility and maximum forearm length. You know why you need it. I don't have to describe it. So cosmetic necessary, stability, mobility, as well as some functional status. Management, no doubt, very, very mild cases, casting, and Lamb compared surgical with non-surgical, and he found out that improvement surgically by appearance and function, including improved alignment, range of movement, and strength. Team approach of occupational therapy is part of the team, is part of the multidisciplinary team working with orthopedic surgeons and physical therapists to address both the functional challenges and potential cosmetic concerns for radial club hand from infancy through childhood. So goals: increase wrist and finger mobility, strength and coordination. You teach compensatory strategies for limited hand function, improve ability to grasp, manipulate objects. This is very specific to your subjects, so I don't want to go in detail. You know all the stages of it, and perform self-care. Maximize overall functional capability and independence. So intervention is mild case, stretching and exercises. Splinting and casting your role. Splinting is very much important. Pre-operatively, post-operatively, mild cases, moderate cases, severe cases, everywhere you need a splinting. And functional training. Adaptive equipment, pre and post-surgery support. These are important key occupational therapy interventions. Strategy. Physical therapy and occupational therapy are upon the main treatments of mild cases. If case is mild, severe, not minimum radius is absent, only therapy splinting. Exercise starts soon after the birth and focus on stretching and gently aligning the bones in the hand and arm, which can help correct the hand difference without surgery. Demonstrate exercise and teach parents. We have to teach the parents how to do it because all patients or attendants or mother, they cannot stay in the hospital. So we have to teach them. So you have to teach them the exercises and how to do at home. And severe club hand may receive these therapies before and after surgery. Physical therapy can also improve hand, wrist, and elbow movement. Occupational therapy can help children with limited hand function learn how to complete daily tasks such as getting dressed and activity of daily living. Suppose very specific for OT, maximizing hand function through exercises, splinting, and adaptive strategies. Alongside physiotherapy and surgery to improve wrist and finger mobility, strength, and ability to perform daily tasks. Custom splints, positioning, teaching exercises. Work with the families, providing stretches, guides, splint wear, etc. And personalized plans also for the patient because we have to, in rehabilitation, we have to know the person, know the family, know the finance status. Everything depends upon how you take a decision to manage that patient. So splint cast, these are part of your study. So how to wear a splint, what is the, how to make a splint, in what stage, it is a corrective stitch or it is slowly correct. You have to take a decision seeing the cases. So these are the wrist initial casting followed by splints. Surgery, little bit about surgery. Many surgery have been described slowly, ulnarization, dentalization, carpal notch. There's many surgeries are described. How to aim is make the limb straight, cosmetically acceptable, functionally good, and also to achieve the maximum strength without any deformity. So procedures are centralization, radialization, all the three procedures described in the history. Last 30 of 95 to till today, this first procedure, second procedure, third procedure. Pre-centralization sometimes very rigid, it cannot come to its, we cannot, even if stretching we cannot do, so you need release and distraction. So in the initial phase, sometimes you go on distracting the hand to the, because it has to reach the top of the, or in the end of the radius, so that it can, you can centralize by some means to keep it here. Otherwise it will go back. So initial stages, if you don't succeed by various types of exercise stretching, we can do this type of distraction to reach, then followed by centralization. So centralization, traditional treatment may be distraction and centralization both. So centralization is important. How to do centralize means you have to keep the entire hand in the front of the wrist or in the tip of the lower end of the radius. So that is another method, radialization. Some people thought that pass the radius towards the ulnar side. Pass the ulnar towards the radial side. That is radialization. Again, it has got its complications. I don't want to tell details about all these things. But centralization needs various types of flaps and other things to centralize it. It has got problems, complications, but this needs some and once it comes to the front, centralization, if ulna is long, we cut it and make it straight so that it will be on the line of the wrist joint. So maybe radius is absent, but the wrist will be, see, slowly also this ulna becomes broad and it acts as a wrist joint like a lower end of the radius and functionally. And lateral we can do the ulna lengthening also to reach, to improve the length of the. Polysization important. Many cases there is no thumb. So your second finger, index finger, we have to make it a polysization thumb, so that they can, because you know, I don't have to tell you about what is the function of the thumb. So index, you have to make it a thumb so that you can get a good movement or good work. Function can be improved. So if there is no thumb, don't worry, polysization can be done. So followed by various types of splints. Hand therapy, this is a very, very important aspect of the because once you operate, to improve these children, you need all this. This is exactly your subject, how you train them, you assess them, and you train them so that they can do their functions better. These are all post-op cases. This is a bilateral case. This is a unilateral case. They are under training. You see, this is it. So I don't want to tell this. You are experts of this. So once you correct, then no doubt you get some deformity corrected, you get some functions. So every these are all central radiation. It has got complications. Recurrence may be there in some cases. We have to again correct it or splint anything. You have to manage the complications. So many complications also there we come across. Ulnar lengthening can be done to improve the length of the forearm. Radial lengthening can be done once it is there. Once somebody there is no wrist joint, some people transport the metatarsophalangeal joints of the foot to make a wrist joint so that you can have a function of the wrist joint. Pale, that is the latest one. The drawer Pale is a person from USA who does a lot of deformity correction throughout the world. He is an Israeli settled in the USA. So he has his own technique. He told that this ulna, you translocate the ulna towards this side, so that there is a deforming force will be not there. It will be deformity force this direction. There is no recurrence, and there will be good function and mobility and length can be maintained. So this is the last moment when we tried in, I think around 2008 we started in Nirtar. So this palace with lack of fulcrum, forearm shortening, excessive palmar flexion. So means there is this latest method is to do the there will be no complications. This is the, in one stage we have to you have to open it. This is the lower end of the ulna. All the vessels are visible. Flexors on the anterior volar aspect, extension of the dorsal aspect. You pass the ulna towards the radial side. That is the surgery. So this is the lower end radius. You pass this radius ulna, lower end ulna to this side, so that there will be stability and mobility. This is the hand. After the surgery, then closure, see the deformity is corrected, no recurrence. So these are the pre-op. Here ulna is here. Here you see there on radius side is the ulna. So good length and as well as function. This is another case, pre-op, post-op. After the correction, these are the cases after the correction of the same Palace, under Palace principle we started. Bilateral hand, we found good functional, no recurrence. Most important is no recurrence and good mobility. These are the two important things. They can write, they can use their buttoning and unbuttoning. Complications also sometimes helps us in life. See, there is some, once you transport the ulna, but due to some infection, ulna becomes wide. So ulna become wide means wrist become very stable. Here also same thing. Ulna is also some periosteum passed and it become two and it get a good stability wrist. So sometimes complications also help is to stabilize the hand. So conclusion, it is a new technique, acceptable long-term result, risk of recurrence of radial deviation less, functional improvements, needs comparison with other methods. This paper presents a longitudinal study comprising outcomes from radialization we started, centralization and ulnarization of 3 decades. Again, story does not end here. Research continued, as some of you know, also seniors must be knowing, that the hexapod has come into the field which can correct in various angles. So hexapod research continues. Ilizaro and hexapod, they can do own donors, no doubt. Your role will be same, remember. So thank you very much. For that, I got this Henry Bensal Award in SICOT, is a national international conference. From that, I learned that if you work in a small place also, if you work in a small place, if you work very specifically, think about the subject very specifically, you may be a rural area, but the world one day will recognize you. That is my message today, after 30 years working in this case, getting the result. So there is no, you have to do hard work to reach the your goal. So thank you very much, sir. Thank you very much for giving us the opportunity. Thank you all the dignitaries and executives of the Oticon and Occupational Therapy. Thank you, sir.
Thank you, sir, for this enlightening session. Now, may I request Dr. Surendra Kumar Meena, sir, and Dr. Amitabh Kishore Dwivedi, sir, to come forward and felicitate Dr. Sakti Prasad Das, sir. Thank you, sir. At this juncture, may I respectfully hand over the microphone to our honorable chairpersons to lead the session further.
Good morning, all. So now after faculty talk, we are moving forward for the competitive papers, and we have 6 papers in this competitive category. I would like to invite Sneha Panda. Her title, the topic of the paper is Effectiveness of Graded Chair Height Reduction Training to Improve Floor to Stand Ability in Stroke Survivor. You please start.
Good afternoon,
Yeah,
everyone.
Okay. I'm very sure that judges are there and they are doing the scoring. All the best.
Good afternoon, everyone. Today I'm going to present the topic Effectiveness of Graded Chair Height Reduction Training to Improve Floor to Stand Ability in Stroke Survivors. So coming to the introduction, stroke commonly results in long-lasting deficits in strength, balance, and coordinated movement, which significantly limits a person's ability to perform activities of daily living. One functional challenge that remains particularly difficult for many stroke survivors is rising from the floor. And this is very important in Indian context because it is related to many culturally significant activities such as praying, eating, social interaction, and household tasks, which are traditionally performed at a floor level. When stroke survivors are unable to rise independently from the floor, their participation in this essential and meaningful activities becomes restricted, affecting overall independence and quality of life. Now, this leads me to the rationale of the study that conventional rehabilitation frequently relies on sit to stand practice from a standard chair height to improve lower limb function and transitional mobility. Although this approach strengthens the lower limbs and enhances general mobility, the movement pattern practiced from a standard chair does not fully represent the demands of a floor to stand transitions. The movement from flow requires a much larger range of motion at the hip, knees, greater postural control, and increased effort to shift the body weight through progressively lower positions. Graded sit to stand training, achieved by systematically reducing the chair height over time, offers a practical method to bridge this gap. This gradual reduction in height allows survivor to safely explore lower transitional positions, improve the limb loading, strengthen anti-gravity muscles, and build the confidence needed to attempt floor to stand movements. Coming to the methodology of the study, the research design is a pre-test and post-test type of study, and the convenient sampling technique was used to gather a total participants of 24. The independent variable used in my study was graded chair height reduction training, and the dependent variable was floor to stand ability as measured by using the sitting rising test. The inclusion criteria for my study included first ever unilateral stroke, stroke duration greater than of 6 months, MMSE score above 24, and ability to stand independently without any physical assistance for a minimum of 2 minutes. The exclusion criteria for my study included severe cognitive, perceptual, or visual deficit, hemi-neglect or significant proprioceptive loss, musculoskeletal impairments that restricted the lower limb movement, and comorbid conditions such as cardiac or respiratory instability. The screening tool which I used for my study was MMSE, and the outcome measure was sitting rising test. So sitting rising test is a 10-pointed scoring where 5 points are given when a patient attempts to sit on the floor from a standing position, and another 5 point is given when the patient attempts to rise from the floor. So we start the score with 5 and we go on reducing 1 point each time the patient uses hand, forearm, knee or side of the leg used, and minus 0.5 when there is a loss of balance. The same grows when the patient attempts to rise from the floor. The procedure of the study, patients were screened for eligibility according to the inclusion and exclusion criteria. This led me to the total participant size of 24. Informed consent was obtained from each patient, and SRT was administered before the 5 weeks intervention. After intervention, SRT was administered and data analyzed using the pair-T test. Coming to the intervention, the duration of my study was 5 weeks, where 45-minute sessions were given per day, and the session was divided into 15 minutes performed 3 times daily. My study had 4 grades. In the grade 1, the patient attempted sit to stand from a standard chair height, where the height differed from 45 to 50 centimeter. In the second stage, we went to low stool, where the surface height was 35 centimeter. Then we went to the mat surface, where the surface height was 20 centimeter. Then we went to squat to stand. The key point to note was the patient performed modified sit to stand, as we can see in the picture, where the paretic limb or the affected limb was placed posterior to the unaffected limb while the patient performed sit to stand. This is a study taken from a paper where it is mentioning that when paretic limb is posteriorly is placed, then the limb loading is better on the affected limb. Now, the criteria from going from stage 1 or grade 1 to grade 2 of the study is when the patient is able to do independently in standard chair. I've used low stool, and the patient performed modified sit to stand independently in the low stool. I went to the mat surface and so on. Coming to the data analysis, first the descriptive statistics in the gender distribution table. Out of 24 total participants, male participants were 18, leading to the 75% of my population being male, and 6 participants, that is 25% of my population, being female. Now coming to the age distribution, the minimum age of participant was 25 and one of the maximum age was 65, leading to mean age of the participant being 45.8 plus or minus 9.86. Now coming to the inferential statistics, the p-value of the study was less than 0.05, which meant the study was statistically significant. And in the pre-test, as we can see in the chart, the minimum score was 2 and the maximum score was 5, which led to the mean of the SRT score before intervention being 3.25 plus or minus 1.0. And in the post-test, that is after 5 weeks of intervention, the minimum score attained by a person was 7 and the maximum score attained was 9. This led to a mean score of 7.88 plus or minus 0.85. Now, this is a chart showing individual progress in a pre and post test. So let's take an example that one patient had a score of 4 before the 5-week of intervention. He reached a score of 9 or 8 after the intervention. Now coming to the gender-wise performance summary, the rate of improvement on average, female participants showed a slightly higher improvement compared to the male participants. However, this difference in gain was not statistically significant. This leads me to the discussion. The findings of the present study demonstrate that graded chair height reduction training leads to a marked improvement in floor to stand ability among stroke survivors, as reflected by the significant increase in the SRT scores. This improvement suggests that progressively practicing transitions from increasingly lower heights can effectively enhance the neuromuscular and postural demands required for floor level mobility. Importantly, this approach addresses a critical gap in traditional rehabilitation, which often overlooks the cultural relevance of floor level functioning in an Indian context. This study assumed a uniform standard height for all participants without accounting for individual anthropometric differences. There were certain limitations, that is, the sample size was small and there was a single group pre and post design without a control group. So, the future recommendations are future studies may examine the effectiveness of intervention separately in individuals with a recent stroke and those with chronic stroke to determine whether the timing of the stroke influences functional outcome related to floor level mobility, and comparative designs where a control group and an experimental group can be taken. Concludingly, graded chair height reduction training is a practical, low-cost, and culturally appropriate intervention that significantly improves floor to stand ability in stroke survivors. The method enhances independence, promotes participation in culturally important daily tasks, and can be integrated easily into routine rehabilitations. These are my references. Thank you.
Judge, please note that she have taken 9 minutes. And I'm very sure that all the presenters, knowing there is a watch over there near podium, left side, and I will request them to keep an eye on that to stick with the time. Thank you very much. Okay. The second presenter is Divya Pandey, and her topic is correlation between unilateral spatial neglect and motor recovery, balance and functional outcome in a stroke survivor.
Good afternoon, everyone. My study topic is correlation between the unilateral spatial neglect with motor recovery, balance, and the functional outcomes in the stroke survivors. Unilateral spatial neglect is prevalent is among the 70% in the post-stroke survivors. It is characterized by the reduced awareness of the information like sensory, motor, visual on the affected side, and it is more common in the right hemisphere damage, brain damage, but is also present in the left hemisphere brain damage. USN may also delay the motor and the functional recoveries. Subjects with USN exhibit the impaired weight shifting, postural asymmetry, and the increased fall risk. Deficit in the spatial attention negatively affect the motor planning and the movement toward the neglected side. USN also reduces the opportunities for the motor learning and the sensory motor integration. USN leads to the learned non-use of the affective limb and which interferes with the activities of the daily living and the functional independence. As you can see in this picture, the subject have written only on the right side of the board, neglecting the left side of the board. And the high prevalence of the USN in the stroke warrant the need to understand its impact on the recovery, and such knowledge is essential for the effective rehabilitation planning. Novelty of the study was the discerning the association by the quantifying all the motor components of the upper extremity and the lower extremities, and the determining the relationship by assessing the function neglect, which is a measure of the personal, peripersonal, and the extrapersonal neglect. Objective of the study was to determine the relationship between the USN with the motor recovery, balance, and the function. It is ethically approved by the Institute Ethical Committee, and the CTI registration was done, and the funding was done by the Indian Council of the Medical Research, it's ICMR. The study was done in the neuro rehab unit of the rehabilitation unit. It is a cross-sectional study which includes the 80 post-stroke hemiparetic subjects. Inclusion criteria was age between 20 to 70 years, and the duration was more than 1 month post-stroke. Side of the paresis, either right side or the left side, and the unilateral spatial neglect is exhibited by the letter cancellation test. Exclusion criteria was receptive communication disorder, homonomous hemianopia, the contractures and deformity of the hand, and any other visual deficits. The outcome measures for the unilateral spatial neglect to assess to USN, we use the letter cancellation test and the Catherine-Berger scale. And the Fogel-Meyer assessment we use to assess the motor recovery. For the balance, we use the Berg balance scale, and the function we use the Barthel index. Letter cancellation test, as you can see in this picture, this is a test of the letter cancellation. This is a A4 size, which includes the 425 distractors present in the sheet, and there are total 40 O letter present, 20 on the right side and 20 on the left side. During the test, we ask the patient to cross the all O's which is present on the sheets, and the USN is considered when the omission of at least 2 letters. And it is a type of the pen paper test of neglect. Catherine-Berger scale, it assesses the function neglect. It includes the 10 items like gaze oriented, limb awareness, collision, meals, and etc. It is a 4-point scale, 0 to 3, total score is 30, mild is 1 to 10, moderate is 11 to 20, and the severe is 21 to 30. And the higher score indicates the severity. Fogel-Meyer assessment, it is a motor recovery scale for the stroke subjects. This is a 3-point ordinal scale, which is 0 is cannot perform, 1 is performed partially, and 2 is performed fully, and the total score is 100. FMA includes the upper extremity component and the lower extremity component. In the upper extremity, it includes the upper arm and the wrist hand. Upper arm includes the 18 items, wrist hand includes the 15 items, and the total score of upper extremity is 66. Here we are assessing the violation movement with synergy in the sitting position like flexion synergy and the extensor synergy. And the FMA lower extremity includes the 17 items and the total score is 34, which includes total FMA is 100. Berg balance scale, it assesses the balance ability. It is a 14-item measures, which includes, which is a 5-point scale, 0 to 4. Maximum score is 56 and the higher indicates a good balance. Barthel index, it assesses the functional independence. Total 10 items, score is 100. And the items are divided into 2 categories, the self-care and the mobility. And in this video, the patient is left hemiparetic patient is doing the dressing task. Data analysis. For the data analysis, we use the Pearson correlation test. The p-value was less than 0.05. And for the analysis, we use the IBM SPSS version 23. For the study correlation classified as mild is R value is less than 0.3, moderate is between 0.32 and 0.3 to 0.75, and the strong is more than 0.75. Total number of the study for the for this study was 80 and mean age was 51 years. Gender male was 67.5%, female was 32.5%, and the post-stroke duration mean was 10 months, and the side of lesion right was 55% and the left was 45%, and the type of stroke frontoparietal is 25%, and the multiple areas includes the 65% and the others are the 10%. The result significance shows the significant moderate positive correlation for found between the USN by the LCT is with the motor recovery, balance performance and the functional independence, and the negative correlation were found between the function neglect, which is the VSS with the CBS with the motor recovery, balance performance and the functional independence. These all the graphical representation between the variables LCT versus FMA. It shows the moderate positive correlation between FMA upper extremity and the lower extremities also show the moderate positive correlation. Upper arm and wrist hand component, the BBS LCT versus BBS, it also shows the moderate positive correlation. LCT versus BI, Barthel index, its R value was 0.70 and its interpretation was like moderate positive correlation. Now CBS versus FMA, it shows a moderate negative correlation between the variables. The R value was -0.64. CBS versus FMA upper extremity and the lower extremities also shows the moderate negative correlations. CBS versus upper arm, Fogelman upper arm and the Fogelman wrist hand components, it also shows the moderate negative correlation. CBS versus BBS work balance scales, it also shows the moderate negative correlation, and CBS versus BI. Discussion, USN also USN severity significantly affects the motor recovery after stroke. As you see in this picture, the patient has shaved only his right side and neglecting the left side completely. And the both paper pencil like LCT and the functional neglect CBS correlated with the motor recovery. And the higher neglect severity is associated with the poor balance performance, and the functional independence is markedly reduced in the individual with the USN. Partial neglect is linked with the poorer motor recovery both in the acute and the chronic phase, and the neglect severity negatively impacts the motor outcome, like the patient is walking towards his left side ignoring the left side completely. And the partial neglect disturbs the postural control and balance, which leads to the instability and the increased falls, and the presence of the neglect predicts the lower functional recovery. USN is a complex and the multifaceted condition. It significantly affects physical and functional recovery after stroke, and there is no single standardized assessment for all the types of the spatial neglect. USN is usually underdiagnosed and undertreated. Lack of the standard testing and the treatment makes the spatial neglect a complex challenge, and the paper-based neuropsychological assessment remain the preferred standard over the digital alternatives. Paper-based tasks less times and the easily understood by the subjects. Recovery from the USN mainly occurs during the early post-stroke period. Approximately 42% of the patients recover within the first 3 months, and the recovery increases to 53% between 3 and 6 months. For the intervention part, the targeted interventions can reduce the severity of the spatial neglect. Combining motor and the neglect rehabilitation improves the recovery in the stroke subjects, and the mirror therapy and the prism adaptation can be considered as a potential intervention for the stroke rehab. Limitation of the study was the heterogeneity of the study subjects, which includes the brain involvement, type of the USN deficit, motor recovery stages, and the few subjects with the severe neglect. Recommendation is like assessment of the spatial neglect routinely in the stroke subjects, and to develop the integrated protocol or the modifying the existing ones, and the customize the rehab based on the neglect severity. From this study, we concluded that USN is associated with the slower motor recovery. Balance control is significantly impaired in the individual with USN. USN also limits the ability to perform the radial functions. And the early detection of the USN is essential for the optimal recovery in the stroke rehab. And the integrated treatment for the USN should be included in the rehabilitation programs. These are all the references. Thank you so much.
Thank you. The next presenter is Dr. Sanjay Bhatt Prabhu. His topic is determining the correlation between
Good afternoon, everyone. The title is Determining the Correlation Between Cognitive Self-Efficacy and Functional Cognition in Patients with Parkinson's Disease. Coming to introduction, Parkinson's disease is the second most common neurodegenerative alignment. 0.3% of the global population and 1% of adults over 60 are believed to have Parkinson's disease. Parkinson's disease is characterized by significant non-motor impairments that hinder participation in daily activities. Cognitive self-efficacy indicates confidence in identifying and handling cognitive challenges. It is relevant to everyday cognitive functions and cognitive interventions among individuals with PD because it affects the choice, engagement, and sustainment of participation in cognitively challenging activities. Functional cognition is how an individual utilizes and integrates his or her thinking and processing skills to accomplish everyday activities in clinical and community living environments. In PD, decreased executive function, particularly cognitive flexibility and attentional control, impairs functional cognition, leading to difficulties in performing daily tasks. After thorough review of literature, we came up with the need of the study, that is, non-demented individuals with PD exhibit lower cognitive self-efficacy compared to healthy controls. Reduced cognitive self-efficacy may impair an individual's ability to identify and manage cognitive challenges, thereby affecting participation in cognitively demanding daily activities. While the findings emphasize the importance of addressing cognitive self-efficacy in rehabilitation, the future scope identified the need to examine relationship with functional cognition. There are no or limited studies in this area. Aim and objective: to determine the correlation between cognitive self-efficacy and functional cognition in patients with Parkinson's disease. Coming to the methodology, so it was a cross-sectional correlational study design conducted in Goa Medical College and Hospital, a tertiary healthcare center in Goa. Individuals diagnosed with PD were selected using convenient sampling method. There were 60 in number, and instrumentation used was Cognitive Self-Efficacy Questionnaire 2, that is part 1, 2, and 4, and weekly calendar planning activity 10. The approval of both the scales was taken from the author. Eligibility criteria, inclusion criteria: the participants who met criteria for typical idiopathic PD within Honian stage 1 to 3, participants who were able to understand, speak, and write in English, and informed consent. Exclusion criteria: suspected dementia or global cognitive impairment, determined by physician or caregiver report, MMSE score less than 27, other neurological conditions, history of psychiatric disorder, and conditions like low vision that might interfere in the testing. Procedure: the approval was taken from the Institutional Ethics Committee before the commencement of the study, and data collection was done later. Before the data collection, identification and selection of the study participants as per the eligibility criteria. Then standardized scales were administered, data was collected and analyzed, and the results were prepared, followed by interpretation and discussion. Statistical analysis was done using Spearman's rank correlation. This analysis was done in the following, as we can see in the slide. That is, the Cognitive Self-Efficacy Questionnaire 2, part 1, 2, and 3 were 4 were correlated with the WCPA 10 individually, and number of months since diagnosis of the disease was correlated with Cognitive Self-Efficacy Questionnaire and WCPA 10. Results: demographic information: there were 15 female participants and male participants were 45 in number. So the first correlation, that was between self-recognition of cognitive lapses with WCPA, showed a positive correlation, a strong positive correlation, except in the areas of missing appointments and time taken, in which they showed a negative correlation, p-value being 0.0001, highly significant. Similar thing was seen in part 2, that is managing symptoms with WCPA and self-efficacy for cognitive everyday tasks. Last, the correlation was done between number of months since the diagnosis of the disease of Parkinson's with the Parkinson's disease. So both showed p-values were more than 0.05. It was not significant. Coming to the discussion, this study examined the correlation between cognitive self-efficacy and functional cognition in individuals with Parkinson's disease. Findings demonstrate a strong and meaningful correlation between CSE and functional cognition. Lower CSE was associated with poorer functional cognition, including reduced accuracy, increased errors, and slower task completion. These challenges were evident even in non-demented individuals, highlighting subtle but significant functional difficulties and early cognitive decline. Results align with the previous findings showing reduced cognitive self-efficacy in non-demented individuals with PD, negatively affecting cognitively demanding daily tasks. Also, across all CSC2 domains, CSC consistently correlated with WCPA10. Reduced belief in cognitive control may limit engagement in complex everyday task activities such as medication management and financial planning. Findings align with the Bandura's self-efficacy theory, emphasizing the role of self-efficacy in motivation, efforts, and task engagement. Cognitive self-efficacy may act as a mediator between cognitive impairment and daily functioning in PD. Disease duration showed no significant association with CSC or functional cognition. Prior research studies indicates that cognitive, motor, depressive symptoms and its severity, medication dosage are associated with lower CSC and functional cognition rather than disease duration. Performance-based assessments such as WCPA-10 are sensitive in these conditions, and this study supports the clinical relevance of WCPA10 and CSC2 in occupational therapy. This study reinforces the importance of addressing the non-motor symptoms, including functional cognition and cognitive self-efficacy, to support everyday functioning and independence in PD. Despite valuable insight, there were few limitations, such as small sample size, use of non-probability convenience sampling method. Study participants may not be the exact representation of the entire population, and neither CSC2 and WCPA10 currently have normative data for Indian population. Study implication and future scope, developing and testing interventions that enhance both functional cognition and cognitive self-efficacy with the aim of improving everyday functioning and participation in individuals with Parkinson's disease. Future studies with larger and more diverse samples, contextually validated assessment tools to be added for more generalized results. Coming to the conclusion, study demonstrate the possible connection between cognitive self-efficacy and functional cognition in individuals with PD, and indicating that confidence in managing cognitive difficulties may affect task engagement in real world. Strengthening and expanding this evidence will guide occupational therapists in clinical decision-making, strategy training, discharge planning, and inform short-term and long-term therapeutic intervention planning. I express my sincere gratitude towards all the participants of the study who generously devoted their time and effort to take part in this study. Dr. John Toglia, author of Multi-Context Approach, for her generosity in providing essential material support, including WCPA-10 assessment tool, and for granting permission to use CSC2 and WCPA-10 for this research. I express my gratitude to the Dean Sir, Professor and Head of Orthopedic Surgery, Professor and Head of Neurology, and Institutional Ethics Committee of my college for allowing me to carry out my study in this prestigious institution. Finally, I offer my profound thanks to my parents and loved ones for their constant support. Thank you. These are my references.
Thank you. The next presenter is Dr. Poonam Rani. Her topic is effectiveness of bilateral arm training along with functional electrical stimulation for restoration of upper limb function and activities of daily living performance in chronic stroke patient. This is a comparative study between dominant and versus non-dominant hand.
Hello, good afternoon all. This is the introduction. Stroke remains a major public health concern in India, ranking among the top causes of mortality and the long-term disability in India. Recent population-based studies indicate that the adjusted prevalence of stroke varies widely, approximately 84 to 262 per 1 lakh people in the rural regions and 334 to 424 per 1 lakh in the urban regions in the India. The incidence rate has been reported to be around 119 to 145 per 1 lakh individuals. A stroke affecting the brain's right hemisphere often leads to the symptoms that differ from those caused by a stroke in the left hemisphere. affected in the post-stroke cases. In addition, the impact of a stroke can vary depending on whether a person is right-handed dominant or the left-handed dominance. Hand dominance refers to the preferred use of the one hand when carrying out the various tasks in the activities of daily living. It plays a significant role in the motor performance as the dominant hand is typically relied on for most routine and the leisure activity of the daily routine. So the bilateral movement is based on the theoretical principles of coordination between the affected and the non-affected sides and it is based on the neural crosstalk models of the brain, and the unilateral movement causes inhibition of the neural plasticity in the ipsilateral hemisphere, where symmetrical bilateral movement will activate both the cerebral hemisphere and decreasing the interhemispheric inhibition and facilitate the limb recovery on the affected side. Thus, bilateral movement influences the coupling effects of both sides of the hemisphere in the central nervous system through the corpus callosum and the subcortical neural circuits. Functional electrical stimulation is an emerging treatment for the rehabilitation of the upper limb function of persons who have had a stroke. Both the clinical reviews and meta-analysis have supported FES in promoting with the recovery of the muscle strength and the motor recovery after the stroke. So, rationally behind the study, Rose Winstein suggested that a bimanual intervention approach could reduce the movement velocity of the unaffected limb and at the same time increase the velocity of the paretic limb, called the bimanual facilitation effect, which facilitate the movement control of the affected upper limb. Functional electrical stimulation, when combining with the bilateral arm training, could improve the motor functions in the chronic stroke survivors. The combination of bilateral arm training with the FES revealed functional improvement in the affected hand of the post-stroke patient in the recent studies. A specific upper extremity rehabilitation approach is necessary that recognizes the movement differences between the dominant and non-dominant hands. So, previous study have shown that the two-handed task training had a different influence on the dominant and the non-dominant motor recovery. There are few studies which shows the comparative effect of bilateral arm training on improvement of dominant versus the non-dominant hand affected in the post-stroke patients. So from the above studies, we could observe that there are the studies which shows the bilateral arm training along with the FES has the better functional improvement in the upper extremity in the stroke patient, and the further comparative effects of bilateral arm training between the dominant and non-dominant hand in a stroke patient shows a better improvement in which group is required. Hence, a trial is being made in the present study to find the comparative effect of bilateral arm training along with the FES on improvement of dominant versus non-dominant hand function in the chronic stroke survivors, and it's observed its impact on the radial performance. So, aim of this study is to find out the comparative effect of bilateral arm training along with the FES on improvement of dominant versus non-dominant hand function in the chronic stroke survivors and to observe its impact on radial performance. Null hypothesis: there is no significant difference between the dominant and non-dominant chronic stroke patients in improvement of restoration of upper limb function and the radial performance by using the bilateral arm training along with FES. Alternative hypothesis: there is a significant difference between the dominant and non-dominant affected chronic stroke survivors in improvement for the restoration of upper limb function and the radial performance by using the bilateral arm training along with the FES. Coming to the methodology part, study design and experimental pre-test, post-test design, comparative study. Sample size: a total of 22 subjects of clinically diagnosed unilateral chronic stroke. Sampling method: each subject was allocated to the research group through the convenient sampling method. Inclusion criteria: clinically diagnosed unilaterally stroke, subject with the first episode of stroke greater than 6 months post-stroke, age range 20 to 60 years of age, stroke with the brainstorm stage of hand 3 and 4, ability to understand the verbal information. In the exclusion criteria: history of any metal implants inside the body, history of seizures or pregnancy, history of aphasia, history of any skin allergy and the unhealthy skin, past history of upper extremity musculoskeletal condition that affect the upper limb function, history of severe pain in the either arm, and the cognitive deficit MMSE score less than 25. Screening tool: we use the mini mental state examination and the brainstorm stage of recovery of hand 3 and 4. Outcome measure: we use the Shadow arm and hand activity inventory version 13, and the instrument we use the Mega XP functional electrical stimulation machine. This is the flow chart and the procedure of the study. Patient assessed for the eligibility is 30. Allocation of patient by the convenient method 22. In the there is a two group. Group A is the dominant hand affected post-stroke cases and group B is the non-dominant hand affected post cases. There is a 12 patient in the group A and 10 cases in the the group B in the non-dominant hand side. All the participants of both the group received the same type of intervention, that is functional electrical stimulation along with the bilateral arm training and the conventional occupational therapy program in the department. Functional task of daily activities for the bilateral arm training. So there is 4 activities were chosen as all of them involve the hand manipulation and the functional task for the daily activities. These training activities were run in a cycle so that each participant had a similar pattern of training. So as in the figure 1, the lady is doing the drinking with bilateral hand use activity with the FES. In the 2, pour a glass of water. 3rd, cleaning a desk by a towel by using the bilateral hand use. In 4, put the basketball in the basket with the bilateral hand use. This is the data analysis and the result table 1 showing the baseline characteristics of the participants. So number of subjects were 11 in the dominant hand side and 8 in the non-dominant hand side. Age range is 20 to 60 years in both the group. Mean age was 42.3 in the dominant hand side and 44.9 in the non-dominant side. There was 7 male and 4 female in the dominant hand group and 5 male and 3 female in the non-dominant hand group. Side of paresis was 11 right side paresis in the dominant side and 8 patients were left side paresis in the non-dominant hand side, and all the participants of both the group was right hand dominance. Descriptive statistics of outcome measures shown by using the Cherokee arm and hand activity inventory. So there is a mean test score in the dominant hand side. Pre-test score is 54.3, post-test score is 78.3. That shows the significant improvement in the dominant hand side. In the non-dominant hand side, also showing the mean test score improvement in the pre-post analysis. Table 3 and graph 1 showing the result of Mann-Whitney U test between the difference of the group 1 dominant and non-dominant hand affected side. So here we can see there is a significant value is 0.006 that shows that there is a significant improvement, there is a significant difference between both the group, and there is a marked more increment in the dominant side group. Table 4 and graph 2 showing the result of Wilcoxon sign rank for the Kahai pre-test and the pre-post test analysis score of dominant and non-dominant side group. So there is a significant improvement in group 1 and group 2 also. In the conclusion, in the present study, it was observed that there was a significant improvement to restore the upper extremity function and the daily living performance in both the group scored by the Cherokee arm and hand activity inventory scale. It was further observed in this study that there was a significant difference in the restoration of upper limb function and radial performance between both the group. As observed in the score of Cherokee arm and hand activity inventory, it is showing the improvement in the group 1 and is greater than in the group 2, that is the non-dominant hand, and level of significance was 0.006 as shown in table number 2. From the obtained result of the study, it is observed that there is a significant difference between the dominant and non-dominant chronic stroke patient in improvement for restoration of upper limb function and radial performance by using the bilateral arm training and along with the functional electrical stimulation. These are the limitations. Small sample size, all the subjects were right hand dominant, no carryover effect was observed. In the future recommendation, a study can be done to find out the effect of bilateral arm training along with the FES by comparing between the male-female stroke clients. Study can be done to find out the effect of bilateral arm training along with the FES by comparing the right and left hand dominant stroke clients. Effects of bilateral arm training along with the FES may be observed on the recovery in subacute stroke survivors. These are my references. Thank you.
Thank you very much. I like her confidence. Means this much she have written and how fast she was reading. So what can be done in 10 minutes, she have proved it. The next presenter is Dr. Susri S. Raut. Her topic is comparison of vestibular rehabilitation therapy and dual task training on balance and gait in middle cerebral artery stroke.
Good afternoon, everyone. Myself, Dr. Sushri Suchismita Raut. My research topic is comparison of vestibular rehabilitation therapy and dual task training on balance and gait in MCA stroke patients. Stroke is a neurological condition which occurs due to the damage to the blood vessels of central nervous system. There are 2 types of stroke. One is hemorrhagic stroke, the other one is ischemic stroke. The middle cerebral artery is an important artery which supplies to a larger area of brain. When it is getting blocked, that will lead to severe stroke and major brain functions. The patients, those who are having MC stroke, they will experience balance and gait difficulties. Vestibular rehabilitation therapy is an exercise-based approach which aims to improve the balance and gait through adaptation of vestibulo-ocular reflex. Vestibulo-ocular reflex is something which keeps the eyes stable while doing the head movement. Dual task training involves performing two tasks simultaneously, which improves the balance and gait after the stroke. Coming to the need for the study, in India, about 1 out of the 4 people are at risk of experiencing a stroke. Around 85% strokes are ischemic strokes, and more than half of these are occurring only the MC artery. Vestibular rehabilitation therapy helps to restore the balance by promoting the neural plasticity. Dual task training combines balance and cognitive activities for improving the balance after the stroke. Despite the individual benefits of these interventions, there is still limited research which is the comparison of effectiveness of vestibular rehabilitation therapy and dual task training on balance and gait with MC stroke patients. Coming to the aim of the study, it is to compare the effectiveness of vestibular rehabilitation therapy and dual task training on balance and gait in MC stroke patients. The objectives are to compare the pre-test score of Berg-Balance scale and Wisconsin gait scale between the vestibular rehabilitation therapy group and dual task training group. The second objective is to compare the post-test score of Berg-Balance scale and Wisconsin gait scale between the vestibular rehabilitation therapy group and dual task training group. Coming to the methodology, the ethical clearance has been taken from the ethical committee. It is a quasi-experimental study which included 60 participants through the convenience sampling method. The 60 participants were divided into two experimental groups, that is Group A and Group B. The study included participants, those who are having only the MC stroke, the subacute stroke patients less than 3 months, Berg-Balance scale score between 21 to 40, and the modified ASO scale grades would be less than 3. The study excluded the participants, those who are having mini-mental status examination score less than 18, subjects, those who are having any unstable medical condition which is affecting the gait, any neurological and psychological conditions like Parkinson's disease, spinal cord injury, and multiple sclerosis, subjects, those who are having uncorrected hearing and visual impairments. Initially, the ethical clearance was obtained for the study. Next, the consent form and demographic details were obtained. 60 persons with MC stroke were recruited for the study. 60 participants were divided into two groups, that is Group A and Group B. Group A consisted of 30 participants and Group B also consisted of 30 participants. Pre-test has been done by using the Berg-Balance scale and Wisconsin gait scale for both the groups. Group A received conventional OT plus vestibular rehabilitation therapy, whereas Group B received conventional OT plus dual task training. The post-test has been done by using the Berg-Balance scale and Wisconsin gait scale. Data analysis has been done by using the software SPSS 29 version. For screening, modified ASO scale and MMSE scale has been used. Modified ASO scale is used for assessing the spasticity of the patient. It has moderate to good validity and moderate to substantial inter-rater reliability. MMSE is used for assessing the mental status of the person. It has moderate validity in stroke patients and good test-retest reliability. Outcome measures include Berg-Balance scale and Wisconsin gait scale. Berg-Balance scale is used for assessing the balance because it has moderate to high validity and high intra-rater and inter-rater reliability. Wisconsin gait scale is used for assessing the gait problems only for the stroke patient. It is a stroke-specific scale. The higher the score, the more the seriously get affected. Coming to the intervention protocol, conventional OT has been given for both the groups, which was given for 45 minutes a day, 5 days in a week for 4 weeks. It included limb stretching, strengthening exercises, stability exercises. Group A received vestibular rehabilitation therapy for 45 minutes per day, 3 times a week for 8 weeks, which included adaptation exercises, ocular exercises, balance exercises, and gait exercises. Dual task training has been given for Group B for 45 minutes per day, 3 times a week for 8 weeks, which included stance activities and gait activities. These stance and gait activities includes the balance activities as well as the cognitive activities. Coming to the results and discussion, Table 1 depicts about the demographic distribution of the variables. Here 60 participants are divided into two groups, that is Group A and Group B. It explains that males are more affected than females, but females are more severely affected. And 46 to 65 age group is more prone for having the MC stroke. Table 2 explains that that paired t-test has been used for comparison between pre and post-test score of balance scale and Wisconsin gait scale in group A. The vestibular rehabilitation therapy group showed significant improvement in balance and gait, which included vestibular ocular reflexes, balance exercises, gait exercises, and ocular motor exercises. These findings are consistent with Meng et al. 2023, who explained that vestibular exercises enhance the cerebellar activation, which is leading to the improvement in balance and gait. Table 3 is explaining that paired t-test has been used for comparison between pre-test and post-test score of balance scale and Wisconsin gait scale in group B. The dual task training group showed significant improvements in balance and gait following the dual task training because it included primary task, that is balance task, and secondary task, that is cognitive task. These findings are supported by Su et al. 2022, who reported that improvements in gait parameters are following due to dual task training. Table 4 explains that independent t-test has been used for comparison of pre-test score of balance scale and Wisconsin gait scale between group A and group B. Here the p-value is more than 0.05, so the results are no significant difference in pre-test of balance scale and Wisconsin gait scale between group B, between two groups. So there is a equal sample distribution of before the intervention. Table 5 explains that independent t-test has been used for comparison of post-test score of balance scale and Wisconsin gait scale between the group A and group B. Here the p-value is less than 0.05. So there is a significant improvement in balance and gait between group A and group B. The vestibular group showed improvement in balance scale and Wisconsin gait scale as compared to the dual task training group. These results are aligning with Salim et al. 2019, who explained that vestibular rehabilitation therapy is more effective than dual task training for improving the balance and gait in MC stroke. The study limitations are, the study included a small sample size, blinding was not done for the participants. The implication of the study, it is a safe, cost-effective and easy to use in all the environments. The protocol does not require any particular equipments. The study's results show that the vestibular rehabilitation therapy and dual task training both are significant improvement on balance and gait in MC stroke, but the study concluded that the vestibular rehabilitation therapy is more effective in MC stroke patients for improving the balance and gait than dual task training. Hence, the vestibular rehabilitation can be used as an OT intervention. The study recommends that further researches can be done by using the RCT and larger sample size, and future rehabilitation protocols can be done by combining both the vestibular rehabilitation therapy and dual task training to maximize the functional recovery in stroke patients. These are the references. Thank you.
Thank you. The last presentation for the day before lunch. The presenter is Dr. V. Shondarya. Her title is Mobile Application-Based Home Program for Cognitive Rehabilitation in Clients with Traumatic Brain Injury.
Good afternoon all. I would like to present my study on mobile application-based home program for cognitive rehabilitation in clients with traumatic brain injury, a feasibility study. We all know that TBI can be defined as organic damage to the brain, and it causes a spectrum of motor, cognitive, and emotional deficits. And these deficits, especially cognitive deficits, can have a profound impact on daily functioning, quality of life, and overall well-being. Now, cognitive rehabilitation in TBI has seen a lot of progress over the years, both in compensating and remediative. And one such area of research is mHealth, that is health interventions through smartphones or tablets. And mobile applications in general can provide personalized cognitive training tailored to the client's specific goals. And we are having this technology in our hand. It is something that we can put to good use, provided we have the right guidance. Now, there isn't recent enough research to show if we can use it normally in therapy as home program or otherwise. And in this era especially, this is, I think, a resource we need to tap into. Now, obviously, there is a lot of resource, there's a lot of research on commercial video games and rehabilitation. We are using Wii games, we are using PlayStation, Nintendo regularly in our therapy. And in a lot of sectors, they are developing games for cognitive rehabilitation where you just have to input either MMSE score or MOCA score, and then the app itself will design a game and ask the client to play it. And again, mobile game aided neurorehabilitation is being studied, but not always as a remediative neurocognitive method, more as compensatory. And we also saw recent research where it was done by non-medical professionals and who did content analysis on mobile applications and how that can be used for cognitive training. So this is what ended up formulating our study for us. And a study was designed and we obtained permission from the scientific committee of our institution. We decided to conduct this study in inpatient and outpatient setup in our institute, as well as in the outpatient setup of a prominent government hospital nearby. And we used AS3, which had the domains of memory, attention, verbal fluency, language, and visuospatial skills. And we tried to fit the games according to the interest of the client. To select the games from Play Store, obviously if it was a paid game or if it was ad powered, we rejected it immediately. We were not working with a population which could pay for the games, or I did not want the ads to interrupt the focus that they will have on the games. Obviously, we played through the games to see how the ease of access was, how the interface was, and what cognitive components is it addressing, how much time is being taken, how long is every game, and what is the control of the game, and if it had its own assessment system. If it had its own assessment system, we usually ended up rejecting it because we did not know the basis for the assessment behind that. This is a few screenshots of the games that we rejected because of one of the reasons that I mentioned above. Obviously, we did also have a few misleading applications that were predominantly suggested to us by our clients. When we played through it, we rejected it. The mobile games that ended up being selected by us were Neurobix. They had different games inside. This is, I think, a screenshot from Pico's spatial reasoning. There was help given, but not throughout the game. We ended up with Train Your Brain, Neurobix 60, visual spatial games, paint by numbers, coloring games, differences, Pico spatial reasoning, animal card matching, free flow, and Zen match. Our inclusion criteria was that the client should have a smartphone, should be able to read either English or Hindi, should have an RLS stage 6 or more, should score 15 in MMSE, and not be more than 24 months post-TBI, and be an adult to consent to this. Our exclusion criteria was if they had any other comorbid neurological or psychological disorders, and if they were a senior citizen, they were generally excluded unless they expressed special interest in it. After obtaining consent from our clients, we used our screening tools to see if they are eligible for our study, and then convenient sampling was done, dividing them into control and experimental group. Pretest was done post that. The control group received conventional cognitive rehabilitation and conventional home program, and experimental group received a conventional home program, conventional cognitive rehabilitation and home program that had an array of mobile games and apps which they are supposed to play. Regular follow-up was done using a checklist and also using a screenshot of their digital well-being where you could see the usage of every app, and then data analysis was done. This is one of the screenshots of one of our clients who played the game. Results, this is the overall demographics of my population. We see that the mean RLA was 7, which means they are just coming out of it. They are giving appropriate responses to us. And PAT-T test was done. PAT-T test and independent PAT-T test was done. we can see that there is the value of 9.906 indicates that there is a positive correlation. Discussion and conclusion. In the study, we had initially targeted for 30 participants in the study, but we only ended up with 28. Two of them left the study. One of them, the reason being that it was taking time away from their Instagram time, which was a point that we noted down, which needs to be studied further. But apart from that, overall, we saw that there is a positive correlation in the post-test group, which means it is benefiting them. But we don't know the exact reason behind it. It might be because in literature, they say that they get into a flow state, which makes it easier for them to focus on the next task that is coming up or the next cue that is being given to them. It might also be because whatever feedback they are getting is in real time. There is no lag between them doing something and them getting the feedback back. So these does pose very interesting and a little obvious answers to our results, but we will need further research on the same topic to see if we can completely understand this change. This study underscores the possibility of using such low-cost applications for rehabilitative use, and if tailor-made planning is done for each client. In a country with a huge burden of TBI clients that need rehabilitation, there is an increasing demand for resources and rehab professionals, and mobile is something that everyone has now, so this is a good area to be looked into. We conclude that this study could be of great importance if done on a larger scale and potentially can be a progressive step in the domain of everyday technology being used. Limitations of my study were we did not include diffuse axonal injury, and we could not segregate according to the severity or type of TBI. And we also understand that the findings of this study could be limited to Eastern Indian population only. And again, all these people are people who already know how to use a smartphone. The total sample size of the study was very small, which leads to these findings, though being very positive, not something that we can generalize. Future recommendation, the same study could be done on a larger scale, and research and development on free Indian smartphone applications that can be used for cognitive rehabilitation can also be explored. This is very specifically from some apps which are, there is one Korean app called Neuro World that has the same thing. The entire interface is in Korean, but we can use MMSE score and MOCA score to play the game there. And the data on patient participants' usage and time spent on other mobile applications was outside the scope of this story, but the potential of it impacting the participants' gameplay and psychological and cognitive health needs to be further researched. And the acceptance and attitude of clients towards these interventions needs to be further studied further also. These are my references. Thank you.
Thank you. Chandra be here, and may I request all the presenters to come to the dais for the question and answer session. Thank you. So the first presenter, Dr. Sneha Panda.
Yes, sir. Yes, sir.
Yeah. Any question? Yes.
So good morning. Myself Raghuram from Chennai. So what are the tools you used, and speak about the administration time?
So the first one was a standard chair. There were 4 grades to that. So in the first one, a standard chair was used, and in the second one, a low mat was used, like a low stool was used. In the third grade, only a mat was used, like a mat surface was used. And in the fourth stage, the person did squat to stand on the ground.
Administration time of the tools, standardized tools you used.
Administration time, sir, of the SRT, you're asking, of the tools I used. So SRT, it is a tool, there is no specific time. It measures the health the person takes. So the person is asked to perform like sitting to the floor, and then he is asked to stand simultaneously. And how much help he takes while that is measured. So time, average time that a person takes to sit and stand up from the floor. There is no specific time which is measured for that.
Thank you.
Myself Shanta, assistant professor from Delhi. You have a lower extremity management of stroke.
Yes, ma'am.
If chair permits, I have two questions. You have not mentioned the motor recovery stage of lower extremity, first thing. Second thing is your age criteria is from 25 to 65. So if you talk about sitting to standing, it's a drastic difference from 25 to 65. So please explain these two facts. Thank you.
Ma'am, first, I did not mention I have not directly mentioned the BRS stage if you're asking, but I have taken the inclusion criteria that the person should be ability to stand independently for the 2 minutes. So this, I have not mentioned specifically, but it more or less leads to BRS stage of minimum 3 or 4, where the person is able to stand independently. And ma'am, in the next question, ma'am, can you repeat again, please? Age. I have taken participants. The main goal was who were not able to perform the stroke. That was my criteria. I did not take into account the age when the stroke has occurred. I have tried to include the population from small to large size, but as you say, it could be a further recommendation or a study could be done.
Thank you, Sneha. I just want to give a suggestion. In future
Yes, sir.
study, if you can correlate this with the function, that will be a good study for our profession. Because this is very simple and very nice activity you have selected. And
Yes,
if you
sir.
are correlating it with the function, that will be much more effective.
Yeah.
Thank you.
Thank you, sir.
The next presenter is Dr. Divya Pandey.
So myself Raghuram from Chennai. Sample size and age-wise distribution. Please tell about the sample size and age-wise distribution. I think you have mentioned age from 20 to 70.
Yes, sir.
Am I right? Yes.
So sample size was taken from the previous study. It is an ongoing project. So we have taken from the sample from that study, and we assessed the previous study, and we done the sample size calculation with the formulas. So we got that sample size of 80 patients.
So the age-wise distribution, 20 to 70 years you have mentioned, no?
Yes, sir. So I'm not getting that question, like age-wise distribution, like
So-
why I took that.
Yes, yes.
Oh. So because in our setup we are getting patients from 20 to say mid early 20 to late 60s, and stroke is more.
It's okay, ma'am. Okay, thank you.
Okay. Next question. One more question. Okay. If there is no, then the third presenter is Dr. Sanjog Sanjay Bhatt Prabhu. Any question? Okay, if there is no question,
This
then...
question, sir. Good
Okay.
afternoon.
Okay, yeah, sure.
Myself Pooja from Goa Medical College. I just wanted to ask you that you have said that you have excluded from your study dementia, right? But then how you will consider pre-dementia in Parkinsonism?
Ma'am, thank you for the question. So, as I mentioned that I have excluded dementia because my study, the objective was in non-demented Parkinson patient, and to understand their functional cognition. Like early, so my main objective was to find out whether cognitive self-efficacy, if there is some decrease in cognitive self-efficacy, whether the functional cognition is affected or not. So early cognitive decline can be understood by checking cognitive self-efficacy. So that's why I
Okay.
did that.
Yes.
Any further question? Okay. Yes.
Hello, I'm Dr. Sriyash from Mumbai. I wanted to ask you, does it not require basic functional cognition to fill up this self-awareness scale?
Sir, I
How would you
didn't get it.
differentiate between that?
So cognitive self-efficacy is something like one's ability to use the cognition in daily world, and functional cognition is one's ability to one's cognitive self-efficacy is actually the belief of using cognitive functions, and functional cognition is using these cognitive functions like attention, concentration, etc. in real world. So that's why how these can affect the functional cognition. That's
Okay, thank you very much. The next presenter is
Thank you, sir.
Dr. Poonam Rani.
Good afternoon, everybody. I'm Yogita from Mumbai. I have a question. I would like to ask what stage, pardon me if I missed it in the presentation, what stage of motor recovery were your clients were in?
Breast of stage of recovery used for the
For
hand,
the hand and the arm.
3 and 4. I mentioned in the slide.
Is there an evidence suggesting that in grade 3 and 4, where there is spasticity picking up, you use the functional electrical stimulation? That's the
Yes.
question.
Yes, we included the BRS stage recovery 3 and 4 from the previous study that I have taken from the reference article. For the FVS, we can use the 3 and 4. Already, actually, we are working on the bilateral hand activity. So we required some synergistic pattern to improve the gross motor functions, and that required the finger opening and the wrist extensors also.
I think no cross question allowed, so I'll take it.
Yes, better.
Thanks.
Okay, okay.
Thanks.
Thank you very much. Next. Any question? Okay. If there is no question, then the next presenter,
Thank you.
Dr. Sushri S. Raut.
Yes, sir.
Yeah.
Myself, Dr. Durgesh Pathak from New Delhi. You have taken MCA stroke in your inclusion criteria. Well, we all know that MCA stroke is a part of the anterior circulation. And your topic was regarding the balances difficulty. So please justify this MCA stroke for your inclusion criteria. And another question is how since this is the comparative study, then how the homogeneity of the group was maintained?
Thank you, sir, for the question. Sir, MC is supplying to a larger area of brain, that is frontal lobe, parietal lobe, and temporal lobe. So in frontal lobe, MC is frontal lobe it is supplying. So the motor aspects are affected. As the motor is affected, so there will be hemiparesis. Due to that hemiparesis, the person will be having balance and gait impairments.
Okay, any other questions? Yeah.
How would you justify the passive stretching and mobilization in your control protocol? Well, that's not the part of an occupational therapy protocol as a conventional management.
Sir, it was used in conventional OT, which was given as a preparatory activities that can be done as PT also, not bias.
Okay.
Thank you, sir.
Thank you. The next presenter is Dr. V. Soundarya. Any question for her?
Sir.
Yeah.
Myself, Dr. Naresh from Sri Abhirami College.
Okay.
Ma'am, I have a question. Based on the mobile application, you said that you are not using the paid scales, paid applications. But though in the free applications there will be ads, so how you will able to restrict?
So we played through each of the games that we selected, and we made sure that it is all completely offline. So if the client is playing it offline, they will not have any ad pop-ups coming up. So one of the games that I have mentioned here is now ad powered, but it was not at the time when the study was being done. So when continuing this further, we will have to play through the game again and check.
Any further question?
Yes.
And also you said about MOCA, like how you decided the any criteria in that MOCA?
Sir, I have used ACE3 in my study, but we have had other games which have been made, which uses MOCA scores as the basis to start the game.
Thank you.
Yeah, we can
Yes.
take, yes.
Myself, Pooja, and question from here. Do you have used any specific statistical analysis for this study? Because in order to say that it is helpful, you need to, you might have used any specific statistical.
No, ma'am, we just used the SPSS to calculate the T score, and we did the T test and the PAT T test using SPSS. We focus more on the protocol than the results.
Yes, but you need to.
I'll make sure I'll do that once I
Yes.
continue this.
Okay, thank you.
Thank you all the presenter, and thank you the judges. It was nice session, sir. Please.
So thank you very much to all presenters, very young professionals, and you are doing great job. You are doing good research. So wish you very good luck for future, more studies. Thank you.
Moving forward, now I request Dr. Surendra Kumar Meena sir to come forward and hand over the certificate to the participants. For this, first I invite Dr. Sneha Panda. Dr. Divya Pandey. Dr. Sanjog Sanjay Bhatt Prabhu. Thank you so much, sir. Now I would like to request Dr. Amitabh Kishore Dwivedi sir to come forward and hand over the certificate to the rest of the participants. Dr. Poonam Rani. Dr. Shushri S. Raut. Dr. V. Saundarya. Thank you so much, sir. We sincerely thank all the presenters for enriching this scientific session through their valuable research contribution and scholarly insights. At this august moment, we take the honor of presenting this mark of appreciation to Dr. Surendra Kumar Meena sir and thank him for gracing this occasion with his esteemed presence. We kindly request Dr. Lakshmanan S. sir to felicitate him. Sir, please come. Thank you, sir. We now present our token of appreciation to Dr. Amitabh Kishan. May I request Dr. Sujata Missal ma'am to felicitate him. Thank you, ma'am. We sincerely thank our respected chairpersons for their guidance and our esteemed presenters for sharing their valuable insights. Your contributions have made this session engaging and enriching. Thank you so much.
ଆମକୁ ଦେଇଦିଅନ୍ତୁ ପେନ୍ଡ୍ରାଇଭ୍ଟା କାହିଁକିନା ବେଟର୍ ହେବ ଆମେ ଆମ ସିଷ୍ଟମ୍ରୁ
ଆଚ୍ଛା ଏଇଠିରେ ପ୍ଲେ କରିବେନି
କରିପାରିବେ ବଟ୍ ସେ ସବୁ ମ୍ୟାନେଜ୍ କରିବା ଇଜି ନା ସେଥିପାଇଁ ବେଟର୍ ସିଷ୍ଟମ୍ ଲାଗିଛି ଏଇଟା ନୁହଁ
ନା ଏଇଟା କାଢ଼ିବେ ଓ ସରି
Can you give the pen back?
किनका सुजाता मैडम का नहीं है
দেখুন সে মাকে কেতে থর কল করলে সচিন হ্যালো হ্যাঁ
Durgesh, Durgesh. She just came actually. She got ticket.
କୋଉଠି ଗଳା କଣ
Satakshi. 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 Start करी हाँ नहीं करता
A very good afternoon to our respected chairpersons, esteemed dignitaries, honorable delegates, dear participants, and enthusiastic students present here. In keeping with the spirit of the event, we are delighted to announce that the mini movie will be played now. We sincerely hope that this will be both engaging and meaningful. All of you are warmly invited to experience and celebrate the creativity and effort behind the mini movie. Thank you all.
Restraint, silence, and order must be maintained.
These are human beings in difficulty, not criminals. They deserve compassion and activity. Let's do some activities now. Use both your hands. Start slow and stay focused. This will prepare you for your walk again.
It feels good to do things by myself again.
We will practice this daily at the same time.
I feel a little scared of falling.
I'm right beside you. Start slowly. Push the paddle down. Very good.
Slowly open the tap. Okay, now close it. Take your hand towards your mouth and eat. This will make you independent again. What role matters to you?
I want to return to work.
You have the right to enter like everyone else.
Wow, yaar, nice throw.
I never thought I could play like this.
one's journey through life, pain is sometimes irritable. However, suffering is preventable. We believe in compassionate care as a guiding principle. In one's journey through life, pain is sometimes irritable. However, suffering is preventable. We believe in compassionate care as a guiding principle. Palliative care extends beyond medical treatment, and using a holistic approach, we relieve total pain and prevent suffering to enhance the quality of life for patients and their families. Every individual is treated with dignity and respect, ensuring comfort on their road to recovery. Occupational therapy plays a crucial role in palliative care. It focuses on enhancing the quality of life by helping patients regain independence and find joy in daily activities, even in the face of illness and adversity. We have witnessed a growing need for structured rehabilitation services to complement our existing care. Patients with life-limiting illnesses face challenges such as mobility restrictions, cognitive decline, and chronic pain. By offering comprehensive rehabilitation interventions, we aim to restore dignity and functionality, thus giving hope to patients. Our therapy programs focus on functional training and vocational rehabilitation, enabling them to engage in cherished daily activities. Every story is a testament to resilience. In every smile regained, in every moment shared with loved ones, we witness the profound impact of compassionate care. Patients are referred by physicians and undergo comprehensive assessments to create individualized treatment and rehabilitation plans. Regular monitoring ensures progress and adjustments, empowering not only patients, but also their caregivers. Join us in advocating for the need of patients to receive holistic care that transforms lives and spread awareness about the importance of palliative care and how occupational therapy plays a pivotal role in improving independence, restoring participation, and maintaining dignity. Together, we can ensure that every individual experiences the compassionate care that they deserve.
Hello, there's a small announcement. Now we have a ACCORD GB meeting in a boardroom in the annex building. So whoever are fellows of Academic Council of OT, please gather there in next 15 minutes.
John
Thank
is a
you.
weaver by profession who loves to weave rug, basket and carpet, but due to some illness, he is struggling to use his hand functionally.
Dr. Anna, a renowned occupational therapist. John came to know about her and he visited her clinic.
I haven't been a drug since 3 to 4 months.
Don't be discouraged, John. Your perseverance and your hard work will help you overcome this challenge.
is a weaver by profession who loves to weave rug, basket and carpet, but due to some illness, he is struggling to use his hand functionally.
Dr. Anna, a renowned occupational therapist. John came to know about her and he visited her clinic.
I have been with the drug since 3 to 4 months.
Don't make this noise, John. There were several things that happened. We have not overcome this challenge. Every setback is an opportunity to learn and come back stronger.
Move up! Keep firing! Man down my leg! I can't move it! Got him! Pull back!
I saw a way out through the supply lines. It's risky.
Let activity be medicine. Let purpose be therapy.
During World War I, thousands of injured soldiers needed rehabilitation. A new profession emerged, occupational therapy, using activity-based treatment to rebuild lives.
Arun is not defined by his stroke, but by his courage to rise after it.
They can't even do this anymore.
Don't worry, we will find a way.
After a stroke, even simple actions can feel impossible. Occupational therapy helps survivors to adapt and revamp their daily living.
Dr. Isha, an occupational therapist restoring purpose through everyday actions. We'll work together, okay? In step by step.
When can I really improve?
Yes, with efforts and right support. Focus on your mental health.
It's really hard, but I won't give up.
Every client walks in with a story. Some carry frustration, but all of them carry hope. And my job, my privilege is to help transform that hope into ability, confidence, and independence. Reputation, hope, support. Small goals make big victories. Just do well, distract, and I'll help you, okay? Well?
The spoon slips, frustration rises, but with positive reinforcement, Arun tries persistently and finds his success in the simplest yet most powerful way.
Arun's journey shows what's possible when determination meets the right care. Healing occurs with every guided step.
मुझे देर हो रही है मैं निकल रही हूँ मेरा वेट मत करना क्या शो हुआ बेटा तो ठीक तो है ना उठ रही थी मैं उठ नहीं पाई मेरा पैर काम नहीं कर रहा मम्मा सब ठीक तो है ना तो ठीक क्या हुआ कुछ नहीं पाई
डॉक्टर साहब मेरी बेटी ठीक तो हो जाएगी ना, उसे क्या हुआ है?
देखिए आपकी बेटी को टीए केवल स्पाइनल कॉर्ड इंजरी हुई है। इंजरी काफी सीरियस है बट हाँ अब काफी स्टेबल है। हमारा फोकस अभी उसकी सेफ्टी, स्टेबिलिटी और रिहैबिलिटेशन पर होगा।
So Riya, what was your previous occupation?
So, painting. All I think about is painting. Painting was my life.
Yeah, I'm not a painter like you, but I have tried painting. So you have to continue the painting, okay?
No, I am making you remember what is still yours. Don't paint perfection, paint stability, paint balance, paint endurance.
Amma, after you left, my life has changed upside down. Everything around me felt unsafe and empty. My mind wouldn't let me sleep. I have lost everything in my life. I'm scared of my life. I don't know what to do. I feel like I can never be the person I was before. I have lost hope and I feel like ending my life. How happy I used to be. I will never be happy again. I miss my old good days.
What happened, my child?
These are the common symptoms of depression, and it's important that you have brought her for help. With the right support and treatment, she can recover. Along with prescribed medications, I can refer her to occupational therapy. Hi, I'm Dr. Abhiya, occupational therapist. So now tell me, how can I help you?
She stays in her room most of the time. She doesn't go out. She doesn't eat properly. Before she used to do painting and all. Now she stopped doing that also. So I don't know what to do about that.
So Karen, now tell me, what is bothering you?
Actually, ma'am, I don't know what is happening with me. I used to love painting a lot, but something has gone wrong with me. I got to know that painting is what you like the most, right? So, as an occupational therapist, I use painting as a therapeutic modality to rebuild your routine, focus, and confidence. So, let's begin. As an occupational therapist, my role is to understand what gives meaning to her life. I begin therapy by listening because healing starts when a person feels understood. As Karen was under constant stress and anxiety, I started relaxation techniques to help her calm down. The activities that once gave meaning start feeling heavy, pointless, and exhausting for her. So, I gently introduced activity scheduling, letting her take each step at her own pace. For her, painting was more than an art, it's her identity and strength. Step by step, through painting, I made her independent in her occupational performance and helped her live life again.
Hello? Hello, Kiran? Huh? There is a good news. Your painting has been selected for competition. Really? Yes, congratulations. This was one of my biggest dreams, but in the journey to achieve this, I lost the person I loved the most. This journey has taught me one powerful lesson that my mental health matters the most, and occupational therapy made me understand this truth.
Guided by the spirit of inquiry, driven by relevance, and committed to advancing the profession, we are delighted to commence the next scientific session for today, which is themed on occupational therapy for a changing world, innovation, inclusion, and functional recovery. Occupational therapy has always been rooted in tradition, with hands that heal, activities that matter, and occupations that give life its meaning. As the world continues to evolve, so does our profession. Innovation becomes our bridge where traditional wisdom meets new ideas, evidence, and technology. Inclusion reflects our commitment to ensuring that every individual, regardless of ability, age, culture, and community, has equal opportunity to meaningful participation in daily life. Functional recovery remains our core mission, restoring not just movement, but independence, identity, and dignity. To guide and to add more valuable insights to this enriching scientific session, we are privileged to have two esteemed chairpersons with us. To begin with, we have Dr. Priyadarshi Alok Sir, who is an associate professor and head of the Department of Occupational Therapy at Bihar College of Physiotherapy and Occupational Therapy, Government of Bihar, under Bihar Medical University. He has an extensive years of experience in the field of occupational therapy as an academician, researcher, as well as clinician. Possessing strong leadership qualities, he has established himself as a respected figure in his field, and his dedication to education has significantly contributed to the development of occupational therapy professionals. Joining him is Dr. Kaushik Sao Sir, an assistant professor, senior scale in the Department of Occupational Therapy, Manipal College of Health Professions, Manipal Academy of Higher Education, Manipal. He holds a master's degree in occupational therapy, child health, and is currently pursuing his PhD at Manipal Academy of Higher Education. He serves as an assistant editor of the Indian Journal of Occupational Therapy. He has published extensively in peer-reviewed journals and has multiple patents, copyrights, and funded research projects to his credit. I would now request our respected chairpersons to kindly take their seats on the dais to steer this scientific deliberation. To complement this theme, we now arrive at a session of great timeliness and profound relevance for academicians, clinicians, researchers, and emerging scholars of our profession. It is our privilege to have Professor Dr. Prakash Kumar Sir, bearing an MOT and PhD, along with an MSc from Trinity College Dublin, to deliver a talk on the topic Turning Innovation into Action, the art of winning and using project grants effectively in allied and healthcare sciences. He is also the principal and professor at Mahatma Gandhi Occupational Therapy College. May I respectfully invite Dr. Prakash Kumar Sir to kindly come upon the dais and proceed with his talk. Please, sir.
Good afternoon, you all. So, my respected senior, my teachers, and all others delegates coming from all part of our country. So, I am try to just focus few important, you can say it's a kind of tips. So, how we can, as a professional, as an OT professional, as a student, how we can proposed a proposal for the funding agency. What are the strategy so that we can easily get grants from either government or any non-government agency from private agency. So for any grants, for any proposal, any research, either it is funded or non-funded, their outcomes, their final outcomes is very important, which is important as well for our professions. So outcome of any research can be in future with some other procedure can be make as a policy, can be adopt as our ministry, our government or any other agency, any institute can adopt. So any adoption as a policy, as a implementation, which all are on the basis of research output, we can say is a evidence based output. So, okay, so first few slides, which is just explain the terminology which are frequently used. So, grants can be anything, grants, any proposal, any project, any concept. If we prepare, if we proceed, if we targeted for the funding, that is a grants. Any ideas can be if funded by any agency, that is a grants. So research, any research or hypothesis, and maybe acquisition of any instrumentations or any kind of outcome measure scales or any tools. So grants always awarded to some person or any institution. It's not necessary key grants is only funded to any person. Grants can be funded to the organization too. So any person, any organization is there to receive the grants funds. And every grants have deliverable, that is a outcome results. Example, we can see there are number of grants, ICMR, DST or other agency have give. But when we called a project, this is a grants. But project is the same. It's a part of the grants, planned set of activity. When we receive the grants, for example, or maybe when we approach for the grants, in both situation, the documentation parts of our ideas, documented view of our ideas is a project. So in normally we can sometimes we say project. So project is the same, same as a objective research methodology, everything will be there. Again, funded or non-funded. Next one is fellowship. Fellowship, and sometimes we call as a scholarship. So what is this fellowship exactly? For fellowship, generally fellowship is awarded to some prestigious organizations for higher professional advanced skills. Fellowship is generally preferred for postgraduate or maybe postdoc student for PhD. So fellowship is for if person, if researcher need any advanced skills in any other profession, so he can apply for the fellowships. Again, awarded for the individual, no organizations, may or may not involve a defined project. It's not necessary every fellowship have a proposal, every fellowship have a project. It's not necessary. Fellowship may be just awarded to train functional MRI skills. Example, postdoc fellowship or other different types. And same, in the same way, there is a scholarship. Scholarship is a scholarship mainly for the basic skill learning, scholarship given for the undergraduate student. It's a kind of educational assistance scholarship, if we say. But in fellowship, it's a research scientific based approach. So there is so many tips existing in our literature, in our website, Google's, you can find number of tips. But important things, these are the documents. What documents you need to complete before you apply the grants? That is a covering letter, one project summary, and project. In this project, everything is in detail. So some others, budgets and some flow chart kind of things. And if any other financial assistance, maybe partial assistance you already received for the same concept, same ideas, you need to explain. So project summary, coming on the project summary, what is this? This is the first, this is the things your reviewer read. One page is enough that summarize your everything. Reviewers have no, reviewers have not enough time to read your complete projects. So project summary is very important. You try to explore, you try to explain all your ideas within one page. So this is important. Stage writing, writing, pre-writing, review and complete writing, and then revise with your mentor, maybe with your senior faculty, maybe some other professional who have expertise in the research. One important area, always you when you write a project, you please consider always your audience. Audience means not your populations. Audience from here, I mean to say, audience is your funding agency. What is your funding agency expectations? For example, ICMR or DST or any other agency. So always look what are the objectives of their funding agency. What are their goals? What government have decided? In which area they have proposed some plan. So look out the audience. It's not like you already make a proposal, means earlier you make a proposal and same proposal you submitted to the ICMR, DST and others fellowships. This is not the way. For individual funding agency, you plan individually and discuss with your other teams, look their criteria, their reviewers. Sometimes funding agency have also mentioned the reviewers profile. Then again you look out their reviewers profile, what are their background, what are the skills and their research scientific skills. So for successful grants, yes, we need to support from our organizations topic carefully. Obviously we need to some preliminary data analysis, scientific methods. Always the established format. Every agency have different format. You need to fit and that format. Well organized, scientifically organized, peer review, always in mind, always check who will be review your projects. And if you don't succeed, again try again. So some homework before you submit the proposal. So coming on this, that homework, one is the reviewer. There is a two types of reviewer in any grants. For example, if a government kind of agency, the reviewers are from different backgrounds. Different means biological backgrounds, basic science background, maybe clinicians or maybe other technicians. Technician means technical expert, means maybe some from IIT. So if what is the reviewers motivations, if they have given some targets, so if the reviewers work for the funder, means if they bind from the funding agency, then select that project which is likelihood of achieving the funding agency priorities. Always they fix on their priorities. But in some international projects, maybe if you look the Melinda Gates Foundation or maybe Marie Curie fellowships, in that any European or US Fulbright, Nehru Fulbright scholarship. So in this grants, volunteers have from different background, they are not bind to their funding agency. So they have motivation, they always select the quality projects and provide a service to their field. Always keep with the latest research. They have more aggressive reviewers. And reviewers always means, especially for our occupational therapy field, I never face any reviewers from our occupational therapy background. This is the very common things. Yes, for clinicians, the reviewer may be clinician, but if we apply for grants for ICMR or any agency, it's means rarest chance other side maybe occupational therapists are there. So always keep in mind, the experts are not our research field, have a lot of proposal in the relatively short times. Maybe they can review anywhere. So we just focus on one page summary. That's why. 4 questions that is important. What are write a proposal? When you write, not write a proposal, when you write ideas, when you just start the idea, conceive the idea. So first, what are you trying to do? For example, I am trying, the project will demonstrate that law of gravity is applicable to orange. If this is my target. Apple is proven. Our target is to demonstrate that the law of gravity is applicable to orange. Then how it's done today? And what are the limits of current practice? Challenges, gap. Currently the law of gravity has been demonstrated as applying to apple. While apples are an important fruit, gravity has not been shown to be applicable to other fruits, specifically the orange. Yes, we just try to justify there is some gap. Next, what new in the approach and why do you think it will be successful? Example, based on the law of gravity, on the hypothesis, our approach differs in use of orange rather than the traditional apples. We believe orange will be successful on the basis of law of gravity as they have been observed falling from trees similarly to the apples. And last one, who cares? Means, for example, if it succeed, where it get benefited, who is the beneficiaries? Yes, thus demonstrating the law of gravity with orange is important because successful completion of this research will revolutionize orange farming by. This is because of this is why we should give money to drop orange off the buildings. So this is a simple example. And what are the risks? So you need to explain the risk. Is any risk or any kind of maybe complex potential risks, you need to justify or explain. This project depends heavily upon the availability of oranges. If adequate supply of oranges cannot be obtained, grapefruits will be suffice, but with less impressive splatter. The risk of inadequate supplies orange is greater. So this is kind, you just justify what are the risk and what are the strategy to accommodate. What are the midterm and final exam to check the success? For example, if this is another questions, means where you have to check the efficacy, you can say like deliverable efficacy. So by the end of year, thousands oranges of building, when we project is completed, we will evaluate our result upon whether we have successfully demonstrated gravity applicable to the orange. And now this one example, and with the example we just justify our ideas can be feasible or not. This idea can be usable, applicable, or maybe adaptable, maybe achievable or not. So one, this you all know SMART goal. Our objective is based on the SMART goal: specific, measurable, attainable, relevant, and timely. Few important points: do not use big words in your project. Either when you make a synopsis or project or maybe dissertations, this is the common rule. So unnecessarily avoid big words. For example, this project will elucidate the theory of science. The broader impact activities will allow student to experience visual impressions of a working lab. So just this kind of statement you just avoid. Next, do not use grandiose language. Grandiose language is like, if we suggest that this project will solve climate change and end of the world hunger. So this kind of statement you avoid. This is not easy. We are doing a research. We do not do any invention. So we always think before we write a research or research project, always once time every researcher thought ki yes, this can be a first time, like Edison, we invent a bulb. No, we just do a research already happened, already in existing in the literature. We just to justify with some new originality, new novelty. Avoid run-on sentence, not like this kind of paragraph. This is monotonous paragraph. And another word, avoid wall of text. So don't build the wall of text. Minimize, use bullet form, use summary, use the basic concept. No need to make an article like a project may, we don't never expect you write a literature review like a systematic review. So there is another example, make the reviewer interfering man based on the prior research. If we say, we generally write based on the prior research, the next step is obviously avoid this thing. Once process A has been completed, we will begin work on process C. No. Based on the prior research, the next step is you mention. This is the next step. After step A complete, then we will move to step B. Step B have this objective, and this objective we complete through this methodology. Every objective have a different methodology. So format. Now I am giving a standard one format, which is abroad everywhere use. You can use for national or international. So there is three component: excellence, impact, and implementations of any project. What is the excellence of your idea? What's impact to the target population, and how it will be implemented? So in excellence, there are four important points. Quality, innovative first. qualitative innovative aspects and credibility of the research. In this, second is the clarity and the quality of transfer of knowledge. Transfer of knowledge between host institute and the researcher and vice versa. Third one is the quality of supervisor and quality of your team, of your organizations. And fourth point is capacity of the researcher to complete this project. So for example, in quality, innovative aspect and credibility, there is 5 points. So first, again, there is a means everyone have a thought, introduction, background, state of art is kind of same thing. Introduction have different, in state of art have different concept. When we thought about the introduction, the sets of context and importance of the problem means you explain the burden of situation, you explain the burden of any populations. In introduction, you need to answer why this problem important and worth funding. Why, what is the burden for our society? For example, autism or any case, you explain the burden of situation and why it is important. And again, you also explain that through funding, maybe it can be resolved. That includes background of the topic. In the introduction, you need to background. You write the backgrounds, magnitude, relevance, focus on what is the problem, why does it matters. So for example, I'm just giving one example. Preterms neonates are at increased risk of feeding difficulties and neurodevelopmental delay, leading to prolonged NICU stay and long-term functional impairment. Early occupational therapy intervention play a crucial role in optimizing developmental outcome. Sensory motor approach is already, however, unexplored. So our target is in NICU, we try to focus on feeding difficulties and neurodevelopmental neurodevelopmental strategy. There are two focus. So what is in the state of art? Now coming on the state of art. The state of art demonstrate what is already known, what has been done, and what is missing. Means in the state of art, we try to find the research gap, answer what is the current best knowledge and where is the gap. Include summary of everything, focus on evidence based. Now for the same example, evidence supports the effectiveness of PYOMI in feeding difficulties, readiness and oral skills, and sense-based approach for sensory related, sense-based for the neurodevelopmental strategy. However, current literature largely evaluates this approach independently, and our target is combined effect. So this is, we can make a title, and on the basis of, this is not title, this is an introduction, state of art. So in this state of art, we focus to explain in this way. Already existing, what we are trying to do. What is the novelty, originality. Next is the objective. Objective based on the SMART. That includes maybe primary, secondary. Primary, which is your main target, main goal, and through primary, if anything possibility to outcome maybe you expect some more result, you can count in a secondary objectives. Focus on the end points. Objective always have some end points. So example of this same first objective, impact of oral feeding readiness with the help of PYOMI. Second, neurodevelopment with the help of sense. And third, compare the outcomes when we give a combined effect. Next is the overview of the action. This terminology is very important. Objective, state of art, overview of the actions. Every standard format have this. Overview the action explain how the objective will be achieved. Means in every objective you need to route map. Means destination is your objective. This is the destination, and how you reach that destination means route map is a state of art. It's generally we include in the objective, but this is the state of art of overview of the action. Sorry. So overview the action and how objective will be achieved. It answer what exactly will be done and how will be how the project will be implemented, include study design, everything, focus on process, implementation and feasibility. And for the same example, the project will conducted as a randomized comparative interventional study among preterm neonates admitted to the NICU. Eligible neonates will be randomly allocated to receive either standard NICU care or standard care along with the PYOMI and sense-based intervention baseline and post-intervention. Then we compare after 12, 13, 15 months. So this is a overview of the action. What is your action? How it achieve? Next is the research methodology. Yes, this is common things. We all know in research methodology, design, population, scientific base, research and approach. What is different? A research methodology and research approach. Research methodology, what method and how we apply this method. That is a approach, simple. So in project, you explain, not just say this control design, how it will implement. What is this design? So you explain the method. So research methodology is a scientific design and approach is a practical execution. The study, same example. The study will adopt a randomized comparative interventional design conducted in NICU setting. Preterm neonates meeting in the inclusion criteria will be randomly allocated in this group. Intervention group receive this, control group this receive, like this. So when we do this kind of thing, this for a student, when we plan for dissertation, जब हम करते हैं, this is a approach, this is a methodology. Okay, so originality and innovative. There is another two, maybe you can say it is interchangeable words. Originality and innovative aspects of the research. What is new? Obviously, what is different? Why you research? Deserve funding. So originality refers to the novelty of the research idea, questions. And innovations, when we do in different way, that is a innovations. When we use new techniques, new scale, or maybe any new approach, maybe originality. But if it is not possible, then we can do the same approach in different populations. When we can use the same research using different instrument or scale, that is a novel, innovative aspects. So focus on contribution to the knowledge and filling a clear research gap. So when in the previous study, independently when demonstrate the PYOMI and the sense, it's already proven there is a limited evidence that examining the combined effect, then we have target combined effect. This is a innovative aspects. Okay, so interdisciplinary, then is another things we need to focus nowadays from last 3-4 years. Every government agency only focus or only target that fund projects in which there is a interdisciplinary aspects. So how knowledge, method, perspective, different discipline, shared problem means it when we interdisciplinary means our problem can be shared, our result can be shared, everything we shared. If problem is complex, there is a solutions from every backgrounds. Discipline involves role of each disciplines. Example, in the same example, we need to contact neonatologist, occupational therapists, physio and nursing, other professions. So we need a interdisciplinary aspects, carries possibility in collaboration opportunities. So we government or any funding agency never expect like you are doing a research for the social cause. No. Everyone doing a work for some personal interest. So no need to hide. No. This is I am doing this research for the betterment of this community population. No. Government expect what is your intention, how your skill can be achieved. You need to explain clearly, crystal clear. You need to explain. So career possibility, what is the career possibility with these projects? Career possibility means how this project builds human capacity and creates sustainable academic sustainability. Means through this projects, in which area, means for example in autism this behavioral this symptom can be achieved in next 3 years, next 5 years. Maybe the we can use the same concept from the other state, other population. So sustainability. Career possibility referring to training skill development, professional skills, includes research skill developments, progression, leadership, mentoring, all are your skills. Focus on capacity building and collaboration opportunities. Yes, government look what is your capability to collaborate with other organization as well other professionals. So next is this excellence part is, first part is cover. Second part, now I am fast forward this content. Second part is the clarity and quality of transfer. Clarity and quality of transfer, the same is how researcher can benefit it from the host institute. If I am doing a research in AIMS Bhubaneswar, so how I can benefit it to do this research from AIMS if the same concept I replicate to the other private organizations. So you explore what is the benefited I expect from the host institute and benefited to the host institute. Again, we have to explain aims, how aims will get benefited, what benefits here may be aims through this research. Yes, there is a institute gain capacity, reputations, sustainability from hosting. If you do some policy, make a policy, make some protocol, institute gain, the organization can replicate your program in next few years. So institute get benefited, and this all benefited we need to document. Next is the example of benefit. There is example researcher get benefited and maybe host institute some benefited. Third area, quality of the supervision. Quality of the supervision means quality of your supervisor, as a supervisor, as a principal investigator, your quality, you demonstrate, you explain everything, what is your publication, what is your expertise, any skills you needed, maybe needed, or you already achieved some skill, detail academic and scientific your experience. Hosting arrangement means yes, you also explain the characteristics of your host institute. Yes, this research can be only possible because this instrument, this kind of facility, this kind of lab is there. So you need to explain this. Capacity of the researcher to reach. Yes, always funding agency looking is achievable or not. Otherwise, before reading the concept of your ideas, these things are very important. Next one is after excellence, there is an impact. In impact, enhancing the potential and future career prospect of the researcher. What is the impact of your fund grants? Impact on personal researcher, on impact on the society, on the community, and quality of the proposed measure to communicate. Just in one slide. First impact, how effectively the research result will be used, shared, and translated into practice, not merely published. Just publication is not impact. Impact, when your research is beneficially, research can be useful for the society. That is the impact that grants funding agency expect from the researcher. Just when you say ki 3-4 publication after this is my deliverable, no funding agency give funds for do these things. If impact for the society, or maybe for you are you are going to conduct some seminar, some for public lectures, or do some workshops. So this is the impact. Enhancing the potential and future career prospect of the researcher. Yes, in the your proposed action will strengthen research long-term career. You need to explain. Now, third is the quality of the proposed measure to communicate actions into different target audience. You need to explain. And the third area is implementations. In implementations, overall coherence and effectiveness of the work plan that include appropriation of the allocation of task and resources. Means now in this area, implementation, now reviewers say everything is okay, chalo theek hai, ye acha hai, acha hai. Ab start kaise kare? From where we start? Where is your instrument? आप मुझे instrument दिखाओ. Is skills is there, place is there, everything. So, for example, logically structured, feasible, time-bound work plan. Everyone knows. We need to share what is the logical timetable work plan for 1 or 2 year, 3 years research. Next is the appropriateness of the management structure and proceed. Means you need, we need to explain ki yes, our management, we have a ethical committee, we have a research body, we need, if we have a biostatisticians, when we need support, everything is there, explain. Appropriateness of institutional environments, everything, administration and account sections are there, where is the fund coming, how is dispersed, this is need to explain. So this is this this is a standard format of when for any projects, either ICMR or in abroad, we need to explain in this format what work package. It's an important term, work package, titles. You define on the basis of objective. In every objective, maybe you can define 2, 3, 4 work. In one objective, 2 work, 3 work can be there. And for every work package title, then this is based on what objective. You just mention this work is based on this objective, and for every work, then again you mention the task. So this is a task, means review literature is one task. We need to complete the data sample size calculation, maybe a different task. And deliverable, what are the deliverable? Say everyone expect benefit kya hai? For every benefit, for researcher, for funding agency, for community. So for every objective, maybe 2 or 3 work package is very common. 3 work package is standard work package. And for every work package, you need to discuss at least 3 deliverable. Deliverable can be a publications. Deliverable can be a report. It's a protocol, anything. So you mention. And next is the budget. Yes, budget is different budgets. Budgets involved maybe for the instrument purpose, for the manpower, budgets for the contingency budgets, may be recurring or non-recurring. It depends. Some other budgets like a travel budgets, you can mention travel. Justification for every budget is important. Justification. Without justification, no meaning for the funding agency. And some institutional overheads, every means 5 to 10% is vary, depends on the administration. And this is the last one, we all knows. We need to explain for every projects. This is a chart, Gantt chart, for every activity, for every work plan. Make a different work, WP1, WP2, WP3 likes. Progress monitoring every quarterly, or sometime is a half yearly. We need to progress monitor, deliverable, milestone achieved. Whatever you decided earlier, this is a milestone. And milestone, you make a time frame ki in this month we published one paper like this. This is a milestone. Conference, seminar, and public engagement. These all are the part. Public engagement is very important for any government grants. That's it. Thank you.
Thanks, Dr. Prakash, for your valuable talk. If anyone wants anything more about the research, can contact Dr. Prakash in sitting there areas.
Thank you, sir, for that highly insightful and thought-provoking session. Now, I would like to request our honorable chairpersons, Dr. Priyadarshi Alok sir and Dr. Kaushik Sao sir, to please felicitate Dr. Prakash Kumar sir. Thank you, sir. May I please have your attention? There is an announcement. Those who have not submitted their presentations for the scientific session 7, which is scheduled to be held tomorrow, are kindly requested to submit the presentations in the backstage at 3:15 p.m. today. Now, may I respectfully hand over the microphone to our honorable chairpersons to lead the session further.
Good afternoon, everyone. Without any further delay, with the permission of the chairperson, Alok sir, we are starting the session 5, so which is occupational therapy for changing world, innovation, inclusion, and functional recovery. So I'll call first presented Dr. Trupti Priya Naik. So you can see there is a timer is there. Okay, next to your presentation board, there is a timer. Left side. Okay. You can see? Yes, you can start.
A very good afternoon to everyone present over here. My topic for the presentation is effect of work simulator guided therapy on functional disability and walking ability in persons with chronic non-specific low back pain. My guide was Dr. Jitendra Mahapatra sir and my co-guide was Dr. Shreya Bishwas ma'am. So coming to the introduction, pain is an unpleasant sensory and emotional experience that is connected to actual or potential tissue damage, and it is classified based on its location in the body. Low back pain is defined as pain localized between the 12th rib and the inferior gluteal folds, which may or may not accompany the leg pain. With the duration of pain, it is classified as acute, that is less than 3 months, subacute between 3 to 4 months, and chronic more than 6 months. Then coming to the pathology, specific and non-specific. The specific low back pain refers to destructive diseases such as disc herniation, spinal stenosis, etc. Coming to non-specific, no identifiable pain source is found here. All the specific red flag conditions were ruled out, such as cauda equina syndrome or any neurological deficits. This type of back pain does not have identifiable cause. How low back pain causes disability? According to the World Health Organization International Classification of Functioning Model, they have identified disability into 3 categories. The first one is impairments of the body functions, and the second one is body structures. The third one is the limitation of activities and participations. The disability becomes the outcome of an interaction between the health state of an individual and the overall context, overall environmental context. So it has become necessary to evaluate the functional disability in the low back pain in the studies. Now, how walking is affected in the low back pain. Low back pain is a fundamental means of human mobility. As in low back pain, musculoskeletal tissue is common. It is significantly impaired. So the physical function is impaired. Individuals with LBP typically cover shorter distances as compared to the individuals who do not have low back pain. According to Suzanne N. Greenberg, he aimed helping clients with LBP to return to work using the work simulated Eisenhagen work system functional capacity evaluation. He proved that work simulators do have an impact in improving the physical function and the reintegration to work. Our goal was to integrate the Baltimore therapeutic equipment work simulator program along with the traditional occupational therapy, which includes mat exercises and Swiss ball exercises. Review of literature. I had took the conventional occupational therapy from the article that was written by Ravi V. Watamba et al. In 2012. He mentioned that there was a significant improvement using the conventional mat exercises and the Swiss ball exercises along with yoga. The second article was Ellen Lee Morin, J. Simons et al. In 2002, he mentioned the perceived gait ability and the endurance used in the working ability. Next is the Susan N. Greenberg. In 1996, he mentioned a case study on low back pain from which we took the work simulator, which helped in conducting the low back pain intervention. Study rationale. My aim was to determine the combined effect of work simulator guided therapy along with the conventional occupational therapy versus the conventional occupational therapy alone on the functional disability and the walking ability in persons with chronic non-specific low back pain. Experimental hypothesis was there is a significant effect of work simulator guided therapy along with the conventional occupational therapy, and the null hypothesis was there was no significant effect. Methodology. Study design. It was a pre-test and a post-test design. The study population was 30 patients with chronic non-specific low back pain. The inclusion criteria were chronic non-specific low back pain for more than 6 months. The person should understand and follow all the verbal commands. The age criteria was 30 to 60 years. Both male and females were included. No history of treatment of BT work simulator in the past. Next is the exclusion criteria. The hip flexors, abductors, and the plantar flexors should not be less than 3+. The women who were pregnant were excluded. Coexisting major medical conditions, any contraindication to general exercise, no radiculopathy, and no previous history or surgery of the individual. The visual analog scale should not be more than or equal to 7. Next are the scales. First is the Oswestry Disability Index Questionnaire. It includes 10 questions which were pain intensity, personal care, lifting, walking, sitting, standing, sleeping, social life, traveling, employment, or homemaking. The disability scale, the scores were 0 to 50, which included 0 as no disability and 50 as completely disabled. Lower the score, less is the disability. Then is the 6-minute walk test, which was used to measure the endurance of the person. It was the distance was measured here that was covered by the individual. 10-meter walk test, it was measured for the speed of the walk. It was measured by the time. Next is the procedure. Sample of convenience were recruited from the OPD and the Department of Occupational Therapy, NILD Kolkata, diagnosed with chronic non-specific low back pain. After general screening using visual analog scale, MMT, and straight leg raise test, they were randomly allocated into 2 groups. 15 patients were under control group, whereas 15 patients were under experimental groups. On the first day, a baseline evaluation was conducted, which included the Oswestry Disability Index, 6-minute walk test, and 10-meter walk test. This was the pre-test. Then coming to the last day of the therapy, the control group was the intervention. It took only conventional occupational therapy for 40 minutes, 3 days per week for up to 4 weeks. And in the experimental group, work simulated guided therapy, it was for 20 minutes, along with the conventional occupational therapy, which was for 20 minutes. It was also for 3 days per week for up to 4 weeks. On the last day of the 4th week, the post-test was conducted and the results were compared. These are the images. The first one is the Swiss ball. The conventional occupational therapy included the mat exercises, which included SLR. One is of 30 degrees, another one is of 45 degrees. Bridging, bird dog exercises, which has back extension in forearm, weight bearing, alternate arm, leg raise. Swiss ball therapy, and next is the Baltimore therapeutic equipment. It included trunk flexion, extension, hip flexion, abduction, extension, knee flexion, extension, plantar flexion. These are the images. Now coming to the data collection. The data collection was done by IBM SPSS statistic version 25. This is the Oswestry index. The Oswestry index, we used Wilcoxon signed rank test and Mann-Whitney U test. This showed that the experimental group shows better result, and in the 6-minute walk test, we used paired t-test, independent t-test, which also showed experimental group was the better, has a better result. Then coming to the 10-meter walk test, it also had the experimental group shows the better result. The result and the discussion, the walk simulator guided therapy, it had reduced the disability up to 34%, and it has increased the distance up to 99 meters and decreased the seconds up to 11 seconds. So definitely the experimental group has the better result. The conclusion, the study underscores the potential of the work simulator as a valuable adjunct in the management of chronic non-specific low back pain, paving the way for more integrative and effective treatment strategies. These are my limitations. It included the limited number of participants, blinding was not done, the shorter intervention period and no follow-up period. The external factors were not controlled in the study. These are my references. Thank you.
Yeah, next presenter is Dr. Chetna.
Imagine suddenly you have to relearn how to write your own name, not as a child, but as an adult. This challenge is an reality of many individuals with brachial plexus injury, and where this study begins. I, Chetna Balai, today my study title is Effect of Pencil Gripper and Hand Dominance Transfer Training on Non-Dominant Handwriting Performance in Brachial Plexus Injury Patients. So brachial plexus is an essential for upper limb function. An injury to this network will result in profound impairment that significantly limits an individual's ability to perform activities of daily living. So there are 2 studies from the North India and Tamil Nadu tertiary hospitals, which shows that the most people with brachial plexus injury are men aged between 21 to 30 years. About 63% have injuries on the right side, and many of them suffers pan plexus injury. So in brachial plexus injury, there's generally a permanent disruption of the function of the affected limb. So loss of the function of the dominant upper extremity will render the person to face the double challenges. First is to carry out the function of the dominant limb with the non-dominant upper extremity and to accomplish the bimanual task with the non-dominant extremity. So after the injury of the dominant upper extremity, the patient used non-dominant hand for all the functional activities. This force shift is generally referred to as injury-induced hand dominance transfer. This is an area of concern for many occupational therapists who work with patients with sustained injury to their dominant upper limb. The aim of the study is to find out the effect of pencil gripper along with hand dominance transfer training in improving handwriting of non-dominant hand in traumatic brachial plexus injury. The objective was to measure the improvement in handwriting components such as legibility, speed, pen control, and pen manipulation. The rationale, as the injury altered their perception about themselves, their previous role in the community, family, school, and they find it difficult to get back to their previous occupation. Their sense of autonomy have been given up. So due to the functional loss of dominant hand, the one-handed activities and hand dominance transfer training crucial for the patient to make them independent. So one of them is the handwriting. It is an important component for them so that they can be able to write their examination, copy the notes for their classes, sign the official documents, and pick up with their colleagues. So therefore, hand dominance transfer training becomes an important factor for the rehabilitation. The hypothesis, the alternative hypothesis states that pencil gripper use combined with hand dominance transfer training significantly improve non-dominant handwriting performance in patients with brachial plexus injury. And the null hypothesis states that pencil gripper use combined with hand dominance transfer training has no significant effect on non-dominant handwriting performance in patients with brachial plexus injury. Methodology. Study design was pre-test, post-test, quasi-experimental design. Sample size was 30. Sampling method was convenient sampling. Place of study was outpatient department of tertiary hospital. Variables, independent variable were pencil gripper, hand dominance transfer training, and dependent variables were handwriting. Selected criteria, inclusion criteria was dominant side brachial plexus injury, age range were 18 years above. Both the genders were included, male and female, ability to follow simple instruction, and the client should be literate. Exclusion criteria, non-dominant side brachial plexus injury, not able to follow instruction, not literate. So the procedure, they were assessed for the eligibility by using the two screening tool. First is a modified Edinburgh handedness inventory, which has 12 components, which includes the preference of the used hand for cutting the vegetables, toothbrush, or combing the hair, and then the MMSC. Then the convenient sampling was done. They were allotted to the group 1 and group 2. For the group 1, a therapeutic intervention with peer-shaped pencil gripper were given and with the handwriting protocol. And for group 1, the home program without pencil gripper were given. They were analyzed for the outcome measure of handwriting assessment battery for adults, version 6, as a primary outcome measure, for which 12 worksheets per day for 6 weeks has been given, and after 6 weeks, post-tests were taken and data analysis were done. For experimental group, the intervention has been divided into 6 weeks, and each week contains of different exercises. So in week 1, there was a foundation. During this first week, therapy focused on improving grip, posture, hand stability, basic motor control of the non-dominant hand, in which the subjects perform warm-up exercises such as finger tapping, wrist movements, squeezing a soft ball, along with basic pencil holding practice, line tracing, simple strengthening activities. In week 2, basic strokes were initiated, which training emphasized pre-writing strokes which required for letter formation, such as drawing circles, loops, waves, diagonal lines, shapes, progressing from tracing to copying, and independent writing to improve control and coordination. Then the week 3, lowercase letters were initiated, practicing by grouping them according to similar movements patterns, such as subjects traced, copied, and independently wrote letters on line paper with emphasis on rhythm, consistency, and proper letter formation. The week 4, uppercase letter and letter combination were initiated. Then the week 5, sentence writing and speed training for the handwriting legibility, endurance, and writing speed, and subject practice writing common words and simple sentences and perform timed writing tasks to gradually increase speed while maintaining clarity. Week 6, in which the fluency, endurance, and function writing were initiated, and which placed on fluent and function writing. Paragraph writing, everyday writing tasks such as filling forms and writing notes, and continuous writing exercises to improve endurance automatically of the non-dominant hand. For the control group, the group received home treatment to write words or sentence from the newspaper books without a pencil gripper. Data analysis were done using IBM SPSS version 30. The level of the significance was set up less than 0.05, and the independent sample t-tests were applied for continuous variables with approximately normal distribution, and Mann-Whitney U-test used for ordinal data, which is for the pre-writing legibility. So results, a total of 30 right-handed patients were participated with exonotomosis and neurotmosis, in which 29 were males, 1 were female. They were divided into 2 groups, and in the experimental there are 15 males, and in control group there are 1 female and 14 males. This is the comparison between the post-test of the group 1 and group 2 in 4 variables for the pen control, pen manipulation, writing speed, and writing legibility, in which you can see group 1 has significant better improvement in first 3 components, but there is no significant improvement in the legibility. So discussion, pencil gripper along with hand dominance transfer training in improving pen manipulation, pen control, writing speed, and legibility of non-dominant hand in brachial plexus patient has improved. The statistical analysis between the groups shows that the experimental group has highly significant improvement in the 3 components as compared to the group 2, but no significant difference has been found in writing legibility. The result of this study support the alternate hypothesis that pencil gripper along with hand dominance transfer training improve handwriting of non-dominant hand in brachial plexus injury. So the probable mechanism of improving the pen control, manipulation, writing speed, and legibility could be explained by the activity-induced neuroplasticity and task-oriented approach, and which has guided the client through the visual tracing of their improvement. So this supports the broader principle that the skill acquisition and motor learning occurs more efficiently through task-specific repetitive practice. So limitation of the study is that the study was conducted only in a small size of population. Sample size was collected in a confined geographical area. Lack of maintenance phase after the intervention. Short intervention duration may not have been long enough to observe sustained long-term improvement. And the study assessed handwriting performance only in English, which may not be reflect outcome in other languages with different script or letter forms. Future recommendations should include a larger and more diverse group. Should compare different types of pencil grips, hand training techniques to identify the most effective approach. Further studies could compare handwriting improvement across different languages to assess if the result apply beyond English. So the conclusion of the study is that combined intervention of the pencil gripper use and the hand dominance transfer training significantly improve handwriting in individuals with BPI using their non-dominant hand, and the result indicate improvement in grip stability, write fluency, and overall handwriting quality, and this supports the effectiveness of assistive tools and structured training in occupational therapy for patients with upper limb impairment, and the findings highlight the importance of individualized task-specific rehabilitation. Thank you. These are my references.
Thank you, Dr. Chetna. Next presenter is Dr. Sobika.
So good afternoon, one and all present here. I am Shobika. My topic is about the development of cutoff score for the school readiness inventory for preschoolers with autism spectrum disorder, SHIPA. Introduction. Autism spectrum disorder is a lifelong neurodevelopmental condition that typically appears before the age of 3. It is mainly defined by challenges in social communication along with restricted or repetitive patterns of interest and behaviors. The other concept is school readiness, which has been broadly defined by Snow as a set of competencies a child should possess upon entering school that are essential for later achievement. Children with ASD often face unique challenges in adapting to formal educational settings. So the SHIPA consists of 93 items, each rated on a 6-point Likert scale. from 0 to 5, with a total score ranging from 0 to 465. The score is mostly used as a continuous variable, yet no valid cutoff score has been proposed. So the use of continuous value is inconvenient in decision making whether to put a child in school or not in the transition program. A cutoff score serves as a threshold that differentiates individuals based on their measured performance levels, allowing for meaningful interpretation of results. So this research focuses on the development of a cutoff score for the SHIPA, aiming to bridge the gap between assessment and intervention and to improve educational outcomes for preschoolers with ASD. Rationale for the study: parents of children with ASD often seek clarity on whether their child will be able to attend school in the same way as their typically developing peers. While multiple school readiness assessment tools exist, very few have been developed or validated specifically for children with ASD, that too particularly within the Indian context. So, the SHIPA is designed to address this gap but lacks empirically derived cutoff scores to distinguish between children who are ready versus not ready for school. To ensure its practical utility in clinical and educational settings, it is essential to establish an empirically derived cutoff score that can help classify children into different readiness levels. Hence, the purpose of the study is to develop cutoff scores for the SHIPA scale. The aims and objectives of the study: my aim is to develop cutoff score for the school readiness inventory for preschoolers with autism spectrum disorder, and my first objective is to evaluate school readiness in preschoolers with autism spectrum disorder and also typically developing children. My second objective is to develop cutoff score for the scale by statistically analyzing the scores obtained. Methods: this is a cross-sectional survey study design, and the data was collected from children in KMCH, child development centers and preschools in and around Coimbatore. The population included children with ASD and also typically developing children. Purposive sampling technique was used. The sample size was 310 for children with ASD and 100 typically developing children. The sample size for ASD was calculated based on the prevalent study of autism spectrum disorder, and it resulted in a minimum sample size of 310. And the sample size for typically developing children was calculated based on the assumed prevalence of 50%, and it resulted in a sample size of 100. The selection criteria: inclusion criteria for ASD population included children who are medically diagnosed with autism spectrum disorder, age ranging between 3 years to 6 years, including both boy and girl children. And for typically developing children, the age range was 3 to 4 years, including both boy and girl children. Exclusion criteria for ASD population: children with ASD who are diagnosed to have visual impairment other than refractory errors and auditory impairments were excluded from the study. Children with associated genetic disorders, any acute illness, systemic disease, and neurological abnormalities were also excluded from the study. For typically developing children, children who are diagnosed to have visual deficits other than refractory errors or auditory deficits are excluded from the study. So, data collection procedure: the research protocol was reviewed by the Institutional Scientific Research Committee and the Ethical Committee of the institution. Approval was obtained from both the committees, and an informed consent was obtained from the child's parent as well as from the concerned centers to conduct the study. So this is the flowchart of the plan. Based on inclusion criteria, 310 children with ASD and 100 typically developing children were recruited. Consent was obtained from the participants, that is, from the parents and the concerned centers. SHIPA was administered, and the obtained scores were statistically analyzed, and the cutoff scores were developed. So this is the data analysis and research. These tables represent the participant characteristics. The majority of the children included in my study were male, and majority of them were coming from a nuclear family. Most of these children reported to have no siblings at all. And getting into the schooling status, out of 100 typically developing children, 98 children were attending mainstream school, where they have just entered the preschools, and 2 children were not attending any schools at all. Whereas in the ASD group, they were spread across daycare, special school, inclusive school, mainstream school. And there are 33% of children who were not attending any school at all. And Tamil is the majority of the language spoken by them. And coming into the stereotypical behaviors, all the 310 children in the ASD group had the stereotypical behaviors, where none of them in TD has these behaviors. So this graph represents the mean and standard deviation for the SHIPA scores. The mean and standard deviation scores for SHIPA total were consistently higher for typically developing children than for children with ASD. Further analysis by gender resulted that both male and female typically developing children outperformed their ASD counterparts with markedly higher group means in the typically developing sample. No substantial difference was noted in SHIPA means between the ASD males and females. SHIPA total scores were also examined across distinct age bands. In the ASD sample, mean SHIPA scores increase steadily with age, suggesting greater readiness in older children and thereby indicating developmental progress with age. Among TD children, the mean score for youngest group was substantially higher than all the ASD age bands. So this table represents the mean and SD for all the domain-specific scores of SHIPA. Across all 9 domains, mean and standard deviation scores for SHIPA were consistently higher for the typically developing children than for children with ASD. So further breakdown by gender showed that both males and females scored similarly on SHIPA domains, with group differences between ASD and TD being much larger than the within group gender differences. So this table shows the mean and standard deviation for the SHIPA total and domain-specific scores, which are calculated from the scores of typically developing children. We have also calculated -1 standard deviation, 2 and 3 standard deviations in order to develop a cutoff for the children with ASD. Here we considered -1 SD and -3 SD scores as cutoff scores to categorize children with ASD into 3 school readiness levels, which is ready, ready with assistance, and not ready. So this is a cutoff score which have been developed. Children who are scoring between 0 to 325 will be considered not ready for formal schooling, and who are scoring between 326 to 378 will be considered as ready with assistance, and the scores between 379 to 465 will be considered as ready for school. Similarly, this is the domain-specific cutoff score which have been developed based on the typically developing scores. So this graph represents the frequency of children with ASD at different levels of school readiness, which is obtained by applying the cutoff score developed in the ASD sample of this study. When categorized using SD cutoffs, the majority of children with ASD were classified as not ready, and only a small proportion were considered as ready. A within-group comparison of school readiness scores among children with ASD based on age was also done. The within-group effect for age on SHIPA total score was highly significant, with the p-value was less than 0.001, indicating that school readiness differed meaningfully across age groups among children with ASD. The ANOVA research demonstrates that school readiness and all underlying domains improve significantly with age among children with ASD. The differences in mean across age groups were of sufficient magnitude to yield strong statistical significance in every area of readiness, including language, cognition, numeracy, and adaptive skills. Getting into the discussion part, using the standard deviation-based thresholds established from the typically developing group, 3 distinct categories were defined, which is ready, not ready, and ready with assistance. So application of these empirically derived cutoffs indicated that a large majority, that is 89% of children with ASD in this sample, were classified as not ready for formal schooling, with only 7.1 falling under ready with assistance and a mere 3.9 in the ready category. Similarly, Mukri et al. Stressed that the substantial readiness gap between ASD and TD groups, highlighting the need for measures sensitive to the unique learning profiles found in autism. Notably, domain-level analysis revealed variable profiles where domains such as expressive, receptive skills, and social-emotional domains saw nearly all children with ASD in the not-ready group, whereas a higher proportion showed some readiness or emerging competence in domains like attention and memory, general knowledge, and fine motor skills. Age-specific analysis show incremental improvements in school readiness scores among older children with ASD, supporting the notion of developmental progress with age, but also highlighting the persistent deficits relative to typically developing peers. There is no significant gender difference emerged either for ASD or TD groups in both the total and domain-specific scores. So this result concurs with Shaman and Bate, who found that gender is not typically a major determinant of school readiness in ASD populations, supporting the appropriateness of unified assessment standards for boys and girls. So findings by Mukri et al. And Missel et al. Also affirm the importance of validated local cutoffs for the Indian contents, where imported norms may not fit the demographic and educational realities of Indian preschoolers. Concluding my study, this study has successfully developed a cutoff score for the SHIPA scale, facilitating classification of school readiness among children with ASD. The findings indicate that majority of children currently fall with the not ready category, underscoring substantial needs for early and targeted intervention prior to transitioning into formal educational settings. Limitations. The study included only a limited sample of children, and there is lack of follow-up data. So recommendations of future study should include a larger and more diverse samples and should employ external criteria to enhance robustness of cutoff. These are my references. Thank you.
Thank you, Dr. Sobika. Now, Dr. Roshni.
pen drive.
We are sorry to announce that there is a technical glitch. We'll proceed in 2 minutes. Sorry for keeping you waiting.
Can you start the next one? Is it possible?
I'll just check.
Yeah, check.
Yes.
Next one, no? Yeah. Due to the technical issues, we'll call her later. Now, we want to call Dr. Jesse for the next presentation.
A very good afternoon to one and all. Myself Dr. Jhashi Guge, and today I am delighted to present a scoping review on occupational therapy interventions and alien hand syndrome. So, how does it all started? It all started with the patient coming to us on an IPD basis, and nobody of us has heard about the condition. So, then the curiosity arose to know that alien hand syndrome is a rare neurological condition characterized by involuntary purposeful limb movements where a patient's limb acts on his own, often interfering with daily functions. It was first described in 1908 by Carl Goldstein, and in 1972, Bryan and Jednach used the term alien hand for the first time. It is more common in women over 40 and often arises from a stroke or neurodegenerative conditions like corticobasal degeneration. Then the curiosity built to know more about the alien hand syndrome subtypes and their clinical features. Then, coming to rationale of my study, where neurological mechanisms have been explored, but the rehabilitative management, especially via occupational therapy, remains poorly understood. Case reports suggest certain occupational therapy strategies may provide functional control, but no comprehensive synthesis exists. This review aims to systematically identify published case-based evidence and describe occupational therapy and related rehabilitation interventions for alien hand syndrome from 2000 to 2024, evaluate their reported outcomes, and highlight the gaps for future research. Then this lead to methodology of my study, that is RC and O'Malley's framework, right from identifying the research question, that is, does occupational therapy intervention has effect in patient with alien hand syndrome, for which I have used Google Scholar, PubMed, Webline, Embase, Scopus, Web of Science, CINEL with the term alien hand syndrome or anaric hand, and occupational therapy or rehabilitation or mirror therapy or verbal cueing or bimanual task, limited to publications between Jan 1st, 2000 to December 31st, 2024. Then articles were selected, uploaded to Convalence to screen titles and abstracts. The selection of studies for inclusion was done in alignment with the review question. The standards for reporting literature research for inclusion and exclusion of studies were used from the elements of Starlight. These are the components of Starlight. The articles included were case reports, series, experimental interventions involving alien hand syndrome and related OT strategies with outcomes reported, and purely pharmacological or imaging studies without OT component studies are excluded. Then articles were shifted, charted, and sorted according to the population, intervention, comparison, outcomes, and study design framework, that is PICO component framework. Then collaboration summarization was done to report the result. To provide insight into the publication pattern on this topic, a descriptive numerical analysis was performed for the year of publication, the study setting, the journal of publication, and the research method. The search result included certain occupational therapy strategies or interventions for alien hand syndrome and variant alien hand syndrome etiologies, intervention details, that is, type, dose, duration, outcome, follow-up, and author's conclusion. Study characteristics, cases where stroke-related alien hand syndrome, including all variants, Participant age ranged from 34 to 62 years and both sexes were included when reported. Then this is how the Prisma SCR flowchart went on, where I scanned for the database and I got 80 articles, out of which 65 articles removed before screening because they were duplicate articles, and 35 articles removed because they are not freely available. So the full text article assessed for eligibility remained 30, out of which 21 articles removed or excluded because there is no OT intervention. So the article included in the review were 9 in number. Then a thematic analysis was performed where 6 themes are identified. The first theme was cognitive motor cueing, where therapist generated or self-generated verbal commands were used to restore voluntary motor control and to reduce intermanual conflict. Second theme was visual feedback and sensory motor cueing, where mirror therapy and visual cueing help realign motor intention with perception, improving agency and coordination. Third theme was bimanual integration, where structured bimanual tasks improved coordinated use of both hands and reduced antagonistic movements. Fourth theme was compensatory strategies, where tactile input, restraining or occupying limb and positioning strategies were used to manage disruptive movements. Fifth theme was functional and ADL based rehabilitation, where task-oriented ADL-based training combined with patient and caregiver education reduced distress and improved participation. And last theme was psychosocial adaptation and education, where environmental adaptations and modified tools enhance safety and independence. Education, structured routines and coping strategies addressed emotional distress associated with the alien hand syndrome. This thematic synthesis of rehabilitation intervention for alien hand syndrome highlights the critical role of multimodal, client-centered therapy in enabling functional recovery across different alien hand syndrome subtypes. The prominent use of verbal cueing underscores its value in re-establishing top-down motor control, especially in cases involving causal disconnection. By coupling verbal commands with visual feedback, therapies appear to reinforce the alignment between motor intention and perceived movement, therefore restoring the disruptive sense of agency. Bimanual integration emerges as another cornerstone of therapy. Engaging both hands in coordinated activities may address the core disconnection in alien hand syndrome, enabling the alien limb to synchronize with intentional goal-directed movement. Despite encouraging outcomes, the evidence base remained limited to case reports and small series. Furthermore, the absence of randomized control trials or long-term follow-up restricts understanding of sustained efficacy and mechanism of recovery. Coming to strength and limitations of my study, strengths were comprehensive synthesis of OT interventions in alien hand syndrome, clear thematic analysis identifying recurring, clinically relevant strategies. There was strong OT focus on functional ADL-based insights, inclusion of various alien hand syndrome subtypes or variants, and use of structural scoping review framework, that is Prisma SCR. Limitations were there was evidence limited to case reports and small case series only. There was lack of standardized outcome measures across studies. There was heterogeneity in alien hand syndrome etiology, intervention, dosage and reporting. There was absence of control trials and follow-up data. And lastly, there was potential publication bias towards successful cases. This study recommends future studies should develop standardized OT intervention protocols for verbal cueing, mirror therapy and bimanual task-based training to ensure consistent implementation and cross-study comparability and use of uniform validated outcome measure. Secondly, prospective multi-site case series with harmonized manuals and clearly defined therapy dosage are needed to build stronger evidence for future control trials, integrating kinematic and neurophysiological tools to clarify mechanism of motor recovery. And lastly, long-term follow-up is essential to check sustained benefits and relapse factor. Use digital and technology-assisted methods to boost accessibility and sensory motor feedback. Development of alien hand syndrome specific patient-reported measures for agency, distress and functional impact. This study concludes that OT intervention, particularly verbal cueing and bimanual engagement, have shown promising outcomes in managing symptoms of alien hand syndrome despite limited data synthesized. To strengthen the evidence base, there is a pressing need for standardized reporting, consisting outcome measure and multiple case series. And lastly, occupational therapy should actively engage in documenting, analyzing and publishing data on rare conditions like alien hand syndrome to contribute to clinical knowledge and improve care practices. These are my references. And I would like to express my sincere indebtedness to Dean, Head of Department, and I gratefully thank to my co-author and my supervisors for their guidance throughout this scoping review. My appreciation goes to my colleagues for their constructive feedback and encouragement. Finally, I am grateful to my family for their constant support and understanding. Thank you.
Thank you, Jashi. Committee, can you go ahead with the current number? Is it done? Problem solved? Yeah, thank you for you. Yeah, we can call the previous. Okay. So, Dr. Roshni, would you please come?
Good afternoon, respected chairperson, honorable judges, and all the delegates member present over here. Today I'm going to present my study titled Relationship Between Thumb Opposition Ability and Feeding Independence in Stroke Survivor, a cross-sectional observational study in the Indian context. To begin with the study, I just want to describe a little bit about the background of the study. The World Health Organization defines stroke as a rapidly developed clinical sign of focal or global disturbance of cerebral function, which lasts more than 24 hours or which can lead to death also, with no apparent cause other than of vascular origin. The paralysis of the hand or upper limb occur acutely in up to 87% of stroke survivor, which reflect the profound impact of upper limb motor deficits. And the loss of functional hand movement significantly limits the participation in daily activities and which can persist for many years if left untreated. So now, how and why hand function is important? In the Indian context, eating with the dominant hand carries a strong cultural significance. Traditionally, eating with a bare hand is regarded as the most natural and hygienic method of consuming food. It enhances the sensory experience of touch, texture, temperature, and taste, and continues to serve as an important marker of Indian cultural identity. Despite increased use of cutleries, functional disability became even more pronounced when the dominant hand is affected. So therefore, regaining functional use of the dominant hand for feeding become a top priority for client which undergoes rehabilitation. Now, what are the impacts of stroke on feeding activities? Feeding is a complex self-care task that requires multiple coordinated hand movements, which includes cupping of the digits, effective thumb opposition, grip formation, and refined motor control as observed. After a stroke, these movement components are often compromised due to weakness, impaired dexterity, altered motor synergies, and loss of fine motor coordination. Thumb opposition plays a crucial role in grasping, manipulating, and bringing food to the mouth. Understanding this relationship can provide clinically relevant evidence to guide rehabilitation planning. Now, coming to the aim and objective of the study. The aim of the study was to determine the relationship between the thumb opposition ability and feeding independence in stroke survivor. And in order to achieve this aim, the objective were to analyze the association between thumb opposition ability and feeding performance in stroke survivor. Now, coming to the rationale of the study, stroke frequently results in persistent upper limb dysfunction, with hand recovery being slower and motor incomplete than lower limb recovery. Impaired hand function significantly limit independence in activities of daily living, particularly self-feeding, which is often prioritized early in rehabilitation. Among the various components of hand function, thumb opposition plays a crucial role in grasp formation, manipulation of food, and precision movement, which required during feeding activity. Understanding the relationship between thumb opposition ability and feeding performance can provide evidence-based justification for thumb-focused intervention in occupational therapy. Therefore, this study was undertaken to explore the association between the thumb opposition ability and feeding independence in stroke survivor within the Indian context, thereby contributing clinically relevant data to guide targeted hand rehabilitation strategies. Now coming to the hypothesis, the alternate hypothesis states that there is a significant positive correlation between thumb opposition and feeding independence among the stroke survivors, whereas the null hypothesis states there is no significant correlation between thumb opposition ability and feeding independence among the stroke survivors. Now coming to the methodology of this study. This study follows a cross-sectional correlational study with the 22 participants, which follows a convenient sampling method, and place of study was tertiary rehabilitation care, and the variables were independent variable, thumb opposition ability, and dependent variables, feeding performance. And the participants were selected on the basis of inclusion and exclusion criteria. Participants having right hemiplegia, aged between 18 and 60 years, and Brunstrom recovery stage score for the hand should be greater than 4, and MMSE score above 25 are included in this study, whereas the participants having hemianopia, spatial neglect, sensory impairment, involvement of the non-dominant hand, non-dominant side, and cognitive dysfunctions were excluded from this study. The screening tool used were Brunstrom recovery stage for hand and mini mental state examination, whereas the outcome measures like Kapasi thumb opposition score were used to measure the thumb mobility, whereas the modified Barthel index were used to measure the feeding performance. Now coming to the procedure, both the outcome measures were administered at the same session. So this is a participant performing thumb opposition. And in another demonstrating video, participant performing feeding task. After collecting data, coming to the data analysis, data were analyzed using both descriptive and inferential statistics. Descriptive statistics like mean, standard deviation, median, minimum, and maximum value were used to interpret the characteristic of participant, whereas the Pearson correlation coefficient to determine the strength and direction of association between both the variables. Whereas corresponding p-value were used, the result part, a total of 22 participants were included in the study, comprising of 15 males and 7 females. A strong positive correlation was observed between the Kapasi and modified Barthel index score, which indicates that higher Kapasi score were associated with better functional performance. Subgroup analysis shows that the correlation between Kapasi and modified Barthel index remains strong and statistically significant in both male and female. Among males, the correlation was 0.9771, whereas among females, it was 0.8477. This is a graphical representation between the feeding performance and the thumb mobility, whereas this side, it's a tabular representation of inferential statistic. Coming to the discussion, the present cross-sectional study examined the relationship between thumb opposition ability and feeding independence among stroke survivors in Indian context, and the finding demonstrates a strong and statistically significant positive correlation between Kapasi thumb opposition score and the feeding component of the modified Barthel index. However, this study has a certain limitation, the small sample size and convenient sampling, which restricts generalizability. Overall, the present study highlights the important role of thumb opposition in performing self-feeding tasks and supports the integration of thumb-focused intervention within hand rehabilitation program for stroke survivors. Recommendation for future. Future studies should be conducted across different cultural and regional contexts as feeding practices and eating styles vary across the different states in India. Future studies with larger sample size and multi-center recruitment are recommended to enhance the generalizability of samples and findings, and interventional studies which focuses on thumb opposition training should be undertaken to examine its direct effect on feeding independence. Coming to the conclusion of this study, from this study, it is clearly observed that there is a meaningful relationship between thumb opposition ability and feeding independence in stroke survivor. The strong positive correlation between the Kapasi thumb opposition score and the feeding component of the modified Barthel index highlights the essential role of thumb mobility and dexterity in performing self-feeding tasks. These findings emphasize that targeted intervention focusing on thumb opposition may enhance the functional independence during early rehabilitation. Future research with larger cohort and longitudinal design is required to confirm this finding and explore the effectiveness of thumb-focused therapeutic strategies. These are my references. Thank you.
Thank you, Dr. Roshni. A small announcement. AOTA General Body Meeting is supposed to be held from 4 p.m. Now it is half an hour late. It will start in the hall number 2. So all members who are willing to attend the GB meeting are requested to assemble there by 4:30. Thank you. Now the next participant is Dr. Nima.
Good afternoon, everyone. The topic for my presentation is effectiveness of task-oriented training on hand dexterity and strength in children with hemiplegic cerebral palsy in Goa, a COSI experimental study. Background: cerebral palsy is defined as a non-progressive permanent disorder of movement and posture attributed to disturbances in the developing fetal infant brain. In India, population-level prevalence estimates around 2.9 to 3 per 1,000 live births. Among its various types, hemiplegic cerebral palsy upper extremity is typically more involved than lower extremity, leading to significant difficulties in hand dexterity, fine motor coordination, and grip strength. These deficits greatly impact a child's ability to perform daily activities such as grasping objects, writing, dressing, limiting their independence. Task-oriented training has emerged as a pivotal approach in rehabilitation of individuals with neurological impairments, and it focuses on improving motor functions and enhancing the performance of activities of daily living through repetitive task-specific exercises. This training method is effective in both hospital settings and home-based settings, making it accessible and convenient for patients. By focusing on what the child needs and wants to do, rather than isolated movements, TOT has shown promising results in improving upper limb coordination, strength, and independence. Need of the study: there is a notable gap in research specifically addressing the impact of task-oriented training on hand dexterity and strength, and also there are a limited number of researches conducted on this effectiveness of this program in Indian context. Aim of the study: to study the effectiveness of task-oriented training on hand dexterity and strength in children with hemiplegic cerebral palsy in Goa, India. Objectives of the study: to evaluate hand dexterity and hand strength of children with hemiplegic cerebral palsy using the box and block test and hand dynamometer, to provide intervention to selected children based on TOT protocol targeting functional upper limb activities, and to assess post-intervention outcome using the same standardized measures and compare with the pretest values. Methodology: a COSI experimental study was conducted to determine the effectiveness of TOT on hand dexterity and strength in children with hemiplegic cerebral palsy. The study was carried out at Pediatric Neuro Rehabilitation Center, Goa Medical College, and OPD 17 Occupational Therapy, and extended to selected private clinics and special schools across Goa. A total of 30 children with hemiplegic cerebral palsy were recruited using a convenient sampling method. Eligibility criteria: in inclusion criteria consisted the children who had diagnosis of CP by the pediatrician, who were aged between 5 to 13 years, who were on level 1 and level 2 on the GMFCS, Gross Motor Functional Classification System, who were able to understand Hindi, Konkani, Marathi or English. The children who had botulinum toxin A treatment in the previous 6 months, excessive spasticity, and poor medical condition were excluded from the study. Instrumentation: two standardized instruments were used to assess outcomes in this study. The box and block test was administered to evaluate unilateral gross manual dexterity of the affected limb. The Jamar hand grip dynamometer was used to measure hand grip strength. Procedure: the intervention followed a task-oriented training approach aimed at improving hand dexterity and strength in children with hemiplegic cerebral palsy. Written informed consent was obtained from the parents or guardians of all participants prior to inclusion in the study. A pretest was conducted to assess baseline hand dexterity and strength. Each child participated in a 6-week program consisting of 3 days per week. each session lasting approximately 40 to 45 minutes. The intervention was implemented at Occupational Therapy OPD 17, Pediatric Neurorehabilitation Center, special schools and private centers across Goa. Each session began with 5 to 10 minutes of warm-up activities such as gentle stretching, wrist and finger mobilization, weight bearing on the affected hand. The TOT activities were individualized based on the child's ability and functional goals, focusing on purposeful, play-based tasks that mimic daily living activities. Activities included picking up grains or pulses, transferring the rice dal lentils from one place to another, transferring blocks or small toys, moving small wooden blocks, marbles or miniature toys between containers using the affected hand, sponge or cloth squeezing a wet sponge or cloth to transfer water between balls, bead threading or straw insertion, thread large beads, bangles or straws into a string or stick, paper crumpling and throwing, crumple newspaper or magazine paper into balls and toss into basket or box, pegboard or clip cloth activity, place and remove pegs, cloth clips or small clothespins from a board or rope or rim of the bucket, clay or dough play, roll, pinch, flatten, modeling clay with dough, atta or rice dough, opening bottle and container caps, opening closing bottles and containers of different sizes, stacking cups or blocks, stack plastic cups, small boxes of wooden blocks on top of one another. Activities of daily living tasks, practice opening, closing different types of locks and latches, buttoning and unbuttoning, and zipping and unzipping activities. These were the results. A total of 30 children with hemiplegic cerebral palsy participated in the study. Among them, 25 were males and 5 were females. The mean age of male participants was 9.54 with standard deviation of 1.93, whereas for females, it was 8.60 with standard deviation of 1.14 years. Overall, ages ranged around 9.25 with standard deviation of 1.7 years. Among participants, 26 children had left-sided hemiparesis, while 4 children had right-sided hemiparesis. Regarding functional classification based on gross motor function classification system, 18 children were classified as level 1 and 12 children were classified as level 2. The box and block test scores showed a significant improvement following the intervention, increasing from a pre-test mean 12.85 with standard deviation of 2.31 to post-test mean of 13.38 with standard deviation of 3.31. Mean increase was of 0.53. This change was statistically significant, indicating that the task-oriented training effectively enhanced manual dexterity in children with hemiplegic cerebral palsy. In contrast, grip strength showed a minimal increase from 2.21 with standard deviation of 0.88 kg at pretest to 2.23 with standard deviation of 0.89. Negligible change of 0.02 was seen. This change was not statistically significant with p is equal to 0.569, suggesting that the intervention did not produce measurable amount of improvement in grip strength over the study period. This is the table for pre and post intervention comparison of hand function outcomes. For box and block test, the p-value was 0.02, which was significant, and for grip strength, it was 0.569, which was not significant. Discussion: the present study demonstrated that 6-week task-oriented training program led to statistically significant improvement in manual dexterity as measured by the box and block test in children with hemiplegic cerebral palsy, while grip strength remained unchanged. This may be due to nature of TOT, which emphasizes functional task performance and motor control rather than resistance training per se. Overall, the results of this study support the use of task-oriented training as an effective strategy to enhance manual dexterity in children with hemiplegic cerebral palsy, echoing similar findings in the literature. Limitations: this study had no control group to confirm causality. This study was done within short 6-week training duration, limited training frequency. There was variability in individual task selection. Future implications: exploring hybrid programs combining strength training with task-oriented approaches, conducting long-term follow-up to assess sustained and delayed effects on hand function. Conclusion: this study affirms that task-oriented training is an effective low-cost therapeutic approach for improving upper limb dexterity in children with hemiplegic cerebral palsy. Participants showed notable improvements in hand dexterity. However, there were no apparent increase in grip strength. This suggests that the intervention was successful in increasing manual dexterity even if hand strength stayed constant, emphasizing its potential use in rehabilitation programs meant to enhance fine motor skills. Ethical approval was taken from the Institutional Review Board of Goa Medical College and was obtained before the commencement of the data collection. This study received no funding from any organization or external source. There is no conflict of interest with respect to the study and its findings. I express my sincere gratitude to all the children and their families who participated in this study. I extend my deep appreciation to the Dean of my college, the head of the Department of Orthopedic Surgery Occupational Therapy, to the Institutional Ethics Committee of Goa Medical College. I am deeply thankful to the principal of Sanjay Center for Special Education for granting permission and providing support required to conduct this study. I also extend my heartfelt appreciation to my parents, guide, seniors, colleagues for their constant support, insightful suggestions, and motivation throughout the course of this research. These are my references. Thank you.
Thank you, Dr. Nima. Now, next presenter is Dr. Dute Krishna.
Good afternoon, all. My study title is Correlational Study Between the Mindfulness-Based Occupational Activity and Emotional Regulation in Young Adults. Introduction. Young adulthood represents a critical transitional phase marked by increasing academic and career demands, evolving social roles, and growing responsibilities. These changes often contribute to heighten the emotional challenges, making effective emotional regulation, the ability to modulate and respond to internal emotional experience is adaptive way essential for mental well-being and successful functioning. Mindfulness, commonly defined as the purposeful, non-judgmental awareness of the present moment, has been identified as a key factor in supporting emotional regulation and overall psychological health. Research indicates that higher dispositional mindfulness is associated with greater use of adaptive regulation strategy, reduce emotional dysregulation, and lower symptoms of anxiety, depression, and stress in general population. Although mindfulness-based interventions have been widely studied, the extent to which everyday occupational activity performed with mindfulness awareness related to emotional regulation remain underexplored, particularly in young adults who may be vulnerable to emotional dysregulation given to the complexity of life transitions in this period. Aim and objective of the study: to examine the relationship between the mindfulness-based occupational activity and emotional regulation in young adults. Objectives: to examine the relationship between the mindfulness and emotional regulation among young adults. To determine the whether higher level of mindfulness are associated with fewer emotional regulation difficulty. Methodology: research design is correlational research design. Sample size is 100 and sample type is convenience sampling. Outcome measures are difficulty in emotional regulation scale and mindfulness attention awareness scale. Inclusion criteria: age is 18 to 28 years, currently in any academic program or pursuing the job, actively participating in the daily occupational activities. Exclusion criteria: psychological disorders, ongoing psychiatric treatments, unwillingness to provide consent. Procedure: participants were first informed about the purpose of the study. It provided written informed consent. Participants first completed a demographic information followed by mass and DRS scale. The tools are administered in a fixed order to maintain the uniformity across all the participants. The average completion time was 15 to 25 minutes. Data analysis. Data analysis use SPSS version 26. The degree and direction of the association between the emotional regulation difficulties and mindfulness were assessed using the Pearson correlation coefficient. Statistical significance was determined by the setting the level of significance P less than 0.05. Results show a negative correlation between the mass and DRS, and a negative correlation between the domain 1 non-acceptance and with the mass scale, and also negative correlation between the domain 2, which is goal related activities, and a positive correlation between the awareness and the clarity domain. Then discussion: the current study looked at how participant emotional regulation domains and mindfulness related to one another. Overall results show a better emotional regulation in the majority of areas were strongly correlated with higher level of mindfulness. A moderate negative correlation was observed between the mass and impulse control difficulties and limited access to emotional regulation strategy, indicating that individuals with greater mindfulness tends to exhibit enhanced impulse control, and are more capable of assessing the effective coping strategy during emotional distress. This aligns with the previous findings that mindfulness promotes inhibition of automatic emotional responses and enhance adaptive coping mechanism. Additionally, the correlation between the mass and non-acceptance of emotional response and goal-directed behavior difficulties suggests that mindfulness individuals demonstrate better acceptance of emotional experience and are less likely to experience disruption in goal-oriented activities under stress. These individuals are consistent with literature suggesting that mindfulness encourages non-judgmental awareness and reduces experiential avoidance. Interestingly, the awareness and clarity domain shows positive correlation since these domains are reverse code. The actual interpretation indicates that higher mindfulness is associated with greater emotional awareness and clarity. This is supported by previous research that identify mindfulness as a key factor in enhancing metacognitive awareness and emotional understanding. Collectively, these findings are highlighted mindfulness as a significant promoter of adaptive emotional regulation. People who practice mindfulness more likely to appraise emotional effectively, maintain calmness during the emotional experience, and assess appropriate regulatory strategy. This support the theoretical model indicating that mindfulness improves emotional processing by enhancing the attentional control, acceptance, and cognitive flexibility. However, varying strength of correlation across the domain suggests that while mindfulness contributes to emotional regulation, it may not be equal effective across all regulatory processes, warranting further investigation into mediating factors such as personality traits or stress level. Limitation: the correlational design prevent conclusions and about causality between mindfulness and emotional regulation. Self-report measure may introduce response bias and inaccurate self-perceptions. The sample was restricted to young adults from a specific geographical region, so limiting the generalizability of the study. Potential confounding factors. Conclusion: the finding of the present study indicate that higher level of mindfulness are significant associated with better emotional regulation across multiple domains of the DERS. Individuals with greater mindfulness demonstrated improved emotional clarity, awareness, impulse control, and access to effective strategy, while experiencing the fewer difficulty related to goal-directed behavior and emotional non-acceptance. Although the strength of association varied across the domain, the results suggest that mindfulness play a meaningful role in enhancing the emotional adaptability. These findings highlight the potential value of mindfulness-based intervention in promoting the healthier emotional regulation. These are my references. Thank you.
Thank you, Dutya Krishna. Now, next presenter is Dr. Kumari Kirti.
Good evening, everyone. Today, my topic for paper is Incidence of Stroke in Young Adults 20 to 40 years, a 10-year retrospective trend analysis 2016 to 2015. Introduction: Stroke is a leading cause of death and long-term disability worldwide. Traditionally considered a disease of older adults, recent epidemiological reports show a growing incidence among young adults aged below 45 years. Studies from several countries report that 10 to 20% of all strokes now occur in young individuals, and this proportion has risen steadily over the past 2 decades. This rise has been associated with early onset of metabolic conditions such as hypertension, diabetes mellitus, and obesity. Lifestyle transitions, including sedentary behavior, high caloric diets, prolonged screen exposure, sleep disturbances, and chronic stress, are increasingly implicated. Many young adults remain undiagnosed until the first neurological event occurs, as this age group seldom participates in routine preventive health screening. Young stroke has severe personal and socio-economic consequences. Individuals in the 20 to 40-year age group are typically at peak productivity, and stroke can lead to sudden interruption of employment, financial instability, disrupted family roles, and long-term disability. Cognitive impairments affecting memory, attention, and executive function are common in this population even when physical recovery is good. Method: study design. A retrospective descriptive trend analysis was conducted, which is a widely accepted method for evaluating temporal patterns in health conditions. Study setting. The study took place at a tertiary level rehabilitation and medical center, which receives a diverse patient population representing both rural and urban demographics, suitable for capturing real world epidemiological patterns. Study period: medical records from January 2016 to September 2025 were reviewed, providing a full decade of data for trend visualization. Study population: all individuals aged 20 to 40 years diagnosed with stroke, ischemic or hemorrhagic during hospital admission were included. Diagnosis was based on clinical examination supported by neuroimaging consistent with standard diagnostic guidelines. Inclusion criteria: age 20 to 40 years, confirmed stroke diagnosis via CT or MRI, admission within the study period. Exclusion criteria: recurrent strokes without clear documentation, incomplete or missing clinical records, and age below 20 or above 40 years. Data collection: data were extracted from hospital admission registers and electronic medical records. Variables included age, gender, stroke subtype, clinical risk factors, and yearly case counts. Only aggregated data were used, ensuring protection of patient's identity in line with the Declaration of Helsinki. Data analysis: annual stroke incidence was tabulated and analyzed descriptively. A time series line graph was prepared to illustrate trend progression. Inferential statistics were not applied as the aim was to document the incidence trends rather than to establish the causality. Results: retrospective trend analysis overview. A retrospective trend analysis involves reviewing previously recorded data over a defined period to identify changes, patterns, and fluctuations in disease occurrence over time. In this study, hospital records from 2016 to 2025 were examined to quantify how many young adults experienced a stroke each year. By arranging the annual case numbers chronologically, a year-to-year pattern was observed, allowing for recognition of increases, decreases, and major shifts in the incidence. Overall trend: the retrospective review revealed a clear upward trajectory in stroke incidence across the decade. The earliest year in the dataset, that is 2016, documented 11 cases. A gradual increase was noted in the subsequent years, rising to 27 cases in 2019. This was followed by a sharper escalation between 2020 and 2024, with the highest recorded incidence of 69 cases in 2024. Although 2025 showed slight stabilization, the overall incidence remains significantly higher than the earliest years of the study. This is the graph showing how the trend was seen. Discussion: the decade-long data from this study demonstrates a clear increase in stroke incidence among young adults, consistent with international findings. This aligns with reports of shifting epidemiology where vascular risk factors appeared earlier in life. The rise in metabolic disorders, hypertension, diabetes, dyslipidemia, and obesity among young adults is well documented. Indian cardiovascular surveys similarly show increasing prevalence of these risk factors in youth driven by lifestyle changes. The risk is further amplified by smoking, which significantly increases both initial and recurrent stroke risk. Young stroke survivors face unique challenges due to disruption of career and family responsibilities. Previous studies confirm that this group often experiences long-term vocational disruption and may struggle to return to previous work roles. Cognitive and executive function impairments, though sometimes subtle, can further impede occupational performance. Occupational therapy is crucial in addressing functional restoration, work reintegration, cognitive rehabilitation, and community participation in young stroke survivors. Overall, the findings emphasize the need for targeted screening programs, lifestyle modification campaigns, and policy-level preventive strategies focused on young adults. Conclusion: The rising number of young adults experiencing stroke over the past decade is more than just a trend in hospital records. It represents individuals in their most productive years suddenly facing life-altering changes. Our findings shows that stroke is no longer a condition limited to older age groups. It is increasingly affecting people who are building careers, supporting families, and shaping their futures. This shift calls for greater awareness, earlier health checkups, and more open conversations about lifestyle, stress, and well being in younger populations. The rising trend observed in this study is a reminder that stroke in young adults is a growing public health concern that deserves attention, empathy, and action. Strengthening preventive care, creating supportive environments, and ensuring access to quality rehabilitation services can help us protect the health and futures of younger generations. Continued research and community awareness will be key to reversing this upward trajectory and helping young adults lead healthier, safer, and more fulfilling lives. These are my references. Thank you.
Thank you, Kurti.
Now I call Dr. Trupti Priya, Dr. Chetna Bali, Dr. Sovika, Dr. Rosni Nirala, Dr. Jasi, Dr. Nima, Dr. Duti Krishna, Dr. Kumari Kriti for question. Audience are requested to kindly ask only 2 questions every. Any question from Trupti Priya? No question? Thank you. Any question from Dr. Chetna? No question. Any question from Dr. Sovika? Okay. Any question from Dr. Rosini? Any question from Dr. Jasi? No question. Any question, Dr. Nima? No question. Any question from Dr. Duti Krishna? Okay. Any question from Dr. Kumari Kriti? Okay. It shows all presenters were very good.
Small suggestions for the first presenter. When you're presenting in the conference as a mayor, you try to hide your identifications. Okay, you should not put your college name or the guide names. Okay, even the organization name. Okay, so there is a suggestions. Second person suggestions when you itself are deciding a 30 sample size. In the later stage, you should not say that is a small sample size. It is a common people are used to do that should need to be avoided. All the best for everyone. Thank you for presentation.
We extend our sincere appreciation to all the presenters for their valuable contributions, and we also express our profound respect and gratitude to the honorable chairpersons for their guidance, leadership, and support throughout the session. We shall now proceed with the presentation of participation certificates. I would kindly request Dr. Priyadarshi Alok sir to kindly hand over the certificates to Dr. Trupti Priya Nayak, Please give a big round of applause. Next up, we have Dr. Chetna Balye. Dr. Shobika S. And finally, Dr. Roshni Nirala. Thank you, sir. I would now request Dr. Kaushik Sao, sir, to kindly hand over the participation certificates to Dr. Zashi Baba Rao Guge. Dr. Nima Digambar Gosavi. Dr. Dwiti Krishna Patnaik. And finally, Dr. Kumari Kirti. Thank you, sir. We sincerely thank all the presenters for enriching this scientific session through their valuable research contributions and scholarly insights. Now, we take the honor of presenting the mark of appreciation to Dr. Priyadarshi Alok sir and thank him for gracing this occasion with his esteemed presence. I kindly request Dr. Madhuchanda ma'am to please felicitate him. Please, ma'am. Thank you, ma'am. We now present our token of appreciation to Dr. Kaushik Sao sir in grateful acknowledgement of his gracious presence. May I please request Dr. Pragyan Singh ma'am to please felicitate him. Thank you so much, ma'am. We sincerely thank our respected chairpersons for their guidance and our esteemed presenters for sharing their valuable insights. Your contributions have made this session engaging and enriching. With gratitude to chairpersons and all participants, we now conclude this scientific session. Thank you all.
Save my hands. Oops.
she get it good from she rise. But cook it on so good and make sure shake all she ties. Smile upon her face, me know she pleased with this eye. Come ignorant to me, them gyal a roll out them eyes. Go down there, wine and go down there. Go down there, wine and go down there. Go down there, wine and go down there. Go down there.
Wine on your foot, make sweat a drip off from the body, yeah. Oh, you're full of chatter, you can't keep up with me energy. What a epic like a bit, embedded in your memory. Little bubble up, it treat it like a felony.
What you gonna do when there is nobody that do it better than this reggae guy? I can do this every morning, every evening. I'll be screaming straight back to sunrise.
Swinging it and this is my ambition. We give it the little love, make you turn and twist
दरिया तेरा इश्क है पिया रंग जाऊं जो मैं हाथ लगाऊं दिन बीते सारा तेरी फिक्र में रैन सारी तेरी खैर मनाऊं I see this fine girl for my party she wear yellow every other girl they do too much but this girl mellow now in my fine situation I go use they tell I'm mellow
والله خوش رقصة يا أخي دوس دوس عندي خوش فصلة يا أخي تفوز تفوز والله خوش رقصة.
गुड इवनिंग ओटिकॉन। तो कैसे हैं आप सब? बढ़िया ही होंगे? हाँ, रिप्लाईज एनीवन? नमस्कार, वनक्कम, सत श्री अकाल, आदाब। मैं आपका होस्ट और दोस्त आज आपका वेलकम करता हूं डे 2 ऑफ ओटिकॉन 2026 में। जोरदार तालियां हो जाएं फॉर दिस ब्यूटीफुल, एनर्जेटिक एंड मेस्मराइजिंग इवेंट के लिए। इस इतने बड़े इवेंट का भार तो मैं अकेले ढो नहीं सकता। तो मैं बुलाना चाहूंगा मेरी को होस्ट जो कि अच्छी है पर बच्ची है। वेलकमिंग मिस सुमन।
हेलो ओटिकॉन, कैसे हैं आप सब? मस्ती का रेंज ऑफ मोशन कम तो नहीं हुआ ना? डोपामिन का लेवल बरकरार रखिए जनाब, क्योंकि दिस इवेंट गोना ब्लो योर माइंड। स्वस्तिक, मेरे आने से पहले तू मेरा मजाक उड़ा रहा था ना? क्या बच्ची? मैं बच्ची नहीं, ओके? आई एम नॉट अ बच्ची। बस ये ओटिकॉन खत्म होने दे, फिर दिखाती हूँ तुझे।
लगता है मैडम जी रूठ गई हैं। एक शायरी हो जाए? एक शायरी। कहते कहते बात थोड़ी इधर उधर बह गई, कहते कहते बात थोड़ी इधर उधर बह गई, पर तुम्हारी हंसी के बिना ये महफिल अधूरी रह गई। अब एक मुस्कान से इस पल को रोशन कर दो जरा, अब एक मुस्कान से इस पल को रोशन कर दो जरा, कहीं ये बेचारा एंकर अपनी स्क्रिप्ट ही ना भूल जाए पूरा।
वाह 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 वाह। चल, अपनी टॉम एंड जेरी फाइट तो चलती रहेगी, पर इस धमाकेदार इवेंट के लिए कुछ सोचा भी है या नहीं?
Of course, भला कैसी बात। Here, gonna feel the energy, the vibrant art and the cultural embellishments which will be performed by our very talented participants. So ladies and gentlemen, we welcome you all to day 2 of Advait 2026.
कि हर कोई कल से अद्वैत अद्वैत किए जा रहे, अब हम सब तो आम लोग हैं, तो क्या कुछ लोग अद्वैत हैं? I mean, नहीं आता मुझे नाचना, नहीं है मेरे स्वर में सरस्वती माँ का वास।
अद्वैत यानी खास है। तेरा होना भी तो एक बात है कि तेरा होना तुझसे नहीं बल्कि तेरे निष्ठा और परिकाष्ठा का प्रकाश है। कुछ इस तरह मैं भी खास हूँ, तू भी खास है, और हम सब के समक्ष एक नए दिन का आगाज है।
So hello every special one and welcome to the day 2 of Advait. We welcome you all to the land of Jagannath, the creator, preserver of the universe.
सब लोग एक साथ मेरे ऊपर दोनों हाथ ऐसे ऊपर करेंगे और बोलेंगे जय जगन्नाथ, जय जगन्नाथ, और थरे जय जगन्नाथ। That's the spirit, guys. So इसी भक्ति के साथ हम आगे बढ़ते हैं और हमारे सबसे पहले परफॉर्मेंस की तरफ एक छोटा सा श्लोक के साथ। ओके। नीलाचल निवासाय नित्याय परमात्मने बलभद्र सुभद्राभ्याम जगन्नाथाय ते नमः. Born in the sacred temples of Nilachal comes a philosophy of balance, tradition walking hand in hand with modern expression.
With blessings of Mahaprabhu Jagannath, Subhadra and Balabhadra, symbols of unity, strength and grace, Dreams College proudly brings to the stage a celebration where confidence meets creativity and style meets soul. Let's put our hands together for Dreams College.
जगन्नाथ मु जगतर नाथ मो स्रष्टा मो सृष्टि मो ही विलय मो ही धारण करिथिली मीन रूप मो कच्छप बराह नरसिंह वामन परशुराम राम बलराम एवं बुद्ध मो ही सृष्टि करिथिली कुरुक्षेत्र रे महाभारत मो केवल मो आ मो ही आसुची कल्कि रूपरे
मु चक्रे बुलाए सारा जगत मु चक्रे बुलाए सारा जगत महाभारत 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 महाभारत।
जिस प्रकार सतयुग में पृथ्वी प्रलय से जूझ रही थी, तब मेरे प्रभु नारायण ने मत्स्य अवतार लिया और मनु और शत्रुपा को इस प्रलय से बचाकर मनुष्य योनि की रक्षा की। इसी प्रकार समुद्र मंथन के समय प्रभु ने कूर्म अवतार धारण करके मंदार पर्वत को स्थिर किया। हिरण्याक्ष नामक एक राक्षस था जिसने धरती माँ का अपहरण करके उन्हें अंतरिक्ष के गहरे समुद्र में छिपा दिया था। उस समय मेरे प्रभु ने हिरण्याक्ष का वध करके धरती माँ को सुरक्षित लाया। सृष्टि अपने सुचारू रूप से संचलित हो रही थी कि अधर्मी हिरण्याकश्यप के अत्याचार उसके पुत्र प्रहलाद पर बढ़ते ही जा रहे थे। फिर कमल नयन ने नरसिंह का दृढ़ रूप धारण करके हिरण्याकश्यप का वध करके अपने भक्त प्रहलाद की रक्षा की। राजा बलि ने अपने प्रताप से तीनों लोकों को अपने अधीन कर लिया था। तब मेरे प्रभु ने वामन अवतार में राजा बलि का अहंकार नष्ट किया।
देवेश्वराय देवाय देव संभूतिकारिणे प्रभवे सर्ववेदानां वामनाय नमो नमः।
नारायण ने ऋषि जमद अग्नि के पुत्र रूप में जन्म लिया और परशुराम कहलाने लगे। नाम में अनंत ब्रह्मांड समाया है, उस सुखदाम का नाम श्री राम। प्रभु मर्यादा पुरुषोत्तम के रूप में अवतरित हुए और समस्त राक्षस कुल का सर्वनाश किया।
चौखट पे चल के आज चारों धाम आए हैं, बजाओ ढोल स्वागत में मेरे घर राम आए हैं।
मुरलीधर लीलाधर या कहो गोपाल, माखन चोर रण छोर या देवकी के लाल, वसुदेव सूतम देवम कंस चाणूर मर्दनम, देवकी परमानंदम कृष्णम वंदे जगत गुरु। अब कलयुग की शुरुआत हो चुकी थी, जिसके प्रथम चरण में मनुष्यों में हिंसा की भावना बढ़ती ही जा रही थी। तब प्रभु ने बुद्ध के रूप में महात्मा का अवतार धारण किया। ओम नमो बुद्धा।
शरणं गच्छामि।
है कि अब आपको अपना 10वां और आखिरी अवतार लेना ही होगा। मनुष्यों के मन में बसे कली का संहार करना ही होगा। अब समय आ चुका है कली का वध करके सतयुग का स्थापना करने।
सबसे प्रबल शस्त्र रचित रक्त चरित
जोरदार तालियां हो जाए एक बार फिर से ड्रीम्स कॉलेज के लिए। जगन्नाथ जी के 10 अवतार को इतनी खूबसूरती से प्रदर्शन करने के लिए बहुत बहुत शुक्रिया ड्रीम्स। A big round of applause once again guys.
हमारे उड़ीसा में एक कहावत है, चा पीबो फुकी फुकी पान खाइबो कले, जेते डिस्को बाजले भी सबो संबलपुरी तले। With this, let's welcome to the stage Sambalpuri dance group from SV Nirtar.
রসর কেলিব এ বড় বড় জিরা নদী ঝিলিমিলি পানি রে ঝিলিমিলি পানি বড় গড়র জিরা নদীর ঝিলিমিলি পানি রস ভরি রসর কেলি গাউথিসি ননি খলিয়া খুসা মুলকি হসা পিঁধি সবটা পরি অটা ভাঙি নাচি দেশি কিন্দিরি কিন্দিরি উসপুনি কে সাজে ধনু যাতরা उस्पुनी के साजे धनु जातरा तिहार भितरे हीरा के देखैने मारे बड़ गड़ हाटू घिनी देमी तो बड़ गड़ हाटू घिनी देमी तो झुमका लगा पोएरी के रसर के लीबो
बजा टिके बजा
रस जामु डाली है रस जामु डाली मोर आखी नूरू छे तोते कलर माली रस जामु डाली रे रस जामु डाली
अरियंता माटी पानी कहा के मिले हो माँ समोले देशे अरियंता माटिर पानी कहा के मिले हो माँ समोले देशे भावर बंधन चहट चंदन भावर बंधन चहट चंदन आरे बासुथिसी मोह मोहरे आमर आदर व्यवहार हीरा खंडर छुआ आमे सभे हो इटा सरगरपुर आमर कला संस्कृति गामर गीत साहित्य झुमी नाची गाउथी मागा सहमित आमर साहा छे सरफ सोहिनी माँ समलेश्वरी तार पन तले जाऊ जीवन मुई करे गुहारी
जोरदार तालियां हो जाए फॉर दिस ब्यूटीफुल परफॉर्मेंस। एक बार जोरदार तालियां हो जाए। बहुत एनर्जेटिक परफॉर्मेंस था यार। इतना सुंदर परफॉर्मेंस होता रहेगा तो पक्का एक्साइटमेंट का लेवल हाई ही होने वाला है। ऑडियंस, सो हाउस द जोश, हाउस द जोश, हाउस द जोश।
बिल्कुल, लेट्स मूव ऑन टू आवर नेक्स्ट परफॉर्मेंस।
इस बार एक कुछ संस्कृत की पंक्तियां हो जाएं। क्या बोलते हो ऑडियंस? थोड़ा सा संस्कृत। यत्र भक्ति तालम लभते, यत्र देहम कथाम वदति, तत्र ओडिसी नृत्यम विराजते। Born in the sacred land of Odisha, Odissi is a dance where Tribhangi becomes poetry, Abhinaya becomes prayer, and every movement whispers devotion.
A classical form, older than centuries, yet eternal in grace and soul. With folded hands and open hearts, let us welcome to the stage Pragya Paramita from Dreams College.
शंखमध्ये शतदलकमले रत्नसिंहासनस्थं सर्वालङ्कारयुक्तं नवघनरुचिरं संयुतं चाग्रतेन भद्राया वामभागे रथचरणयुतं ब्रह्मरुद्रेन्द्रवन्द्यं वेदानां सारमीशं सजनपरिवृतम् ब्रह्मदारुं स्मरामि, ब्रह्मदारुं स्मरामि।
তুমি অনন্ত ক্ষয় হে জগন্নাথ, তুমি অব্যক্ত অক্ষর হে জগন্নাথ, নিজ ইচ্ছারু সৃজিল এ জগত, আদি নাহি যে তুমার নাহি অন্ত, তুমি পবিত্র ওঙ্কার চির সত্য, নীল সিন্ধু তীরে নীলাচল, তহি বিরাজিত বড় দেউଳ, তরু ব্রহ্ম রূপে হে বিশ্ব পালন, উড়াও পতাকা পতিত পাবন, সত্য ধর্ম ন্যায় পরিসংস্থাপিত, ভকতর তুমে হইছ হে নাথ, শ্রী জগন্নাথ শ্রী জগন্নাথ জগন্নাথ শ্রী জগন্নাথ শ্রী জগন্নাথ।
जोरदार तालियां हो जाए प्लीज यार, बहुत बहुत खूबसूरत परफॉर्मेंस था। ए बिग थैंक यू टू मिस प्रज्ञा फॉर दैट एब्सोल्युटली ग्रेसफुल एंड सोल टचिंग परफॉर्मेंस। गूज़बम्स आ गए भाई, बहुत सुंदर परफॉर्मेंस था। और एक बार लेट्स पुट आवर हैंड्स टुगेदर फॉर मिस प्रज्ञा।
यार स्वस्तिक, ये क्लासिकल वगैरह तो सब ठीक है, पर यार कुछ धमाकेदार और चटपटा सुनने का मन नहीं कर रहा, जिसमें हाथ पैर थिरकने लगे और कमर अपने आप ठुमके लगाने शुरू कर दे।
तो हाउ अबाउट सम बॉलीवुड तड़का गाइस?
सुनाई नहीं दे रहा यार, थोड़ा जोर बोलो।
Let's give it up for KMCD College of Allied Health Science.
Desi boys, 1, 2, 3, go! English ढूंढके दिल की रिदम पे मारे जम जम के देसी boys घोड़े मोड़े बन के छाती डोले तन के नाचे जम जम के देसी boys खिड़खिड़ हੱਸਦੀ ਨਜ਼ਰ ਲੱਗ ਜੂ ਖੁਸ਼ੀ ਨਹੀਂ ਰਹਿਨੀਆਂ ਕੋਈ ਗਮੀ ਲੱਭਦੇ ਸ਼ਕਲੋਂ ਦਿਲੋਂ ਤੂੰ ਇੰਨਾ ਸਾਫ਼ ਸੂਰਤ ਹੈ ਵੇ ਮੈਨੂੰ ਕੋਈ ਤਾਂ ਤੇਰੇ ਚ ਜੱਟਾ ਕਮੀ ਲੱਭਦੇ ਜਿਵੇਂ ਤੂੰ ਸਜੀ ਨੂੰ ਸਜਾਉਂਦਾ ਰਹਿਣਾ ਜਿਵੇਂ ਤੂੰ ਖਿਜੀ ਨੂੰ ਖਜਾਉਂਦਾ ਰਹਿਣਾ ਮੇਰੇ ਤੇ ਗੀਤਾਂ ਨੂੰ ਬਣਾਉਂਦਾ ਰਹਿਣਾ ਮੇਰੇ ਤੇ ਲਿਖੇ ਹੋਏ ਸੁਣਾਉਂਦਾ ਰਹਿਣਾ ਆਓ ਜਲੇ ਤੇਰੇ ਤੇ ਮਰ ਜਾ ਮੇਰੇ ਤੇ ਬਣਾਉਣਾ ਤਰਜਾ ਪਤਾ ਮੈਨੂੰ ਦੇ ਦੇਗਾ ਤੂੰ ਜਾ ਮੈਨੂੰ ਤੇਰੇ ਨਾਲ ਪਿਆਰ ਜੱਟਾ ਤਾਂ ਤੇਰੇ ਨਾਲ ਪਿਆਰ ਜੱਟਾ ਤਾਂ ਮੈਨੂੰ ਤੇਰੇ ਨਾਲ ਪਿਆਰ ਜੱਟਾ ਤਾਂ ਤੇਰੇ ਨਾਲ ਪਿਆਰ ਜੱਟਾ ਤਾਂ ਮੈਨੂੰ ਤੇਰੇ ਨਾਲ ਪਿਆਰ ਜੱਟਾ ਤਾਂ ਬੱਲੀਏ ਬੰਗਨ ਬੱਲੀਏ mama mama wait mama lama oh mama mama wait chama lama oh mama mama wait mama lama oh mama mama wait chama lama और दिखा तू तुझे मेरा वाला डांस ये मेरा वाला डांस तो नाचू ये मेरा वाला डांस तो नाचू ये मेरा वाला डांस
मुन्नी बदनाम हुई डार्लिंग तेरे मुन्नी बदनाम हुई डार्लिंग तेरे लिए मुन्नी बदनाम हुई डार्लिंग तेरे लिए मुन्नी के गाल गुलाबी ना शराबी चाल राबी रे ले झंडू बम हुई डार्लिंग तेरे लिए मुन्नी बदनाम हुई डार्लिंग तेरे लिए
ਤਾਈ ਨੂੰ ਕਹਿ ਰੱਖ ਹੁਣ ਬਿੜਕਾਣਾ ਤੂੰ ਵੀ ਮੈਨੂੰ ਮਾਰੀ ਮੈਂ ਝਿੜਕਾਣਾ ਦੇਖ ਕੇ ਮੁੰਡੇ ਨੂੰ ਹਾਂ ਕਰ ਹੋ ਗਈ ਤੂੰ ਵੀ ਉਹਦੇ ਕਹਿੰਦੀ ਸੀ ਉਮਰ ਹੋ ਗਈ ਨੀ ਪਿੱਛੇ ਪੈ ਗਿਆ ਨਾਲ ਖੈ ਗਿਆ ਕੋਲੇ ਪੈ ਗਿਆ ਕੋਈ ਨੀ ਮੈਂ ਦਿਲ ਲੈ ਗਿਆ ਕੋਈ ਨੀ ਮੈਂ ਦਿਲ ਲੈ ਗਿਆ ਕੋਈ ਮੈਂ ਕਿਹੜਾ ਵੀ ਕਰ ਗਈਆਂ ਹੁਣ ਹਰ ਗਈਆਂ ਨੀ ਸਹਿ ਗਿਆ ਕੋਈ ਨੀ ਮੈਂ ਦਿਲ ਲੈ ਗਿਆ ਕੋਈ
ਜੇ ਤੂੰ ਲੱਭਦਾ ਵਫਾ ਫਿਰਦਾ ਨਹੀਂ ਲੱਭਣੀ ਰੁਕ ਤੂੰ ਜਾਏ ਸਜ਼ਾ ਦਾ ਸਜਣ ਸਜਣੀ ਜਦੋਂ ਆਪਣਾ ਬੇਗਾਨਾ ਹੋਇਆ ਤੱਕਦੇ ਆਈ ਫਿਰ ਰੋਂਦਿਆਂ ਨੂੰ ਥਾਂ ਨਹੀਂ ਤੈਨੂੰ ਇਹ ਲੱਭਣੀ
पान में पुदीना देगा नाक गाना गिना देगा चिकनी चमेली देगी चिकना कमीना देगा चांदनी से डर हो के चीट किया तो सारे तारे बोले गिली गिली अखा मेरी बात तेरी बात ज्यादा बातें बुरी बात थाली में कटोरा लेकर आलू भात मूड़ी भात मेरे भी जो किसी ने रिपीट किया तो साला मैंने तेरे मुंह पे मारा मुक्का
वाओ व्हाट एन एनर्जेटिक परफॉर्मेंस गाइस आप लोग सच में मुंबई आ रहे हो आग लगा दी पूरा आग लगा दिया
जोरदार तालियां वापस से हो जाएं यार और एक बार फॉर द परफॉर्मर्स वंस अगेन लेट्स गिव इट अप गाइस
थैंक यू KMCT कॉलेज ऑफ अलाइड हेल्थ साइंसेस सच एन पावरफुल चटपटा परफॉर्मेंस सच में सबको एनर्जी भर दिया है
इसी एनर्जी भरे महफिल में थोड़ी रंग की कमी लग रही है रंग भरने के लिए बुलाते हैं मिस्टर आनंद शर्मा फ्रॉम माजी कॉलेज ऑफ इंदौर इस बेढंगी दुनिया के संगी हम न होते यारा, अपनी तो यारी अतरंगी है रे। कर बेरंगी शामें हुड़दंगी मस्त मलंगी यारा, अपनी तो यारी अतरंगी है रे, अतरंगी रे। अतरंगी रे। Come on guys, जब लाइफ हो आउट ऑफ कंट्रोल, होठों को करके गोल, होठों को करके गोल, सीटी बजा के बोल, ऑल इज वेल। लाइफ आउट ऑफ कंट्रोल, होठों को करके गोल, होठों को करके गोल, सीटी बजा के बोल, ऑल इज वेल। मुर्गी क्या जाने अंडे का क्या होगा, लाइफ मिलेगी या तवे पे फ्राई होगा, कोई न जाने अपना फ्यूचर क्या होगा। तो होठ घुमा, सीटी बजा के बोल, भैया ऑल इज वेल, अरे भैया ऑल इज वेल, अरे चाचू ऑल इज वेल, अरे भैया ऑल इज वेल। कंफ्यूजन ही कंफ्यूजन है, सॉल्यूशन कुछ पता नहीं, सॉल्यूशन जो मिला तो साला क्वेश्चन क्या था पता नहीं। दिल जो तेरा बात बात पे घबराए, में रख के हाथ उसे तू समझा ले, दिल इडियट है प्यार से उसको समझा दे। सिटी बजा के बोल, भैया ऑल इज वेल, अरे भैया ऑल इज वेल, अरे चाचू ऑल इज वेल, अरे भैया ऑल इज वेल। स्कॉलरशिप की पी गया दारू, गम तो फिर भी मिटा नहीं, अगरबत्तियां राख हो गई, गॉड तो फिर भी दिखा नहीं। क्या जाने उसकी जान का क्या होगा, सीख गुजरेगी या साला की माँ होगा, कोई न जाने अपना फ्यूचर क्या होगा। तो होठ घुमा, सीटी बजा के बोल, भैया ऑल इज वेल, भैया ऑल इज वेल, चाचू ऑल इज वेल, भैया ऑल इज
Thank you, Mr. Anand, for such a mesmerizing voice. You mesmerize the whole crowd.
जोरदार तालियां हो जाए, वापस से एक बार जोरदार तालियां हो जाए फॉर दिस ब्यूटीफुल परफॉर्मेंस यार। बीच बीच में तालियां रुकनी ही नहीं चाहिए यार, परफॉर्मर्स का भी हौसला बढ़ता है। ओके ऑडियंस, थोड़ी सी दिल टू दिल की बातें होंगी। ओके दिल टू दिल की बातें,
यही जोश चाहिए,
बस यही जोश। ओके अभी थोड़ी सी दिल टू दिल की बातें, मेरा दिल आपका दिल। ओके लेट्स बी ऑनेस्ट गाइस, बॉलीवुड के हीरोज दर्द में रोते हैं, हाँ या ना? विलेंस गुस्से में चिल्लाते हैं, हाँ, और कॉमेडियंस सच बोल के फंस जाते हैं। सो लेडीज एंड जेंटलमैन, get ready to laugh till your stomach hurts. Welcoming on the stage the Anubhav Singh Bassi from Blinkit, our very own Mr. Soumya Ranjan Ratha. भाई ठीक है लाइट ऊपर कर दे हेलो 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 हाय एवरीवन जय जगन्नाथ सो हाउ आर यू ऑल ओ भाई हार्डकोर कर लेंगे छड़ा ओके ओके चलो शुरू करते हैं तो फिर ओके हाउ मेनी ऑफ यू हैव मेमोरीज रिलेटेड टू स्कूल लाइफ प्लीज रेज योर हैंड okay those who are showing their love life please down your hand कोई हाथ नहीं है नीट से ज्यादा अटेम्प्ट लव लाइफ को दिया था दोनों में फेल हुआ हूँ ठीक है देयर इज अ नाइस रेस्पॉन्स ओके चेंज द क्वेश्चन हाउ मेनी ऑफ यू आर मिंगल नॉट सिंगल not visible okay okay sir black shirt हाँ खड़ा हो खड़ा 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 you Sutos 39 okay okay let me ask you a question don't take it seriously okay अभी आपका गर्लफ्रेंड सीरियस हेल्थ इश्यूज पे है ठीक है ऑक्सीजन लगाए हो रहा है ठीक है ठीक है ठीक है ठीक है अभी आपको उनको बचाना है उनको बचाने के लिए आपको आपका एक्स को किस करना है क्या आप करोगे हाँ या ना हाँ या ना ना हाँ ये तो धर्म संकट है भाई डबल सिग्नल है तू डबल सिग्नल है रॉन्ग नंबर ठीक है मैं अभी आंसर बोलता हूँ ठीक है आंसर बोलता हूँ लॉन्डो की फट जाएगी ऐसा आंसर है ठीक है क्या करना है गर्लफ्रेंड के पास जाना है खड़ा होना है ब्रेकअप कर देना है उसके बाद किस करना है क्योंकि वो तो अभी एक्स हुई ना फिर से पैचअप कर देना है खत्म मेरे जैसा लॉयल बंदा ढूंढना बहुत मुश्किल है You can contact me on Instagram @somyarath69 चलो चलो तो फिर शुरू करते हैं ओके हम लोग मेमोरीज के बारे में बात कर रहे थे ना ओके मेरा स्कूल लाइफ में एक बहुत अच्छा मेमोरी है ठीक है स्कूल में हम एक एलिट ग्रुप था 3 दोस्तों का मैं था आदि था तीसरा था डोरेमोन वो जो छोटा बौना साइज का मैं हूँ एक उड़ता रोबो डोरेमोन वही क्योंकि 3rd स्टैंडर्ड में क्वेश्चन आया था एक्सटिंक्ट हुए हुए जानवरों का नाम लिखिए इसको पता नहीं था इसने सामने वाला का देखा ये था अंधा सामने वाले ने डायनासोर लिखा था इसको लगा डोरेमोन लिखा है डोरेमोन लिखा है और एक्स्ट्रा मार्क के लिए इतना डेस्परेट डोरेमोन का डायग्राम बना डाला अगले दिन मैम आई बोल रही है ये 2 पैर वाला बिल्ली किसने बनाया रे देखो इसमें मैम की कोई गलती नहीं है क्योंकि स्कूल ही स्टेट बोर्ड का था स्टेट बोर्ड का स्कूल क्या पता है डू एनीवन नो ओके ऐसा स्कूल जिसमें किसी को इंग्लिश नहीं आता है हमको इंग्लिश नहीं आता था ठीक है इंग्लिश मैम को नहीं आता था उनको जॉब इसलिए मिला था बिकॉज उनका नाम एल्सा था एल्सा कुमारी चौधरी तो फिर हमारा स्कूल लाइफ कंप्लीट हुआ हम तीनों ने सेम कॉलेज में एडमिशन लिया सॉरी मिला था सेम कॉलेज में क्योंकि इतना कम परसेंटेज आया था मेरा लिमिटेड एडिशन परसेंटेज आया था 69.69% इफ यू नो यू नो ओके हम कॉलेज में गए तो डोरेमन बोलता है भाई मेमोरीज बनाते हैं तो फिर हमको मेमोरीज बनाने के लिए 12th स्टैंडर्ड में एक चांस मिला वो था पिकनिक का लेकिन एक प्रॉब्लम था हर कॉलेज में होता है एक ऐसा सर जिसको हर कोई डरता है
हमारे कॉलेज में थे तावड़े सर। वो सर नहीं, दरिंदा था। पॉकेट में जल्लाद का फोटो रखता था। क्या फ्रस्ट्रेशन था पता नहीं, जिधर जिसको देखता था उधर मारता था। बच्चों ने उनके लिए एक शायरी लिखी थी। अभी आएंगे तावड़े, लगेंगे सबके। तो वो पिकनिक के दिन आए, उधर अटेंडेंस लेना शुरू कर दिए। हम सब चिल एंड एक्साइटेड थे, लेकिन आदि की फटी थी क्योंकि वो 11th स्टैंडर्ड एक भी क्लास अटेंड नहीं किया था। तो सर अटेंडेंस लेना शुरू किए, एक एक करके ले रहे थे। आदि को देखे और देखते ही रह गए। तू कौन है रे? तो आदि को पता नहीं सर कैसे थे, तो सर को देखा, बोला सर मैं आदि, आदित्य नारायण। सर का दिमाग हिल गया, कहीं याददाश्त कमजोर नहीं हो गया तो। लेकिन सर थे स्मार्ट, तो उन्होंने बोला तो तू मेरा सारा क्लास अटेंड करता है, एक चैप्टर का नाम बोल दे। उसको चैप्टर का नाम छोड़ो, सर का नाम भी पता नहीं था, तो उसने हमारे तरफ देखा। सोनोमीटर, इलेक्ट्रिसिटी, न्यूटन लॉज ऑफ मोशन, ये सारे फिजिक्स के चैप्टर थे, हमें पता था। लेकिन हम हैं लौंडे लोग, मेमोरीज के बारे में सोचते हैं। भाई फोटोसिंथेसिस बोल दे। 12th स्टैंडर्ड का बच्चा एक चौड़ में खड़ा होता है, सर फोटोसिंथेसिस। ऐसा होता है ना, गुस्से में हम कुछ बोल देते हैं, वो कोट ऑफ द डे बन जाता है। उस दिन सर गुस्से में बोले, ओए फोटोसिंथेसिस 7th क्लास में खत्म हुआ था, तेरा करियर कल खत्म होगा। तो आदि रोने लगा, हमारे पास आया, बोला भाई सर मुझे कल रश टिकट कर दें, क्या करूँ? तभी डोरेमन बोलता है, अरे भाई कल रश टिकट होगा ना, आज मेमोरीज बनाते हैं। तो हम लोग पिकनिक स्पॉट पे गए। वो एक रिजॉर्ट था, बहुत अच्छा रिजॉर्ट था, डीजे नाइट, स्विमिंग पूल, बहुत अच्छा था। तो डोरेमन गया उधर, जाके बोल रहा है, भाई कॉलेज ने हमारे लिए इतना कुछ किया है, हमें भी कुछ करना चाहिए। तो उसने बैग से 4 ओल्ड मॉन्क के खंबे निकाले। तो मैंने पूछा भाई कैसे पियेंगे? तो उसने एक मास्टर प्लान बताया, ठीक है, थम्सअप का आधा लीटर बोतल लेंगे, आधा फेंकेंगे, ओल्ड मॉन्क ऐड करेंगे, डीजे नाइट के पार्टी में कॉर्नर में एंजॉय करेंगे। मास्टर प्लान था, मास्टर प्लान। हाँ, मैंने भी वैसे ही सोचा था। 150 के 150 लौंडे सेम प्लान में गए थे, सारे फ्लैट। उसी बीच आदि बोलता है, भाई चढ़ नहीं रही है, कुछ कर भाई। डोरन बोलता है, चल भाई नीट बनाते हैं। तो उसने नीट बनाया 120 ml का। वो नीट नहीं, वोल्कानो था। उसे एक बार पीने से ऑर्गन का सारा लोकेशन पता चल जाता है। उस एक शॉट ने मुझे बता दिया, किडनी आगे नहीं पीछे होता है। लिवर ने तो रिटायर ही ले लिया, एक शॉट में तीनों आउट। तो उसी बीच डोरेमन बोलता है, पूरा नशे में है, बोल रहे हैं, अरे भाई निधि को मैं आज प्रपोज करके रहूंगा। तभी आदि बोलता है, हाँ भाई निधि सिर्फ तेरी है, निधि बायो की मैम थी। 11th स्टैंडर्ड में क्वेश्चन आया था, हाउ टू कंट्रोल पॉपुलेशन, वो फेबिक्विक लिख के आया है। अगले दिन मैम आई, बोल रही है मम्मी पापा को लेके आओ। वो बोल रहे, भाई शादी के लिए बात हो चुकी है भाई। Laughter recess, please. 1 minute. तो डोरेमोन ने बोला, भाई चल लॉन्ग ट्रिप पे चलते हैं। तो मैंने बोला गोवा के लिए प्लान बना रहा होगा कुछ। तो उसने पॉकेट में हाथ डाला, गांजा का पैकेट निकाला। तो आदि ने एक बार लिया, उधर फ्लैट हो गया। डोरेमोन ने 2 बार लिया, उल्टी करना शुरू कर दिया। मैं लेने वाला था, तभी तावड़े सर आ गए अपने चैम्बर से, क्योंकि उनका खंबा कंप्लीट हो गया था। तो हम लोग डर गए, हम लोग आके स्विमिंग पूल के पास बैठ गए। तो सर आए हमारे पास, बोल रहे, ओए वो उधर उल्टी क्यों कर रहा है, इंडाइजेशन हो गया क्या? हम लोग डोरेमोन के बारे में बात कर रहे थे। तभी आदि आया, तावड़े सर के सामने खड़ा हुआ, कंधे पे हाथ रखा, बोला, तावड़े, निधि सिर्फ डोरेमोन की है, निधि तावड़े की धर्म पत्नी थी। तो उसने हम तीनों को चैम्बर पे बुलाया, तो रस्टिकेट करने के लिए बोला। तो हमने बहुत सॉरी बोला, पैर पकड़ा। तो उसने हाँ बोला, बट एक शर्त पे, और जितने भी दारू के खंबे हैं उनको सबमिट करना पड़ेगा। तो हमने कर दिया, कोई बात नहीं। हम लोग रिटर्न कर रहे थे, तभी बोला, ओए सुन, डोरेमोन को बोल रहे, ओए सुन, एक नीट बना। तो डोरेमोन ने नीट बनाया 120 ml का। वो सर एक घटक में कंप्लीट कर दिए। वैसे पिकनिक बहुत अच्छा गया। अगले दिन हम स्कूल आए। स्कूल आते वक्त हमें पता चला तावड़े सर को कॉलेज से निकाल दिया गया है। ही हैज़ बीन फाइड अप। हम लोग पता है ऐसे कैसे हो सकता है? तो पता चला आदि, हम लोग स्कूल गए तो पता चला आदि प्रिंसिपल रूम से निकल रहा था। तो देखे तो आदि के फ़ोन में तावड़े सर को पीते हुए कुछ पिक्चर दिखा। तो वो सर को सबमिट कर दिया था। तो आदि के लिए हम लोग एक ही शब्द निकलने आते, जहाँ पना तुझसे ग्रेट हो, तोहफा कबूल करो। ओके, तभी आदि ने एक लाइन बोला, भाई रुक जाए, कॉल करना है। तो उसने फ़ोन निकाला, कॉल किया, हेलो तावड़े, फोटोसिंथेसिस 7 क्लास में ख़त्म हुआ था, तेरा करियर आज ख़त्म हो गया। थैंक यू, थैंक यू।
थैंक यू मिस्टर सौम्या, हसी हसी पेट दरा जाएगा। थैंक यू सो मच मिस्टर सौम्या। क्यों, तेरे को हंसी नहीं आई क्या? तेरा मुंह सड़ा क्यों है?
अरे वो सब तो ठीक है यार, पर अब जो आने वाले हैं ना, वो सबको शॉक करने वाले। यू ऑल विल बी शॉक्ड टू योर कोर।
अरे अच्छा, वो जो खुद को जीनियस बुलाता है?
हाँ, सही कहा। तो गाइस, अपनी कुर्सी की पेटियां बांध लें जरा। बेल्ट्स, बेल्ट्स, या गाइस, बेल्ट्स। क्योंकि सबको अपनी तरकीब से हैरान करने के लिए आ रहे हैं खानों में खान, मिस्टर फरहान खान।
हेलो हेलो।
Good evening, everyone. So today I am going to show you something with this. While I was a kid, I was fascinated by a Rubik's Cube. I always wonder how amazing it would be. I just shake the cube and it gets solved. But do you think it is even possible that someone shakes the cube and it gets solved? Swastik, can you go to the audience? I need you.
श्योर सर, मुझे भी मैजिक देखना है यार। ट्रिक्स पता लगा तो ऑडियंस को भी बता दूंगा मैं।
So I will shuffle the cube. Ma'am, just give the mic to ma'am. Ma'am, is this much shuffle okay, or shall I shuffle it more? Okay, the audience want me to shuffle it more. This much? Okay. So what we'll do is, I'll just take a paper bag. I'll just put the cube in the bag. When I just shake and I snap, the cube comes out solved. Some might be thinking, wait a minute. Some might be thinking, there is a second cube in the bag. I will check, there is no bag. See, no bag. Still not convinced? For the next performance, I want someone to join me on the stage. Yeah, come. Until she joins, I want to show you something cool. Everyone, something very cool. I want every one of you to focus, because if you don't focus, you can actually miss the trick. Watch out. I have a complete cube here. Solved. Okay. So here's the thing. You have to miss it as much as possible. Okay. Take. So in a Rubik's cube, there are 43 quintillions possible combinations. That is 4.3 into 10 to the power 19 possible combinations. So what she is mixing, I don't know. Let's see if I can do something impossible. Thank you guys. So here's the thing. I'll just put in the bag, just a snap, the cubes comes out, solved. Wait a minute. It would be an amazing trick if there was not a second cube in the bag. Just keep it, just hold it, just keep it like that. So the actual trick was not to solve the cube, but to mix the same way she has mixed. As I have said, there are 43 quintillion possible combinations and only one possible way she has mixed. So let's see if I can do what she has mixed. Right about there. So this is the first layer. The second layer, the third layer, the fourth layer, the fifth layer, and the sixth layer. No, sorry. Sixth layer.
Oh my god, this is amazing.
So now we have mixed. Now we'll try to solve it without even looking. Okay? So while I went to the Rubik's Cube competitions, there were participants better than me. So what I did was I used to cheat. For cheating, the most important thing is distraction. So distraction is the key here, as I am distracting you all now. So watch out. I have a mixed cube in my hand. See, I have a completely mixed cube in my hand. Just see, it's a mixed cube completely. Cheating happens in a second. The cubes come out solved. Ma'am, can you please do me a favor? Please come to this. You can go. Thank you. Just select a random color and hide it. I can't see, nobody can see, just yours. Just keep it in the top. For example, you have chosen yellow. Just keep it in the top and just hide it, okay? Just nobody can see, okay? I want someone. Ram sir, can you please join me on the stage? It will be honor. Guys, everyone cheer for Ram sir.
Hello. I was relaxing. He tricked me.
Sir, have the mic. Sir, as you can see, there's a completely mixed cube. You can see, completely mixed. Just show me your hand. have a completely mixed cube here. See, completely mixed. Just keep it like this, okay? Don't move. Just, yeah, just keep it like this. Ma'am, for the first time, reveal the color you have chosen. It's blue. So, sir, as you can see, blue has just disappeared from the cube. Show to the camera, show to the audience. Actually, so can you see so all side? The blue is lying beneath the cube, okay? So what we'll do is, so can you please just now hold it like this? I have another thing, just no, normal. I have another trick. Swastik, can you help us? Swastik, can you assist, sir? Just hold the cube from sir. Sir, I have a completely mixed deck of cards. You need to say me stop anywhere you want. Sir, say in the mic.
Please stop.
Okay. So what is your card?
Is a heart.
So, say to your audience.
Heart, red, 6 of hearts.
Very good. 6 of hearts. So what I will do is, there is a 6 of hearts in my hand. I'll just tear the 6 of hearts. So, where is that? Does the 6 of heart went? It's lying inside the cube. Watch out. Sir, can you hold the card, please? Thank you, sir. So, I will just take a random piece from the cube, okay? So, what we'll do is, I'll just take, what? If you watch closely, inside it, there's a piece. Can you please touch it? And open and join, it is the same 6 of heart that I told just now.
Let us see.
Thank you, sir. Wait a
It's
minute.
exactly matching.
Sir, for the last part, do you know how to solve a Rubik's Cube?
No.
Okay, you have never tried. Okay.
I tried, but failed many
Okay,
times.
what we'll do now is, you'll keep the hand in your back. I will hand you the cube to you. Just shake it 3 times and show it to the audience. Okay?
3 times.
Shake the cube 3 times and just bring it front like this.
Okay.
1, 2, 3 and bring it to the front. Okay? So guys, everyone watch. There's a mixed cube in my hand. Okay? Sir, just put your hand in the back. Just shake it 3 times. Show it to the audience. The cubes come out solved. Thank you, sir. So you want to stay or you just want to rest? Your wish.
You want more?
Yes, I want more. Thank you, sir. It would be an honor for me. So you need to stay me stop. Anywhere you want.
Stop now.
Don't say me. Don't say me this time and not looking. Okay? Okay? I have put the card back. I need you to shuffle so that audience have doubts that I can control the cards. I want you to completely mix the cards. Okay? Just and completely mix. Mix as much as you want. Done. As you can see, the whole deck is different. There's no repetitions in the card. See? None of the card is repeating. Okay?
Okay.
So what I will do is, I'll just do a quick shuffle. Just pick a card. So this was your card. Was this your card?
No.
Say it in the mic. This was not your card.
No.
Okay. Just give me your hand like this. I'll just give the 3 of clubs to you. Just do it. Keep it like this. Okay. Sir has 3 of clubs. So what I will do is, I will take a random card. Just do a quick swipe. The 3 of clubs comes to me. But wait. If the 3 of clubs is with me, then What card sir is holding? So can you show what card are you having? Thank you, sir. Thank you. So for the next part, sir, I want another wall randomly. Sir, can you please come, sir? Sir, sir, sir. Sir, please, sir, please. Sir, sir, please. Sir, please, it would be an honor for me. Sir, please. I insist, sir. Okay, sir. Anyone from the audience, please join me. Sir, can you please, sir, please. Yes, sir, excellent, sir, excellent. Thank you, sir. Sir, as you can see, I have completely deck. Pick any card you want, randomly. You want to keep it or you want to change your mind? You are keeping it. So show it to the audience, don't show it to me. I'm not seeing it, I'm not seeing. Okay, done?
Yes.
Just put it back anywhere you want. Okay, so what I will do is, I'll just put it, sorry, what I will do is, I'll just take a card from the deck, I'll put the card, we'll do random thing. Repeat after me, guys. Abracadabra. Okay, what is there? If I split the card, whole deck is shuffled, only except one card, which is your card. Can you confirm it to the audience? Thank you so much, sir. Thank you so much. So for the next part, what I will do is, I'll just pick the cards. I just want you to say me stop anywhere you want, okay? Hold the mic to your mouth.
Sure. Okay. Stop.
This is your card, okay? So remember what is your card. So what we'll do is, we'll just do a quick shuffle. We'll do a quick shuffle. We'll just sorry. I'll try to bring the cards, okay?
Can I shuffle?
Yeah, you can shuffle, sorry. Sorry, was this your card?
Yes.
Okay. So this time what we'll do is, I will give you to shuffle, okay? But for this, I want just a minute to check. Yeah, you can shuffle. Thank you so much, sir. So, sir, as you can see, you have given me a shuffle deck, okay? I'll just take jokers, like 2 jokers. We'll see random 2 jokers. In a deck of card, we have 2 jokers, okay? So what is the probability of getting if you touch a card, what is the probability that that card we touch is a joker? So we got a 1 joker, and I'm showing if I have 2 jokers here with me. Okay, I'm not getting. Yeah, here it is. Okay.
Okay.
So I have 2 jokers. Now what we'll do is, I'm shuffling it just for confirmation. Okay. So we have two random set.
Yes.
In a deck of cards, what is the probability of, if I ask you to touch a card, what is the probability that the card you have touched is a joker? 2 out of 52.
Yeah, 2.
Just touch a card. Okay, you want to keep it or you want to change your mind?
And keep it.
Okay, you want to keep. Just see and show it to the audience what is your card. Okay. So, as you know, this is not a joker. This is not a joker. Just keep it back. Just keep it back. Just randomly. Okay. So this is not a. Okay. This is not a joker. Okay. Completely mixed. So this is not a joker. So what is the probability the card you have put back is sandwich between 2 jokers?
Sandwich between 2 jokers.
2 jokers.
It will be again 2 out of 52.
No. Just say me randomly.
1 out of 52.
No. If you apply permutation combination, the possibility of getting 2 jokers at the same time is in a millions, and the card getting sandwich between them is more than a million. Okay. For the first time, reveal what was the card.
10 of spade.
10 of
spade.
Spade. So 10 of diamonds. Sorry.
No.
Okay. there is one card sandwich between the jokers. It is 10 of diamonds. Was this your card? Are you sure?
Yeah, yeah, sure. Yes. 10 of jokers. 10 of diamonds. 10 of diamonds. Yes.
Okay. So what we have here is we have a joker here. In a card deck we have two jokers. So what I'll do is I'll just make a quick snap. The card goes vanish. In the deck you can see there's a one joker completely here. Okay. The where is that other jokers went? It lying inside the bag.
It's here.
So do you think there's a possibility that I have the third joker? Is it possible?
No, I didn't see it yet.
In a deck, we know in a deck there is only
Two jokers.
two jokers. I have two jokers here. Do you think there is a third joker with me? It
I
can
didn't see it. If it is there,
Okay,
it can be there, but I didn't see it.
Okay. So this comes out nullified because you didn't give me a clear answer. Okay.
No.
So thank you guys that much. And if you want, I can give a last shot. Okay.
Okay.
Last performance, guys. So we have. I will
One
just
joker.
no. I will just keep the joker here. So what we'll do is I will show you the random cards. You just select a card in your mind and don't say it to me. Whenever you have chosen the card, just don't say me anything. Okay. Don't say me anything. Just keep select a card and keep it in mind. Okay.
From here.
No, I'm showing.
Okay.
Have you made a decision? So you have made your decision. So what we'll do is I'll just make a quick cut in the cards. In a normal card tricks, what it is that the magician will ask you to take a card and it will ask you to keep it back, but I didn't do that. What I did was I just asked you to randomly select a card out of the number of cards. So in this, can you see your card? Can you see your card?
Not yet.
Not yet. Sorry. So you can't see. So the card is completely mixed. So what I will do is just keep some random cards in there. Sir, reveal your card. What was your card?
4 of club.
Just take from the top.
Take from the top.
Thank you. Thank you,
4 of
everyone.
club.
Thank you, everyone. Thank you, sir.
Sure. Thank you.
Sir. Thank you, guys. Farhan Khan signing off. Okay. Just for my friends. So Swastik asked me once that if I just vanish the card and produce it, he will marry me. Do you confirm it? So you said me that if I vanish a card and produce it from somewhere else, you will marry me. Okay. So I have a joker here.
अरे इज्जत दाव पे है मेरा.
Just ace comes.
Ace.
Then where did the joker goes? Ma'am, can you just lift that flower basket? What is the card that?
वाओ! अगर आप सब सोच रहे हैं कि ये मैजिक का सीक्रेट क्या था, तो फिर डोंट वरी, मैं भी वही सोच रही हूँ. Thank you so much for this magical performance, Mr. Farhan.
बहुत शॉकिंग परफॉर्मेंसेस थे. और एक बार बहुत जोर से तालियां हो जाए फरहान खान के लिए.
यार थोड़ा जोर बजाओ यार.
जोरदार से तालियां हो जाए.
So let's welcome Miss Madhumita from SV Netar for solo song.
Hello. 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 आज आसमां से आ गई आगे मैं जहां से ये क्या हुआ मिल गई आज आसमां से आ गई आगे मैं जहां से ये क्या हुआ उड़ी नींदें आँखों से जुड़ी रातें ख्वाबों से मुड़ी ये जाने मैं कहाँ उड़ी नींदें आँखों से जुड़ी रातें ख्वाबों से मुड़ी ये जाने मैं कहाँ मिल गई आज आसमां से आ गई आगे मैं जहाँ से ये क्या हुआ ज़मीं पे है या बादल पे उलझे सितारे आके आंचल से ज़मीं पे है या बादल पे उलझे सितारे आके आंचल से झीली उम्र सारे इस पल में कुछ भी नहीं अब मेरे कल में उड़ी नींदें आँखों से जुड़ी रातें ख्वाबों से मुड़ी ये जाने मैं कहाँ उड़ी नींदें आँखों से जुड़ी रातें ख्वाबों से मुड़ी ये जाने मैं कहाँ मिल गई आज आसमां से आ गई आगे मैं जहां से ये क्या हुआ उड़ी नींदें आँखों से जुड़ी रातें ख्वाबों से मुड़ी ये जाने मैं कहाँ उड़ी नींदें आँखों से जुड़ी रातें ख्वाबों से मुड़ी ये जाने मैं कहाँ उड़ी नींदें आँखों से जुड़ी रातें ख्वाबों से मुड़ी ये जाने मैं कहाँ थैंक यू
Thank you so much, Madhumita, for mesmerizing the whole crowd. Let's move on to our next performance.
Okay, let's welcome MD Tausif Alim from IPH Delhi on the stage. Let's give it up, guys. Cheer karo, cheer karo.
हेलो हेलो चेक
तुझे अपना बना लूं, तुझे तुझसे चुरा लूं, तुझे खुद में छुपा लूं साहिबा। एक मुझ पे करम हो, तू ही मेरा सनम हो, तेरी मुझ पे नजर हो साहिबा। मर मैं जाऊंगा रह न पाऊं, गम जुदाई का सह न पाऊं, है तुझे प्यार का वास्ता। तेरी यादें है कुछ अधूरी, सांस आधी है कुछ है पूरी, आंखों में है कैसी ये नमी, रात के चांद तले आगोश में बाहों में ले लो मुझे, जरा सपनों में अपने बसा। मेरा मन कहने लगा पास आके न तू दूर जा, छूने दे होठ तेरे, जरा सपनों में अपने बसा।
Thank you. Thank you. Next, Sambalpuri Dean Pratik.
जोरदार तालियां हो जाए फॉर मिस्टर तौसीफ। बहुत खूबसूरत गाना गाया उन्होंने। He blessed this stage with his voice. Let's move on to the next performance.
And now moving ahead, please put your hands together and welcome to the next performance of the evening, जो कि ओडिशा की लोक संस्कृति का एक अहम हिस्सा है। ढोल की थाप, रंग बिरंगे परिधान और पश्चिम ओडिशा की पहचान, ऊर्जा और उमंग से भरा हुआ ये नृत्य अति सरल और अत्यंत महान। Any wild guesses, audience? ए भाई तू रहने दे, तुझसे ना हो पाएगा। असली वाले को बुला।
जोड़ो जोड़ो के सकली बेटी धरो रे माएला जोड़ो जोड़ो रो कथा लड़ो पड़ो रे माएला जोड़ो सोर धरी था पहला ईटा जगला कीटा गाजी गिरा गिंजा टुपकी बांगड़ी मागुर गुड़ी रंग हल्दी माखी ठमकी ठमकी जासी चाली जुड़ा गरी आधरी टुपकी बांगड़ी मागुर गुड़ी रंग हल्दी माखी ठमकी ठमकी जासी चाली जुड़ा बेलो रठू मेरो ऐसी कंटा खाली रे माएला जोड़ो जोड़ो के सकली बेटी धरो रे माएला जोड़ो जोड़ो रो कथा लड़ो बड़ो रे माएला जोड़ो रे खांगा पाते हैं गात चोना सेगा
थैंक यू ड्रीम्स कॉलेज फॉर सच ए वंडरफुल डांस यार, बहुत अच्छा परफॉर्मेंस था, जोरदार तालियां हो जाए। मैं तो यहाँ
और रूटिंग करो गाइस, क्या इतना ठंडे क्यों पड़ रहे हो?
सुमन वहाँ तो गैलरी वाले सबसे ज्यादा मजा कर रहे हैं, इधर वाले कम है और इधर वाले कम है। क्या आप लोग कम एंजॉय कर रहे हो?
आप लोगों के तक पहुंच नहीं रही है क्या?
जोर से बोलो, हाउस द जोश। लेफ्ट वाले हाउस द जोश। राइट वाले हाउस द जोश। अरे राइट वाले तो बहुत ज्यादा बोल रहे हैं यार। लेट्स मूव ऑन टू आवर नेक्स्ट परफॉर्मेंस।
And next performance is by Pranati Barik from SV Nirtar.
मैं रूठिया यार मनावांगी, हर चल मन फूक चलावांगी, चंद पत्थर राजा पिघलेगा, तद में कमली कहलावांगी, तद में कमली मेरे माहिया सनम जानम कि मैं करे अनबी दानम, सद पुजरे थे जग जोया नी में जगे अनबी दानम। मेरे माहिया सनम जानम कि मैं करे अनबी दानम, सद पुजरे थे जग जोया नी में जगे अनबी दानम। नी में कमली कमली, नी में कमली कमली, नी में कमल कमली मेरे यार दी, नी में कमली कमली, नी में कमली कमली, नी में कमली कमली मेरे यार दी। झील तिड़को कर गया तू जरिया दरिया मेरे यारा, अखियां दे मोहल्ले में हर शाम गिरा नम, सब गुजरे ते जग सोया नी में जगे अरमी दानम। मेरे माहिया सनम जानम कि मैं करे अरमी दानम, सद गुजरे ते जग सोया नी में जगे अरमी दानम। मैं तो पहन के सांपा केसरिया जुगिनी जोगन बन जाऊं, सुर में दे काले जादू से रोह दे तो पहन के साफा केसरिया जुगनी जोगन बन जाऊं सुर में दे काले जादू से कह दे तो जोग बुलाऊं नी में कमली कमली नी में कमली कमली नी में कमली कमली मेरे आरती नी में कमली कमली नी में कमली कमली नी में कमली कमली मेरे आरती बेखुदी में तू खुदी का जरिया जरिया मेरे आया चल हार सितारों का चंद बरगा तो यारम सब गुजरे ते जग सोया नी में जगया ना मीदानम मेरे माया सनम जानम कि मैं करे आना मीदानम सब गुजरे ते जग सोया नी में जगया ना मीदानम नी में कमली कमली नी में कमली कमली नी में कमली कमली मेरे आरती नी में कमली कमली नी में कमली कमली नी में कमली कमली मेरे आरती नी में कमली कमली 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 मेरे आरती नी में कमली कमली नी में कमली कमली नी में कमली कमली मेरे आरती
Get a great round of applause, guys. Thank you so much, Pranati. Let's move on to our next performance.
Okay. On the occasion of Oticon 2026, we are glad to have a special guest. He is very special and sportsly wants to sing a song. Everyone, please cheer him up. Inviting on the stage Soham Gain. जोरदार तालियों से स्वागत कीजिए उनका प्लीज.
हेलो
चल के तुझे मैं लेके चलो एक ऐसी गगन के तले
थोड़ा cheer करो, guys.
जहाँ गम भी न हो आंसू भी न हो बस प्यार ही प्यार पाले एक ऐसी गगन के तले चल के तुझे मैं लेके चलो एक ऐसी गगन के तले जहाँ गम भी न हो आंसू भी न हो बस प्यार ही प्यार पाले एक ऐसी गगन के तले.
ऑडियंस प्लीज मिलके गाते हैं.
जहाँ डोराए आशा का तेरा जागे.
ऑडियंस एक बार सारे के सारे अपना माइक का फोन के लाइट्स ऑन करके एक बार प्लीज गाइस प्लीज इट्स अ रिक्वेस्ट फोन के फ्लैश लाइट्स ऑन करें प्लीज. cheer him up guys, cheer him up.
चंदा की किरण से डोलकर गन गोर अंधेरा वागे चंदा की किरण से डोलकर गन गोर अंधेरा वागे सपनों में पली हंसती हो कली जहाँ सांग काले जहाँ गम भी न हो आंसू वाले, एक ऐसी गगन के डाले। जहाँ डोर नजर दौड़ाए, आजाद गगन लहराए। जहाँ डोर नजर दौड़ाए, आजाद गगन लहराए। चंदंग बिरंग के पंछी आशा का संदेशा लाए। जहाँ रंग बिरंग के पंछी आशा का संदेशा लाए। सपनों में पली हंसती हो कली, जहाँ शाम सुहानी डले। जहाँ गम भी न हो, आंसू भी न हो, बस प्यार ही प्यार वाले। एक ऐसी गगन के तले, चल के तुझे मैं लेके चलो। एक ऐसी गगन के तले, जहाँ गम भी न हो, आंसू भी न हो, बस प्यार ही प्यार वाले। एक ऐसी गगन के तले, एक ऐसी गगन के तले, एक ऐसी गगन के तले। नमस्कार।
जोरदार तालियां यार, तालियों की बारिश रुकनी नहीं चाहिए प्लीज गाइस। और एक बार तालियां जोर से। Thank you Soham, thank you Soham, thank you for being an inspiration to all the special ones. We as autists want this and this only. Okay, sorry guys, थोड़ा goosebumps आ गया मेरे को। Okay. So सुमन, बॉलीवुड के साथ साथ आज साउथ का तड़का हो जाए।
क्यों नहीं, क्या बोलती जनता यार।
क्योंकि रजनीकांत हो या अल्लू अर्जुन, डांस में लॉजिक नहीं सिर्फ मैजिक चलता है।
थोड़ा जोर, थोड़ा जोर।
Let's give it up guys for South Indian dance group from SV Nirta.
ఇంకేం కావాలే, నీకై నువ్వే వచ్చి వాలావే, ఇకపై తిరనాళ్ళే.
చుట్టమల్లే చుట్టేస్తాంది తుంటరి చూపు, ఊరికే ఉండదు కాసేపు, అస్తమానం నీలోకమే నామై మరపు, చితనైతే నువ్వే నన్నా ఎందుకు పుట్టిందో పుట్టింది ఏమో నువ్వంటే ముచ్చట పుట్టింది, పుడతాని పిచ్చి పట్టింది, నీ పేరు పెట్టింది వయ్యారం ఓడి కట్టింది, గోరింట పెట్టింది, సామికి ముక్కులు కట్టింది, చుట్టమల్లే చుట్టేస్తాంది, చుట్టేస్తాంది, చుట్టమల్లే చుట్టేస్తాంది.
ये सारे स्लो सॉन्ग्स ठीक है, पर जो असल मजा है ना वो तो साउथ के तड़कते वाले भड़कते बीट्स में ही आते हैं। तो चलिए शुरू करें।
రంగాలంటూనే చిన్నదో చిన్నదో రాములరి గుడికొచ్చే చిన్నదో చిన్నదే రంగాలంటూనే చిన్నదో చిన్నదో రాములరి గుడికొచ్చే చిన్నదో చిన్నదే కాదుకాదంటూనే కుర్రదో కుర్రదో కొట్టడానికొచ్చిందే కుర్రదో కుర్రదే పచ్చి పచ్చి పంటూనే పిల్లదో పిల్లదో పల్లెట్టుకొచ్చిందే పిల్లదో పిల్లదే రంగాలంటూనే చిన్నదో చిన్నదో రాములరి గుడికొచ్చే చిన్నదో చిన్నదే
రాజమండ్రి రాగమంజరి మాయమ్మ పేరు తలవనోళ్ళు లేరు మేస్తిరి కళాకారుల ఫ్యామిలీ మరి నే గజ్జ కడితే నిద్రపోదు నిండు రాత్రి
సొగ్గులాడి స్వప్న సుందరి నీ మడత సూపు మా పటేల మల్లె పందిరి రచ్చరాజ కుందె ఊపిరి నీ వంక చూస్తే గుంటలోన డిరిడిరిడిరి
ఏం రసిక రాజువో మరి నా దాసు బావ నీతో ఎప్పుడింత కిరికిరి ఏం రసిక రాజువో మరి నా దాసు బావ నీతో ఎప్పుడింత కిరికిరి
ఆ కుర్చీని మార్చబెట్టి
Guys, make some noise! अरे मैं नहीं सुनिया आया हीरो
అబ్బాయి మనసునే అమ్మాయి లాగేసి తలగడలా నొక్కేస్తే ఏమైతాది
మస్తు మాస్ వస్తుంది బెస్ట్ ఊపు వస్తుంది హై హై హై
अरे यार बैठे क्या हो नाचो बे
రాయే రాయే నా రాకాసే నువ్వే బయటేసి అట్టా దోపేస్తే టాపులేసి పోదే పోదే పప్ప టాపులేసి పోదే పోదే పప్ప
రారో రారో నా శివ కాసి అగ్గి రాజేసి సిగ్గు పెట్టేస్తే టాపులేసి పోదే పోదే పొప్పో టాపులేసి పోదే పోదే పొప్పో
చెట్టు మీద మ్యాంగోలా నువ్వెంత చక్క ఉన్నావే
చాకులాంటి పిల్లాడే ఎంత షార్పుగున్నాడే
చాకొచ్చి మ్యాంగో కోస్తే టాపులేసి పోతే కన్నే కొట్టావంటే టాపులేసి పోతే ముద్దే పెట్టావంటే
టాపులేసి పోతే వెయ్యే పట్టాబట్టే టాపు టాపు టాపులేసి పోతే రో
Make some noise!
ಮಾಡಿಸುತ್ತ ಮನುಷ್ಯದ ನಾನು ತೋಲವ ಅರ್ರರ್ರ ನಾಕಮುಖ 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 ಮಾಡಿಸುತ್ತ ಮನುಷ್ಯದ ನಾನು ತೋಲವ ಚಿರ ಮೇಲೆ ಕಟಿ ಅರ್ರರ್ರ ನಾಕಮುಖ 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 ಅರ್ರರ್ರ ನಾಕಮುಖ 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 ಅರ್ರರ್ರ ನಾಕಮುಖ 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 ನಾಕಮುಖ
బాతి కమింగ్ ఓకే ఓకే தனக்குன்னு வாழாத நீ தரத்துல தாழாத ஒரு கடுமாறானே திருத்திட போறானே தனக்குள்ளமா தளபதி கச்சேரி தளபதி கச்சேரி அங்கனா மனபங்கனா பெரித்தனமா வைபாபலாமா கச்சேரி தளபதி கச்சேரி கொடிய பறக்க விட்டு விருந்து வச்சு கொண்டாடலாமா பக்கல விட்டாய் பக்கல விட்டாய் பக்கல விட்டாய் விட்டாரே பக்கல விட்டாய் பக்கல விட்டாய் பக்கல விட்டாய் விட்டாரே பக்கல விட்டாய் பக்கல விட்டாய் பக்கல விட்டாய் விட்டாரே பக்கல விட்டாய் பக்கல விட்டாய் பக்கல விட்டாய் விட்டாரே
Make some noise!
make some noise guys once more इतना पावर पैक परफॉर्मेंस था, पूरी जनता यहाँ तो सीट पे खड़ी हो गई। अरे भाई तुम लोग बैठे क्यों हो यार? एनर्जी नहीं है क्या?
Okay, so how's the juice, guys? नीचे वाले how's the juice? ऊपर वाले how's the juice? बढ़िया बढ़िया बढ़िया. So let's welcome the next performance by Mr. SP Om and Mr. Prateek.
अभी बैकस्टेज बोला डांस खत्म हो गया, मेरे गाने पे नहीं नाचेंगे। मैंने बोला नहीं नाचेंगे तो मेरा करियर आज खत्म। सब खड़े हो जाओ, नाचना है। प्रतीक सर हेल्प मी।
अरे कब तक जवानी छुपाओगी रानी? अरे कब तक जवानी छुपाओगी रानी? गवारों को कितना सताओगी रानी? कभी तो किसी की दुल्हनिया बनोगी, मुझसे शादी करोगी, अब मुझसे शादी करोगी, मुझसे शादी करोगी, अब मुझसे शादी करोगी।
अरे कब तक जवानी छुपाओगी रानी? कवारों को कितना सताओगी रानी? कभी तो किसी की दुल्हनिया बनोगी, मुझसे शादी करोगी,
अब मुझसे शादी करोगी, मुझसे शादी करोगी, अब मुझसे शादी करोगी।
कम ऑन।
झुमका दिलाऊंगा, कंगना दिलाऊंगा, सब कुछ मैं लाऊंगा तेरी कसम।
अरे चंदा चुराऊंगा, तारे मिलाऊंगा, सूरज झुकाऊंगा तेरी कसम। कभी तो मेरी जा दीवानी बनोगी, मुझसे शादी करोगी, मुझसे शादी करोगी, मुझसे शादी करोगी, मुझसे शादी करोगे। मैं जब भी आऊंगा वापस न जाऊंगा, डोली उठाऊंगा तेरी कसम।
सबको दिखाऊंगा, तुझको चुराऊंगा, दुल्हन बनाऊंगा तेरी कसम।
अरे कब तक मेरी जायूं मुझसे डरोगी? अब मुझसे शादी करोगी, मुझसे शादी
मुझसे शादी करोगी अरे कब तक जवानी छुपाओगी रानी कबारों को कितना सताओगी रानी कभी तो मेरी निगाहें बनोगी मुझसे शादी करोगी 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 मुझसे शादी करोगी
Thank you. You've been great today. Thank you.
Wow, what a power-packed performance! Thank you so much, guys.
भाई जोश तो फुल हाई लग रहा है.
अपनी closing script तो काटनी पड़ेगी भाई.
क्लोजिंग स्पीच तो गया. ओके, माहौल ठंडा नहीं करेंगे अपन. वापस से दे. मैं बोलूंगा हिप हिप, आपको क्या बोलना है? हिप 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 हिप.
थोड़ा जोर, थोड़ा जोर.
वापस से हिप 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 हिप. Okay, so get ready to go on a musical journey. Welcoming on stage one and only DJ Raj.
Warning, ladies and gentlemen, DJ Ross has hijacked the dance floor. Let the party begin. Frequency spiking, dance floor shaking. Come on to the dance floor. Raise up your hands, shake your body as the party protocol are engaged. Let's welcome the man for the hour, DJ Ross.
छुआ तूने बह गया
Hello people, how are you guys doing tonight?
मैं कभी ना किया इश्क ऐसा
Come on, let me see everybody hands up in there right now.
चाहिए ऐसी दीवानगी से मैं चाहूं तो
Come on, you guys ready to jump?
दफा कोई पागल हुआ मैं हुआ मैं हुआ से मैं उठा जो तेरा हुआ मैं
Come on, you guys ready? Everybody hands up. 1, 2, 3, let's go.
अफगान जलोगी माशूक फरेबी घायल है तेरा दीवाना भाई
इसी को hands up. Come on, you guys sing this one.
अब्दुल जिगर आदिल है नजर एक माह जबी एक नूर नहीं रब की जुदाई क्या है तबाही गर्दन सुराही बोली इलाही आसमान जलेबी माशूक फरेबी कायल है तेरा दीवाना भैया भैया बंदूक आके क्या प्यार करेगी शराब कभी बिगाड़ता भैया भैया आसमान जलेबी माशूक फरेबी कायल है तेरा दीवाना भैया भैया बंदूक दिखा क्या प्यार करेगी शराब कभी बिगाड़ता भैया भैया आसमान जलेबी माशूक फरेबी कायल है तेरा दीवाना भैया Are you ready? Are you ready?
Come on, you guys ready for this one? All the Punjabi lovers tonight.
Ladies and gentlemen, you are not ready for this.
दिल पर देती हूँ तेनू इंतजार होना पै जाऊगा नाल रजेती जोगी ते तेनू जोगन होना पै जाऊगा
Guys, ready? कौन फिर से एक बार दोनों हाथ ऊपर हो जाए कौन
Ladies and gentlemen, you are not ready for this.
You guys know those steps.
دوس عندي خوش فصلة يا اخي توز والله خوش رقصة يا اخي دوس عندي خوش فصلة يا اخي توز خليك شبيه عطني رقصة فريسة زيد عليها شوي عندي بيزة اكل محتار اللي عارفه صيده سوي لي وقت انا هيبه هيا سوي رقصة وياه جيب لي واحد كرك يلا وياه لك سيارة بوليس يلا سوي لي رقصة ثانية رقصة المطرب ولا سوي فيها يا اخي
Everybody hands up, get your fucking hands up. One, two, three, let's go! I guys need your energy right now. You guys sing this one.
देखा जो तुझे यार देखा जो तुझे यार दिल में बजती गिटार छलका आंखों से प्यार दिल में बजती गिटार छा रहा कैसा ये नशा रे आ रहा सीने का मजा रे अरे अरे मैं तो गया दिल की गया रे अरे दिल में तो गया दिल की गया रे अरे दिल में तो गया दिल की गया रे अरे दिल में तो गया दिल की गया
I'm on, you guys ready? 1, 2, 3, let's go! और मेरे सारे भाइयों और उनकी बहनों पागलपंती शुरू की जाए। Come on, you guys, play! Hello, please everyone go down. Please everyone go down. Go down, go down.
Dame un grr.
¿Un qué?
Un grr.
¿Un qué?
Dame un tu ta ta tu ta tu ta ta tu. Dame un grr.
Come on, you guys, ready for?
Un grr.
¿Un qué?
Dame un tu ta ta tu ta tu ta tu. Dame un grr. Un grr. Un grr. Un grr. Dame un grr. Un grr. Un grr. Un grr.
Girl, you're my chamacacello. Where you go, girl, I'm gonna follow. What you want, girl, just let me know. You can be my chamacacello. Shorty, I'm gonna get ya. You know I'm gonna get ya. You know I'll even let you be my chamacacello. Yes, I sharmana aja nach ke dikhane. Aa meri hone aja pari da girane. Aa meri yakkiyon se yakkiyon milane. Hum tu na nakhre dikha. Wanna be my chamacacello. Wanna be my chamacacello. Wanna be my chamacacello. Wanna be my chamacacello.
Come on, let me see everybody hands up in the air. All the hands up.
All right, ladies and gentlemen, let me see everybody's hands up in the air and
Clap, clap, clap.
and clap, clap.
Everybody, hands up! Hands up! Get set, jump, jump!
क्रिस का सुनेगा गाना क्रिस का
कौन कौन क्रिस का गाना सुनेगा यहाँ पे?
दिल ना दिया दिल ना दिया
Everybody together!
ना बोलो क्या किया बोलो क्या किया ये दुनिया में भी अगर प्यार न किया तो क्या किया ये दुनिया में भी अगर प्यार न किया तो क्या किया ये दुनिया में भी अगर प्यार न किया तो क्या किया
Everybody, hands up! Motherfucking hands up!
प्यार न किया तो क्या किया दिल न दिया
तेरे लिए ही तो सिग्नल दिल्ली वाली गर्लफ्रेंड छोड़ छोड़ के
1, 2, pump, jump! Come on, you guys ready? ऐसे नहीं सभी के दोनों हाथ ऊपर
बेकरार करके हमें यूं न जाइए आपको हमारी कसम
Come on, you guys ready to jump right now? Put your fucking hands up! I'm going to all the South Conference tonight.
मेरे ख्वाबों में जो आए आके मुझे छेड़ जाए मेरे ख्वाबों में जो आए आके मुझे छेड़ जाए उसे कहो कभी सामने तो आए मेरे ख्वाबों में जो आए आके मुझे छेड़ जाए उसे कहो कभी सामने तो आए
Come on, you guys, hands up in there one more time. Let me see you jump, jump.
जीने के है 4 दिन बाकी है बेकार दिन जीने के है 4 दिन बाकी है बेकार दिन आए एक बार जो चढ़े जवान फिर ना आए जवानी फिर ना आए जीने के है 4 दिन बाकी है बेकार दिन जाए 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 एक बार जो चढ़े जवान फिर ना आए जवानी फिर ना आए कब तक जवानी छुपाओगी रानी अरे कब तक जवानी छुपाओगी रानी कमारों को कितना सताओगी रानी कभी तो किसी की
All the beautiful ladies.
मुझसे शादी होगी मुझसे शादी करोगी मुझसे शादी करोगी मुझसे शादी करोगी और कब तक जवानी छुपाओगी रानी कमारों को कितना सताओगी रानी कभी तो किसी की दुल्हनिया बनोगी मुझसे शादी करोगी मुझसे शादी करोगी मुझसे शादी करोगी मुझसे शादी करोगी मुझको क्या हुआ है क्यों मैं खो गया हूँ पागल था मैं पहले
all the Sambalpur lovers tonight. One, two, three, let's go. Check, check. कौन सारे भोजपुरी वाले
कमरिया करेला पालप लॉलीपॉप लागेलू
हेलो हेलो check 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 check
जिला टॉप लागेलू हो जिला टॉप लागेलू कमरिया 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 करेला पालप लॉलीपॉप लागेलू
साचो
Come on, you guys ready for the Fin Synergy?
Just come outside for the night. Take your time, get your life. Dirty thing,
ऐसे नहीं पंजाबी गाना मतलब सभी के हाथ ऊपर
रोक न पावा अखियां विचों गम दियां बरसातां नू आरे गिन गिन याद च देनी मैं तां जागा रातां नू रोक न पावा अखियां विचों
come on, you guys sing this one. One, two, three, let's go. Everybody hands up. Akon, you guys ready for the next track? Get your hands up. Everybody hands up. 1, 2, 3, let's go. Come on, एक बार सभी के दोनों हाथ ऊपर हो जाए. Come on, all the hands, all the hands. कौन है हमारा देश के लिए, for our country. कौन है the first line all right now.
कोई नहीं है, बस नहीं सौ दिन दुनिया घुमा है, नहीं कहे तेरे जैसा कोई नहीं, मैं गाया जहां भी बस तेरी याद थी, जो मेरे साथ थी, मुझको तड़पाती रुलाती, सबसे तेरी प्यार है, बस तेरा प्यार ही
You guys sing this one. Come on, guys, how the Josh? How the Josh? You guys ready to jump? Hands up! Come on, everyone. 1, 2, everybody!
All the pretty girls out there.
के न लेंगे सारी गलतियां
अमन सारी सुंदर लड़कियां
जाना आज ना भी फिर हम मिलेंगे ना कभी कल सुबह चले जाएंगे हैं घर जहाँ कल सुबह बोले जो भी बोलेगा जहाँ तू मेरा आखिरी हो जाना आज ना भी फिर हम मिलेंगे ना कभी तू जानू वानू जो कहता है बीवी तेरी हूँ लगता है सामे मोर सामे मैं सामी सामी जो कहती हूँ मर्द मेरा तू लगता है सामे मोर सामे तेरे पीछे पीछे चलूं जैसे तेरे पीछे पीछे चलूं जैसे मंदिर की सीढ़ी पे चढ़ूं सामे तेरे बगल बैठूं ऐसे जैसे शिव के बगल गौरी मोर सामे वो टकर जहाँ तेरी नजर ले जाए रे प्रेम नगर ऐसा मैं अरे सामे आजा सामे पल में सामे पर में सामे सनम सामे अरे सामे आजा सामे पल में सामे पर में सामे सनम सामे
कौन सारे संभव डू लबास check
जरा जरा औरता माखी जाऊ छगुरी केन के बुली
check
स्टाइल मारू
check
ए ननी तमे कित्ते धनो स्टाइल मारू
let me see you jump
हल जरा दे हट के गरी मुंह के तमे सजे गरी कित्ते धनो स्टाइल मारू छ ए ननी तमे कित्ते धनो स्टाइल मारू छ आखी थी तो गजल माखी तिरछी नजर तमे मारी तिला के तमे घायल करू छ ए ननी तमे ई पिला के घायल करू छ हे तोर चाहनी लुबलुवानी सबे कसन बढ़िया झूमे देला मोर मन के संबलपुरी गुरिया
मलमलिया रास्ते पिला दिल के संगे घायल कला नहीं देखा ना प्रेम लीला मोया नमी भोली भाली
1 2 3 let's go come on you guys sing this one
दिन का थारे तते नहीं देखले मन नहीं तोर चेहरा खाली खाली
1 2 3 let's go
महीना तते देखला दिन उड़ी गला चेना एते सुंदरी किंता लू जाने जाना मते पागल कलू रसी देलू जानी जानी करी फसी देलू हाय
कौन सारी सुंदर लड़कियों के लिए ये गाना
हेली मुई भमरा देखी तोर चेहरा बरसा रानिया ओ तुई मुई तोर बादल राजा खुशा बांध
कौन सारे एक साथ
लोगामी तोते बोल पाएमी बजा में प्रेम रो बाजा भोरे तुई मोर बहाना पुली संगे चल पलामा हाथ धरी कर देखे ते मां संगे मिसी दे दुल्हन बनामी तोते हुई दो दिल थी बसामी तोते हुई लो दुल्हन बनामी तोते हुई लो दिल थी बसामी तोते हुई लो
लाजकुरी लातामू लाजे लाजे हंसी देला
Now you guys sing this one.
दिल घायला हैला तुर चाकी चाहानी मोते पसे देला रे मोर डार्लिंग 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 मोर डार्लिंग देखे मुल सोचे तुर हीरो के देख यारे नाचुचे मोर डार्लिंग देखे लाजे लाजे होचे तुर हीरो के देख चुमुक चाली तो धक धक हेला दिलटा मोर झुमेला तोर प्रेम निशा मोर डार्लिंग मोर डार्लिंग देखे मोर हंसूचे तोर हीरो के देख यारे नाचुचे मोर डार्लिंग देखे लाजे लाजे हंसूचे तोर हीरो के देख यारे
राजा जी ए राजा जी ए राजा जी ए करे तराहल हाजरो रत मूरत खूबसूरत हो ए राजा जी ए करे तराहल हाजरो रत मूरत खूबसूरत हो ए राजा जी ए करे तराहल हाजरो छीटा जवानी के बेदा हो मना
All the Vestibular lovers tonight.
छीटा जवानी के उड़ेदा हो मना से मना के जुड़ेदा हो आज सुते तो चबारिया पानी की
टूट जाए राजा जी टूट जाए राजा जी पलंग साजवान के टूट जाए राजा जी पलंग साजवान के
अकाल मृत्यु मरता काम करता जो चंडाल का काल
All the father fans tonight.
जो महाकाल का अकाल मृत्यु
Come on, सारे के सारे हाथ ऊपर.
चंडाल का काल उसका क्या बिगाड़े भक्त जो महाकाल का अकाल मृत्यु मरता काम करता जो चंडाल का काल उसका क्या बिगाड़े भक्त जो महाकाल का अकाल मृत्यु मरता काम करता जो चंडाल का काल उसका क्या बिगाड़े भक्त जो महाकाल का
Bum bole bum bum. One, two, three, let's go! Come on, Dora.
पूरम के चांद को घूंघट के नीचे लिए दुनिया से नजरें चुरा के
पीछे कुआं आगे मेरे खाई तू ही बता जाऊं मैं कहां मुझको दुआ किसकी लगी भाई
I can't sing this one.
बता रहा हूं जो यहाँ
इल्ले फिकर आजा इधर बीट पे लगा ले तू ठुमका
One, two, get on the dance
dance floor. 1, 2, 3, 4, get on the dance floor. Booty shake, top and go hardcore. Shoulder, hit it, party, hit it, gimme, 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 gimme some more. 1, 2, 3, 4, get on the dance floor. Booty shake, top and go hardcore. Shoulder, hit it, party, hit it, gimme, 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 gimme some more.
ये हमारी एंट्री यार दिल में बजी घंटी यार टंग तुमने मारी एंट्री यार दिल में बजी घंटी यार टंग दिल की सुन कमेंट्री यार प्यार की गारंटी यार टंग पर दाड़ दाड़ी करना ना अब नहीं सुधरना टूटने लगा है चाहतों का झरना दिल की ना मरम्मत हो ना कोई वारंटी यार टंग तूने मारी एंट्री यार दिल में बची घंटी